Well, welcome. Super excited to see a full class. We capped the course at 12 people, and we've got 12 people here, so this is awesome. So thank you for being here. This is, of course, the Fundamentals of Critical Care Transport course. I think y'all know who I am. I'm Dave Tan. I'm the CMO here, and the course, probably the primary instructor for this class, and I'm the course medical director. I've run a critical care transport program, started one in 2006, I think it was, maybe 2005. So I have a lot of experience in this space. Been at Washington U and Barnes Hospital since 1997. I'm still there per diem. I do a couple, 3 shifts a month at the ER still at Barnes. Plus I got a wedding to pay for. Those are expensive. My oldest daughter just got married. And critical care is near and dear to my heart. We'll talk about why it's so fundamental to our operation here at SCCAD in a moment. But that's me. Joining me as part of the instructor cadre, I'm going to let Chief Stewart introduce himself and the next person.
Well, if you don't know me, hi, my name is Brian. I am going to be one of your adjunct instructors for this program. The last 2 programs, I was the primary instructor, and I'm happy that Dr. Tan is here, and he's going to give us a much better educational experience. We did pretty good our last 2 classes, but I know Dr. Tan's going to do awesome, so excited about that. I'm also your course coordinator, so that means we're going to get more detail about it when we break down the manual, about what that means, about your responsibilities for this class go. So we'll talk about that in a few minutes, but I'll hand it over to Nate.
My name is Nate Bauer. I am one of the freshly minted single resource critical care medics. I was also the co-instructor with Brian. I'll also be doing some instruction for you throughout this course. And if you guys don't have my phone number, or if I haven't given you guys your Google Classroom link or anything like that, let me know. I just said I'll do my best to make myself available for anything you guys might need throughout the course.
And our contact information and numbers and all that will be on the slide at the end of the course when we give you some resources for being successful in this course. Every single one of you, 201, said, I'm here because I want to be better. I want to keep learning. I don't want to be stagnant. I want to advance myself. I want to make my patient care better. And that, I don't know about you, but that warms my heart.
Absolutely.
I mean, that's like wow. Because like I said, there are way easier ways to get CEUs, but this class is motivated, I think, to be here and really learn and be better. And that excites me because I think we're going to have a very fun semester if that's the case. So you're here to learn, you're here to better yourself, you're here to make patient care better. And that is really, really exciting, so awesome. And we also have a wide breadth of experience, from 6 months of experience practically to 3.5 decades or almost. So that's awesome, that's awesome. Thank you very much. I'll tell you what our why is. We wanted to do this because we also want to improve patient outcomes. That's big for us. You know, this is a lot of work to put this class on, but we know that we can improve patient outcomes with a more informed, knowledgeable workforce. We also definitely want to meet your needs. So listening to all of your needs, the common theme is to be a better clinician, and that's exactly what we want to do. And we want to raise the standard of care. Here at SCCAD, we only have a small unit of dedicated single resource critical care medics, but we have just under 100 medics here that have had critical care training and are certified. Many of them want to keep up their certification as well. And so that's why we're having these regular CEU, we call it Fun Fridays. You know, once a month on a Friday, we try to do a critical care topic that you can come to and get CEUs for and maintain that knowledge. One of the things that we believe in is that the best paramedics in the world become board certified, and this course will allow you to sit for the IBSC board certification exam. probably one of the most difficult certifying exams out there. But notice at the top right corner, our number one goal is in fact to make you better clinicians, which aligns with everything that I heard this morning from you, make you better clinicians. And we will do that. We will do more than just let you sit for the board exam, but we want to make you better clinicians. This is the textbook that will facilitate that. In front of you, the critical care transport text from AAOS is probably, there's 2 or 3 out there. I'm just glad that we have one written for paramedics, because when I first started our critical care paramedic course, you know what we had to use? Nursing textbooks, because they didn't have any paramedic textbooks. So we kind of used the nursing textbook, we kind of extrapolated stuff, and it worked okay, but it was suboptimal at best. Then Dr. Brian Bledsoe came out with probably the first critical care paramedic textbook. Unfortunately, as most of you know, publishing a book takes a lot of work to maintain, and it was never maintained or updated. So we now have the CCT text, which is pretty decent. That will help you sit for the board exam as well. You will be substantially more successful if you actually open the book and read it. Okay. I had a student once come and talk to me in the office, say, I'm just having a really hard time. I don't quite understand this. I said, that's great. Let's go over it. There's a really good diagram of this in your book. Let's take it out. Let's get your book out. He opened his book back, pulled the book out. It was still in the plastic. And I said, dude, you have not opened your book. Your chances of success are exponentially higher if you open it from the plastic and you read it. So I say that to you. This is not a course that you can. Some of you probably are used to going through a class based on the class notes, and you're fine. That will not work for this course. It will not work. You have to actually open the book and read it, because the notes that we give you in class are merely the highlighted things that you kind of have to focus on and know. But reading the text is going to be fundamental to passing this course. I cannot underscore that enough, okay? It's a lot. So some people can get overwhelmed on the first day when they see what they have to do. I say keep calm, read the syllabus. The syllabus in your packet is going to be this. It looks like this. It's basically the schedule that Chief Stewart is handing out now. The syllabus is merely, what is your homework assignment? What do I have to do to know and prepare for the next week? What are the upcoming topics? What dates do I have to get off on my calendar for exams and things like that? We are not going to read through the syllabus because you all are adults and you can read it yourself. So put that in your binder. When you go home tonight, be sure you get in your iPhone or your Android or whatever and put it in your calendar. When the exams are, set reminders, blah, blah, blah. What we will stop and spend a little bit of time on, however, is the next part, this. You have to know this. And Chief Stewart is going to highlight things in your training program policies and procedures. This is the thing that you do have to really know. And he is going to walk us through some highlights. We're also not going to read through this page by page, but he is going to highlight some of the more sticky policies and procedures that you absolutely have to know. So Chief Stewart.
All right.
And I will give you this mic so that they can watch this at home with rapt attention again.
All right, let me pull it up here. Let me get out of this. There it is. Okay, so did everybody get a chance to at least browse through it? Are there any pressing questions? Or you can wait till I'm done and then we'll ask questions after that. So here's our contact information. This is on page 4. It'll have my phone number here. That's my cell. As the course coordinator, please contact me and me alone if you're going to be sick and not able to make a class. Don't contact Dr. Tan, please. Contact me, and I'll communicate with Dr. Tan your attendance. As far as attendance goes, it's okay to, well, we don't want you to miss any courses, and that's pretty obvious because Each week, you're going to get a new topic, right? And then we're going to move on from there. So we may review that information, but we certainly will not reteach it. So if you miss an entire day, you're missing chapters worth of information that you'll have to go back and view the video to catch yourself up on, and you won't have us there able to clarify or ask any questions, okay? So it's important you attend every day. However, with that being said, you can miss one day of class. You can even miss 2 days of class. We will not boot you out from 2 days if you miss 2 days. But if you miss 3 days, I don't know what else we could do for you. You'll be so far behind. If you do miss a day, obviously I will know about it. I will work with you. Nate will work with you to sit with you and discuss the day's topics and lessons. No problem. All you have to do is we'll put that burden on you to contact Nate or myself to set an appointment to be able to do that. Okay? So I won't reach out to you necessarily and say, you missed week 4, when can we sit down together to go over week 4? I'm going to rely on you guys as adults to say, this is what I've got, Brian, as a schedule. When can you meet with me to get me through this material? Okay? So that's kind of what I expect. So please call me for any of your absences that you're going to have. Also, if you're going to be tardy, if you're going to be late that morning because you're coming off duty and you're not going to be here at 9, give me a text, please, so we know at least where you are and that you are on your way. Okay? Any questions on that? All right, move right through it. Your course fee is a little higher than it was last year. That's because we're going to do the PIG lab. And so that's why the price increase, if you were aware of that. I think the only thing really that we really probably need to cover are the grades, right? How do I pass this class, Brian? That's probably going to be the most important thing, right? So in this class, we're going to have 4 major exams. Each exam is going to be worth 10% each. So that's a total of 40% of your total grade right there. There are going to be 8 quizzes. So pretty much every day you come in, except for today, you'll either have a quiz or a test. Pretty much. There'll be some weeks where you won't, because of course the week after the test, there's no quiz, because there's been no material presented. But generally, every morning you come in, the first thing you're going to do is take a quiz or walk right into your test. Okay? So there's a total of 8 quizzes, and that'll be 20% of your grade. Laboratory exams are those lab exams we're doing where we'll break you into stations and test you in a practical manner on the stuff that you learned for that test. So on test days, there are no lectures. It's a scheduled class day. It's on a Thursday. But those days you're going to come in and you're going to do the written test, which generally takes an individual 2 to 2.5 hours to do, just the written. They're very comprehensive. And then after that, after lunch, we will break you into skill stations and test you on skill stations. So it's a full day of testing. And I thought it would be not a good idea to lecture that day as well, because your brains are going to be melted. Okay, it's going to be like radioactive meltdown to get through these tests. Trust me. Okay, they're comprehensive. So we don't want to lecture those days. Okay, so it's just a testing day. It's a kind of a low-key day. And when you're done with the test, you leave for the day. So you're not required to be here till 5 p.m. on those days. So those days will be early release for those days. And then we will have homework, but we will not grade them, and they will not count towards your GPA unless you do the homework. And then what we're going to do with it is assign it as extra credit on your upcoming test. So, for example, we're going to hand out some homework for you today, and if you turn it in before the test in a month, for your first test, you'll get 1 extra percentage point on your exam, for that exam. Okay, so that's where homework is done. We'll assign it. It's optional to do. We suggest you do it. Once you do it, turn it into myself or Dr. Tan, and we will notate that for extra credit on the exam. Your final written exam is 15% of your grade, and then your final practical exam is 10% of your grade, which totals 100% of your grade. Any questions on that? Looks good? Okay. I do grade the test. It'll be mostly me grading all the tests and the exams. I'm the one that written them. We're probably going to generally use the ones we used last year, unless Dr. Tan decides he wants to change them up. I do get the grades out immediately, like that day. I'll get you your grade, if not the day after. So, and they'll be issued by email. We do have a Google Classroom, for those of you that have logged in and seen it. The Google Classroom is going to be just for communications. So generally, I'm not going to text you or email you. I'm going to send it through the Google Classroom when it comes to communications about the class. Say, for example, we have to change the syllabus. Or sometimes we may even assign homework to the Google Classroom. So just make sure you're logged in and make sure you're monitoring that. You can actually go get the Google app on your phone, and every time we send something, you get an alert. And that's what we would advise the best thing for you to do. And so you can see all the communication happens through the Google Classroom because you are responsible for that communication on that platform. Okay? But like I said, we will email you your quiz scores and your test scores. Those will come out by email to your personal email address. No one else will ever see your scores. We'll never post them on Google Classroom. Okay? What else? What else? What else? The rest of it is just legal mumbo jumbo, right? I don't think we need to go over that. Any questions on the handbook? No?
Not that I'm looking to not pass the quiz.
Uh-huh. Oh, good question. We need to talk about remediation. So whatever score you get on the quiz is what you get. If it's pass, fail, it doesn't matter. It's just a points accumulation. If you fail a test at a less, now the cutoff is 75%, folks. 75%. If you score 74, you failed the test. If you fail a test, we will give, I really haven't talked to Dr. Tan about this in detail. What I used to do is I'll give you a chance to take the same exam again. Okay, so I'll give you a day or two to study. You'll come back in, you'll take the same exam again. If you pass it greater than 75%, then you're good. And I'll remediate you as much as I'll sit with you. We'll talk about the lessons. We'll remediate. We'll get you up to speed. You'll take it again. You'll pass it. If you don't pass it the second time, then I've never had that happen, but it'll be an issue. And so we'll have to talk about, we'll sit down with Dr. Tan. You, me, Dr. Tan will sit down together and we'll figure out what we'll do from there. We won't boot you from the class so easily. So if you failed the second time, we'll come up with another way to get you through the test. May have to come up with the second test. We'll figure it out. But let me tell you, I've never had anybody fail this class. So we're going to get you through, but you are going to have to work at it. There's not going to be a free ride, but at the same time, we're here to facilitate your success. And if you're a poor test taker, do not worry. Okay, do not stress out about it. We'll get you through. If you need some kind of, accommodation to take a written test, if you can't get it done in the 2.5 hour time frame, please let us know, and we'll accommodate that as well. Okay, because you have all day. You have all 8 hours to take the tests. And that's another reason why we did it that way. So some people just take longer to take a test. That's okay. Does that answer your question? Okay. Any other questions? All right. Your last sheet on that packet is a authorization or a acceptance sheet that I want you to read and sign, because this is verifying that you have been presented the material. You have no further questions. We've answered all your questions. And you're going to abide by that manual. So if you want to sign it, I'd appreciate it. I'll collect it, and then I will witness. And I hand back to Dr. Tan. All right. Yeah, definitely be with you later, too. Thanks. All right. Thank you. Now, I haven't heard one important question yet. When's lunch and how long do we get? Isn't that an important question? Yes. All right, so what do you think, Dr. Tan? I did an hour last year for lunches. What do you think?
Yeah, we can try to give it an hour.
Yeah. Some days we did a little shorter because we were just so swamped, and some of our lecture days are going to be like that. We just got so much fucking material to present to you those days. We may break it down to 30, 45 minutes. You can leave the campus, obviously, if you want to get lunch in the hour. You can bring your lunch back, although it's okay to do that, but I think it's distracting to some people if you're scarfing your meal. So that's why we give you an hour to try to eat everything. But certainly you can drink and have snacks in here during class. That's okay. Okay?
The break area does have a refrigerator. There's a microwave. There's vending machine with sandwiches and salads even and drinks. So you can plan accordingly. I will underscore as well that You passed a couple of classes, it would be very hard to pass this course. The reason why it's being recorded is not so that you can stay home one day and just look at the recording. We do labs, we do a lot of in-person stuff. That's why you really have to be here as an in-person class. So just to kind of emphasize that again. Any further questions on the course manual handbook? Okay. You know what? You should have some expectations from us. We just talked about our expectations of you. You should have some expectations of us. You should expect the instructors to care, and we do. We are invested in your success. So to underline what Chief Stewart said, it is actually pretty difficult to fail out of this course. If that makes you feel any better, we will do everything we can to get you through and pass. So we care. You should have instructors that are knowledgeable. We will have a couple of guest instructors this semester, physicians who have subspecialty expertise in certain areas, and because we feel like we owe that to you. Your instructors should not just be people who read the chapter the night before you did. They really should be experts in their field. They should be prepared, and they should seek your success, which we absolutely do. We expect from you to be self-motivated. If you haven't gotten the sense by now that this is not the kind of course that you can kind of come to class once a week, follow along in the notes, and you're fine, let me say again, you have to be self-motivated. This is at least a 300-level college course. So, and if you don't know what I mean, 100 is like freshman level, 400 senior level. This is at least a 300-level college course. So you really, really do have to treat it as such. Which means the other 6 days that you're not here, you have to be studying. So typically in college, for every hour of lecture, it's 2 to 3 hours of homework. So arrive prepared. Use multiple strategies to understand this material. More than any other time in history, you have the world's information at your fingertips. You don't have to go to a library and find an encyclopedia or some books. You can just Google something and you instantly have information. So be discriminating about everything you see on the internet, but so use good sources of information, reputable sources of information, and of course myself, Chief Stewart, Medic Bauer, we're all here invested to help you as well discriminate between what's a reliable source and what is not. So just ask if you need any help, okay? Fair enough? Is that fair enough? Okay, good. So the plan for the rest of the day, this morning, before noon, we're gonna try and get through chapters 1, 2, 3, and 20 as just overview. Okay, so we're not going to go through any of those chapters. You should have already read those 4 chapters by now. So we're just going to hit some highlights. Then we're going to spend much more time on chapter 5, patient assessment, and really try to get through chapter 9 if we can. If we don't get through all of chapter 9, don't worry. We have some built-in time next week or week 3, I think, when I'm back to finish off chapter 9. This afternoon, Chief Stewart will take you through this chapter. Critical care pharmacology, and get you through some of the fundamentals of pharmacokinetics, pharmacodynamics, and critical care pharmacology. All right? So it's a lot of information. We're going to be moving relatively quickly. You have the course notes in front of you. Feel free to take notes. This is very informal, so if you have a question, yeah. Go ahead, Jenny.
One more quick question.
Go ahead, Jenny.
On the board certification. What is the percentage of people, would you say, that go through this course and then receive their board certification?
Aren't we at 100%?
Well,
Close
let me
to
just
it?
preface this by saying, let me ask you a question first.
Yes.
How many paramedics in the world do you think are board certified in critical care? How many?
In the world?
In the world?
Thousands.
No, give me a percentage. What percentage of paramedics are Russian?
Less than 5, probably.
Maybe.
3.2.
Yeah. So I saw a survey back in, I think 2 or 3, 4 years ago that said basically 5% of all paramedics are board certified. So this is an evolving field. You guys are, this is the tip of the spear for EMS, and this is why I'm here, this is why Dr. Candy's here. So, is it because that it's a hard board test? or is it because that it just isn't out there as much? And I think it's a little bit of both. So to answer your question, the graduation rate for this class is 100%. We'll make sure of that. But I can tell you from the last class, without saying names, we had 12 people, and 8 people are board certified. 2 people have taken the board twice and failed it, and 1 person took the board once and failed it, and 1 person hasn't tested.
Okay.
So what is that? 8 out of 12 for sure that have been successful. The class before that was even worse than that. I think it is what Dr. Tan's trying to portray to you is why are you here, right?
Yeah.
So I think if you are here for the right reasons, the information Dr. Tan's going to give you and I'm going to give you will get you ready for the boards. But don't expect to go to the boards and not be here today and every week, because you won't be successful in the boards. It's a very hard test, and our job is to get you there.
Those 4 test takers?
Huh?
I'm one of those, so that's why I keep.
Well,
making
we're
notes
gonna, all
and
as we go through the course, I'm gonna actually highlight questions that I know the right board questions, without giving you the answers, of course. And I do that to kind of get your mind spinning on different types of questions you're gonna see for the boards. So we will get you ready, not just with material-wise, but how to actually take a board exam.
Okay.
As we go through the course, we're gonna introduce these kind of questions, and we're gonna broach those kind of subjects. So it won't be till the last day of graduation, all of a sudden, go take a board, you'll be ready. You'll be
Awesome. I
ready.
appreciate it, thank
Yep.
you.
Yeah, so purely by the numbers from the last class, 8 out of 12. So 2/3 became board certified. So we will definitely be giving you prompts and prepping you for how to be a good test taker as well, or a better test taker for sure.
Wonderful, thank you.
All right, you ready? All right, Chapter 1, Intro and Overview of CCT. You know, why do we even have a critical care transport service line at SCCAD? Is it required to have one? No. So why do we do it? Because it costs a lot of money to have one, and it doesn't, it's not like we can bill more per se. Why do we do it? Probably for the same reason that you're here. You don't have to do this, but you want to do it because it's the right thing to do. It's an avenue to be better at caring for your patients. At SCCAD, the reason why we have invested so much time, energy, and money in a critical care resource is because we want to be a more reliable provider of quality service. And we want to be able to be more consistent at having a cadre of paramedics that work for us who are much more facile and comfortable at managing ventilators, blood products, et cetera. It's because it's the right thing to do for our patient. If we could make every single person here a critical care paramedic, we would do that, but we can't. So having a single resource service line is one way that we do it. And we do it because people have to get from one place to another. And so at SCCAD, we have this single resource. What it is a bridge and a seamless transition of care from one ICU to another. Now, our 9664 can, in fact, run 911 calls, and they often do for really bad 911 calls. But the vast majority of things they do are going to be because the patient is too sick for a hospital. They're too sick for this doctor and too sick for that ICU. That's how sick they are. So they have to go to another ICU. Okay? So that is where you come in. Now, when we talk about modes of transport, and your chapter talked about this, really it makes sense that if the mode of transport is going to be within about 50-mile radius, a ground ambulance transport makes sense. My dream someday is to have one of these suckers it's no longer single resource as an actual ambulance, a mobile ICU from SCCAD. That would be my ultimate goal. Once you get past 50 miles up to about 150 miles, then rotor wing probably makes more sense from a time standpoint. These are the various airframes that you should be familiar with. In the greater St. Louis area, there's a lot of BK-117s. There's a few Bell Long Rangers, the 206Ls. They're honestly better for traffic helicopters, but they're pretty cheap. And, AirVac. All of the services are always wary of the bottom line, and so they're going to run as cheaply as they can, as safely as they can. So Bells are popular. Out in California, there's a lot of Bell 412s why do you think in hot, arid climates like that, they tend to get bigger airframes? It's about physics. Is that a hint? The lift. It's the density of air, right? In the high desert of California, where it's 120 degrees, there's a lot less aerodynamic lift. So there needs to be a lot more power. So the Bell 412 is pretty popular. The 222s in Texas. Our friends an hour away from here at Mizzou use the MD-900s, the NOTAR, the no-tail rotor helicopters, but they're all pretty good airframes. Past 150 miles, you're probably going to need fixed wing. And so the King Air is a very popular airframe, very efficient, much less expensive than, say, jets are, and pretty safe. But there are CJ4s and P180s that people use for greater than 150 miles, okay? So there's chapter 1 in a very quick nutshell, okay? The rest you need to know. Yes?
A random question, the
Yeah.
ground, like this level of ground transport, critical care, how long has that been going like in the United States? Like how long have we been doing that?
That's been going on for several years. The most common start that really wasn't meant to be a general all-purpose interfacility transfer like we're talking about started with specialty teams like pediatrics especially. So like Children's Hospital and Glennon have had these interfacility, very highly niche specialty services a little longer than just the general ground transport ambulances. It's been a number of years. So like the one that I started at Abbott is almost 20 years old now, right? So, and there had been some, and 20 years ago, this is when it really kind of started to gain favor for general use, not just pediatrics, not just neonatal, but ICU to ICU, as an alternative also to flight. So a couple decades or more. Liz?
Well, I saw something, I think it was through AMS1 from South Carolina has eCPR, the ECMO buses.
We're going to talk about that.
Are you? Okay.
Yeah,
Then
so hold that thought.
Yeah.
But yes, there are very, very specific like stroke units, which has a CT scanner in it, and ECMO units, which has ECMO capability, an operating room in it. Okay. So be sure you kind of talk about certification, licensure, credential, or at least know the differences among that. That's a favorite test question, right? Who gives you your certificate? Your school? Where do you get a license? The state? Who credentials you to be a critical care medic? Yours truly, okay? Your service medical director credentials you to use your certificate and your license, okay? Your board certification is a form of certification after you get this certification, right? So like National Registry is not a license. People think National Registry is a license. It's a certificate. Your state licenses you, okay? All right, chapter 2, when you talk about medical legal issues, probably the thing that gets the attention of most paramedics is this headline. You saw very recently that Peter Kucinich from Colorado Aurora Fire is going to prison for 5 years. That's unprecedented. And I personally think that that's a really bad precedent to be setting when you're now charging paramedics criminally for things instead of civilly, okay? 2 other favorite test questions. What's a tort? You gotta know this. Not a tart, like a breakfast tart. Blueberry tart. I'm talking about a tort. A tort is a wrong that is not criminal. So a tort is typically a infringement of a right, besides contracts, but an infringement of a right leading to civil liability. A wrong against the state, meaning a wrong against, you're breaking the law. That is a criminal concept. That's criminal law. The reason why the paramedic from Colorado was sentenced criminally is because Colorado, oh my goodness, don't get me started, but they said that, and did you know that he's not even the one that pushed the med? He didn't, his thumb was not on the plunger. He was the officer in charge. I think he's a lieutenant. He was the ranking supervisor in charge. He did not touch the patient. He did not push the plunger. But because he was in charge, they said he had a responsibility to stop what was going on, and he did not. Let that sink in.
Yeah,
I'm so sorry. Okay, very quick. This is the Elijah McClain case. A patient was given a big dose of ketamine. The original reason was because he was resisting arrest. He was stopped by the police and questioned, and he was not cooperating and started resisting, and it got out of hand. Suffice to say that he got a medicine that he may or may not have needed per se, but even if he did need it, what do you do when you give a medicine like ketamine? You need to then be prepared to monitor them and manage their airway, et cetera. To make a long story short, he died in the back of the ambulance. And the testimony was such that it got him in prison, a prison sentence. Okay. So you have a lot of responsibility, not just as a critical care paramedic, but as a medic in general, all right, to know that especially as a critical care paramedic, you will have some sharp instruments and dangerous drugs. And you have got to know what your duties and responsibilities are when you're acting as a critical care paramedic. Because you're going to have instruments and drugs that the regular road paramedic does not have. So do you think that gives you an increased liability or lower liability? Way, way increased liability. Okay? So you have to be very responsible and ready to deal with whatever complications come as a result of your expanded scope of practice and your expanded formulary. Okay? Yeah.
This is the case where law enforcement was like telling medics to give ketamine when we got there?
They asked, hey, do you have that ketamine stuff? Now, why do cops ask us specifically for certain meds? Because we're victims of our own success, right? They see us managing a problem, they see us do it well, and then they remember, oh yeah, that medicine that starts with a K. I mean, how many of you have been on unconscious person calls and they say, hey, do you have that Narcan stuff? Right? Before they started carrying it themselves, right? They see the success, they see your success, and they ask for it. Does that mean that they're trying to be nefarious? No, they're trying to solve a problem as well based on limited medical knowledge. They just see unconscious person, Narcan, okay? They don't know the differential of hypoglycemia. They don't know the differential of stroke. They don't know the differential of brain bleed and heart attack. They just know that Narcan is like wakes people from the dead, okay? So they think it works on everybody. It's your job to explain the difference, okay? But no, they asked for it, okay? And that was part of the contention in the trial is, well, who's running the show, the paramedic or the cops, right? That was part of the contention of the trial. Suffice it to say, medical legal issues have gotten the attention of paramedics the world over after this case. Okay? So there are 4 parts of medical negligence that you need to know. There's duty, there is breach of duty, there is harm, and then there's causation. And all 4 things have to be in place in order for you to be found guilty of medical negligence. So what is duty? A duty to act. If you're at home and you hear a car crash in front of your house, do you have to run out there and start rendering aid? No, you don't have a duty to act. If you're on duty at base 31, do you have a duty to act? If you're toned out? Yes, you do, okay? Then, did you breach that duty? In other words, did you fail to do something that you're expected to do? Yes or no? If the answer is yes, the third thing is, well, did it cause any harm? This is the one time where no harm, no foul actually means something. If there was no harm, they can't bring negligence charges against you, right? If Tweedledee and Tweedledum dropped this guy on the stretcher, but it didn't cause any harm other than embarrassment, they can't sue them for negligence. But if he was being hauled off the soccer field because of a broken ankle, and as a result of dropping him, he now has a head bleed, is that harm? That is harm, right? Was dropping him, the 4th thing is causation. Was dropping him on his head the cause of that harm? If the answer is yes, guess what? Ding, 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 all 4 things have been reached. They can be sued for medical negligence, right? Because they had a duty to respond onto that soccer field. They breached that duty by dropping him on his head. They caused harm. Harm was caused as a direct result. See how that works? Okay. If he still had a broken ankle but no other further harm, then there's no additional harm. They can't sue him for negligence. Okay. So 4 of those things have to be, all 4, not 3 out of 4, not 2 out of 4, all 4 have to be in place for you to be found guilty of medical negligence. Okay. The anatomy of a lawsuit, this is also really good to know. What's an SME? Subject matter expert. Most malpractice lawyers think that they're doctors. A couple are actually. But most are not, they're attorneys. So they look for subject matter experts, SMEs, to read a chart and say, hey, do I have a case or not? Because they don't want to take a case they're going to lose, because most of them work on contingency, which means they only get paid if you get paid, right? Like all the commercials say, we don't get paid unless you get paid. So they don't want to take a case they're going to lose. They ask you, hey, you're a critical care paramedic, can you look at this case? And you render an opinion. Yeah, you don't have a case. Or, yeah, they done messed up, and you can go after them. So they're going to make sure that your documentation is read by an SME that will likely exonerate you. Okay, you don't want to be sloppy in your documentation. You want to write it so that an SME reading this 6 months later says, "Oh yeah, Liz, you did a great job. Adam, you did a great job. No problems here." Okay, that's how you want to write it. Specific items to carefully consider: consent and refusals. Okay, so consent is. Does the patient know the risks and benefits of transport? Does the patient know the risk and benefits of whatever procedure you're going to do if they can give consent? Did a conversation take place? That's probably one of the most important things for them to know or to say is, yes, the paramedic gave me informed consent. They told me what was going on. The procedure they were going to do is a central line. The procedure they were going to do is a chest tube. The procedure they were going to do is intubation. And I understood that, okay, if they can give consent. How about refusals? Refusals are among the most dangerous things that we do. What percentage of calls for service at most ambulance services end up in a refusal? Anyone know? 5%, 50%, 20%? Any guesses? About what percent are non-transport refusals? Less than 5%? Okay. Any other guesses? 25%? 10%? 12? Any this side of the room? 15?
I know, I was gonna say, Price is Right.
Yeah, Price is Right rules. Price is Right rules.
35.
35%?
I'm going 30.
30%? Oh. By Price is Right rules, you lost by just 2%. It's about 30%, about a third. That's a lot, right? When I first realized that as a medical director, that was a pucker factor moment, right? Because, man, really? A third of our calls are refusals? Now, I've been on enough calls to know that there are some that are legitimate refusals. There are others where the medic didn't do so good a job at explaining what the risk and benefits were. You know what I mean? You have a lot of influence on the scene of a call. You really do. So you have to be careful what you say or how you say it. All right? Because there are a lot of patients that need to go to a hospital. And the really good paramedics, I have watched them smooth talk their way into the patient getting in the truck, because they know that they're having a heart attack or they're probably having a stroke. And they have a good connection with the patient, and they can give them the risks and benefits of going to the hospital or not going to the hospital. There are some medics, I hate to say that sometimes they spend more time trying to talk them out of it and get a refusal, right? And that's terrible. I personally despise those. Those are terrible, okay? Number one, it's not good for our patients. Number two, it puts you and the district at a great amount of liability. It puts me at great liability, right? Because I'm responsible for the actions of the paramedics to a certain degree. So refusals have to be based on their ability to consent and understand what's going on, the severity of their condition. I've also been on plenty of calls where the refusal is absolutely warranted, right? It's a minor fender bender, a little aches and pains, but no mechanism of trauma, no obvious external trauma. Their vitals are fine, everything's fine. They can refuse, and we don't have any heartburn over that. That's great. Okay, that's a great refusal. So just be very cognizant of consent and refusals. Your book has a nice little discussion on that. Be sure to go over it, okay? You should know these 3 things, EMTALA, HIPAA, and COBRA, because especially to a critical care paramedic, these 3 things really apply to you more than, I mean, it applies to regular ground ambulance services too, but especially to a critical care paramedic. So what is EMTALA? EMTALA stands for the Emergency Medical Treatment and Labor Act. EMTALA requires hospitals to treat, stabilize, and transfer regardless of the ability to pay. The reason why this law was enacted is because more unscrupulous hospitals used to do a wallet biopsy before they rendered care to anybody. Like, if you don't have the money, we don't care for you. We can ship you off to the county hospital someplace else, and they're not stabilizing the patient. Okay, that should never have happened. But it takes just one person to ruin it for everybody, right? So the government stepped in and created EMTALA, which had a lot of unintended consequences to it. What EMTALA requires is an MSc, a medical screening exam, and it is invoked within 250 yards of a hospital. This means that this came from an actual case where somebody was having a medical emergency across the street from a hospital. The hospital knew it, but they said, well, they're not on our property, so we don't have to go out and get them. And the patient died, I believe. And that's when they said, oh, yes, you do. Within 250 yards of a hospital, you have to care for that person, okay? Which creates a whole different set of circumstances. But once they arrive to the hospital, they have to then do a medical screening exam. So they have to stabilize them as well. This is where you come in, because you are called to Acme General Hospital, and they need to transfer this really sick patient down the street to another hospital, and they're having leaking AAA, and their pressure is 70, and their heart rate is 130, and they don't look so good. They're kind of gray. They're kind of the color of the carpet, you know, kind of grayish blue. And they say, okay, you can go now and take them. They have a 20-gauge IV in. They've had 500 cc's of crystalloid. They have no blood hanging. Is that patient stable? No. Okay. Could you be guilty of an EMTALA violation if you take them into your ambulance and they die en route? Nod your head yes. Okay, nod your head yes. This is why you as a critical care paramedic have to know this. Because you can say, time out, doctor. Can we please put a 8 French Cordis in the femoral? Does this hospital have blood? Go get it. And of course, you're going to say this very professionally and politely. And you're going to say, may I help you start some blood? And you start the blood, you intubate them if they need to be intubated, you stabilize them, then you say, let's get in the truck. Okay. So you can, in fact, be guilty of an EMTALA violation. Now, will the lawyers go after the bigger pockets and sue the hospital before they sue you? Yes, they absolutely will, because it's the hospital has to stabilize them, okay? But we have to make sure that EMTALA has been met as well. So you're kind of that last line of defense, right? You are that patient advocate that can say, hospital, you've got to stabilize this patient before we go. We cannot take this patient. Yes, yet. Okay. Now, if the hospital has done everything they can in their power to stabilize this patient, and what they need is a cardiothoracic surgeon, and you're the only entity that can get them there, then should you go? Yes, then you can make an argument that we stabilize them as much as we can. They need hot lights and cold steel, and I'm the only one that can get them there.
Risk versus benefit.
That's where the risk, exactly. That's where the risk versus benefit. Now you can, with a straight and clear conscience, sit in deposition and say, we did everything we could for them. I did everything I could for them as a critical care paramedic. The hospital did. They needed to get to the OR yesterday, and we need to go. That's why we went. Yeah. But in that first scenario, right, where they got a 20 gauge in with no blood hanging, right? Like I'm going through the extremes to let you see. That's no bueno. Okay. So, but yes, in that scenario, you can say the benefit of just going now outweighs the risk. Well, we've done everything we can. Okay. That's the decisions that you have to help make. Okay. It applies to ambulances that are hospital owned and operated as well. It does not apply to air ambulances that use a hospital helipad. So this used to be a big thing, especially in rural areas. What if Aerovac lands at a hospital to pick up your patient from a wreck down the road, but they're not ever going in the hospital? Is the hospital on the hook? No. If they use the hospital helipad as a rendezvous point, that doesn't trigger EMTALA for the hospital. Okay? That basically is just you. Okay? Under EMTALA, you have to verify that the receiving facility has accepted the patient, and it can be done under the circumstances. That they have been stabilized, you have the equipment, the personnel, the equipment, the chart's intact, everything. You can't just go, okay? There was a crew some years ago that arrived at a hospital with their transfer, and the hospital said, what transfer? Where's the paperwork? Like, where's the transfer paperwork? The patient was too unstable for us. They didn't give it to us. They just said that you accepted it. We never accepted this patient. Okay, that was a hot mess. Okay? So make sure that you meet those criteria. What is HIPAA? HIPAA is also probably one of the most misunderstood laws in EMS. HIPAA is the Health Insurance Portability and Accountability Act. The HITECH Act is also mentioned in your book. The HITECH Act simply updated HIPAA to include electronic patient care records. Because when HIPAA was first written, there were no electronic patient care records, all paper. So when electronic patient care records came on board, the HIPAA people were like, well, this is electronic, so the HITECH Act just updated it to say, and electronic paperwork. That's all it did, okay? So it only pertains to covered entities. There are only 3 covered entities. And I have this fight with my police department all the time. I'm also the medical director for St. Charles County Police, and they say, well, we have to maintain HIPAA for these Narcans. I said, you don't. You are not a healthcare provider. You're a police department. You are not a healthcare plan like an MCO. You're not an insurance company. You are not a clearinghouse for medical information. You are a police department. You are not a covered entity. But I stopped arguing with the lawyers because they said, no, we still want to follow HIPAA. I said, okay, you want to follow HIPAA. That's different from you are a covered entity. You understand? So there's only 3. Is SCCAD a covered entity? Absolutely, we are a covered entity, okay? We are healthcare clinicians, okay? We don't make widgets here, we practice medicine. So we are absolutely a covered entity, okay? So we cannot simply publish a list of all the Narcan overdoses we ran on our website. The police department could, but we can't, okay? So protected health information is any information generated by a covered entity. Any information, a patient's address, their date of birth, their name, their medical condition, that's all PHI. Okay? So understand that HIPAA applies to us and all the PHI associated with a call. So basically anything that we do in a call is PHI. Jen?
Real quick on the previous slide, Dr. Tam.
Mm-hmm.
So when it says applies to ambulances that are hospital-owned, so what does that mean? What does that say about that?
Oh, it also applies to ambulances that are hospital-owned, meaning like Christian Hospital EMS is an ambulance service that is hospital-owned and operated that also responds to 911 calls. If it were...
So it applies to us and hospital?
Yes. Yeah. In other words, what it's trying to say is that the hospital-owned ambulance is kind of an extension of the hospital, although they clarified to say that a hospital-owned ambulance, if a patient gets on the ambulance more than 250 yards away, it does not then trigger EMTALA for the hospital because Christian Hospital doesn't always transport the Christian. Christian Hospital can transport to DePaul or Barnes or wherever, Glennon, right? So Christian was like, well, wait a minute. The patient is in the back of our ambulance, that triggers EMTALA. You have to bring the Christian so we could do a medical screening exam. So they had to clarify that. That's why that's in there. Mhm.
But what about us in the sense of we drive to a wrong hospital? Like,
We go to a wrong hospital?
Instead of going to St. Joe's West, we go to St. Joe's, St. Charles, and the patient's like, I don't want to be here.
Oh,
We're not covered, we're not under EMTALA in that sense of,
yeah,
made a mistake,
I
we
think
tried.
that becomes, I think that just becomes an error. I would think.
Because I think
That's a
some
really good
people might-
question.
Might think if you show up on the property of a hospital, you have to go inside.
Oh,
From us.
oh, yes. So yes, actually, if the minute your front tire hits the property of the wrong hospital, that hospital still has to do because if they have an emergency medical condition, they have to screen them. Yeah.
I always have this question. So, guy walks into Barnes St. Peter's, gets checked in. He's like, damn, the waiting room's too long. He calls 911 to go to a different hospital.
Mm-hmm.
If he's not evaluated yet, like in triage, is that still an EMTALA violation to take him off the property? Or is he?
It
It's
is.
happened a bunch of times, so.
Yeah, this actually happens. This happens at St. Mary's too, in the city. They're standing on the sidewalk of St. Mary's. Says, I want to go to Barnes now. Well, I can't remember how we handled that. I think we just took them.
I've
Because-
had that happen at Barnes a bunch of times.
yeah, that also happens at Barnes. I want to go to St.
Yeah,
Mary's.
but I would always say no. Like,
Yeah, so technically they do have to be screened and given an MSC because they're on hospital property. Now the hospital is going to say, well, they never presented themselves to triage. We didn't even know he was here. If we know that the patient is here, like patients are walking on the sidewalk past Barnes all the time, right? Can Barnes be held liable if they trip and fall and sprain their ankle and they limp home? No, they can't be, right? Because they didn't know that they had presented to the hospital. So I think the reason why we just took them is because if they never had a wristband on or they had never presented to the hospital, then they just took them because they were on a public sidewalk even though it was next to the hospital.
Right, I've had ones where like they literally checked in, they've been triaged, and then they saw the
Now-
waiting room, and then they're like,
Yeah.
oh, hell
I guess
no.
if
They
they've
go
been
out
So,
there,
but that's the thing. If they've been triaged, and if they actually do have a wristband on, and they have not been taken immediately back, and they have been deemed to be stable for the waiting room, remember the MSC doesn't say they have to be diagnosed. The MSC is only they have to be screened, that there's no knife sticking out of their head, that they're not having a active STEMI, that they're not actively bleeding, they're not actively in labor. Remember the EMTALA, Emergency Medical Treatment and Labor Act, because this happened a lot to women in labor. Like they were in labor, but they had no insurance. They would jettison them over to the county hospital and a bad outcome happened, right? If you're actively in labor, you can't just jettison someone, you have to stabilize them. That's really where this all started. So if they have been triaged, to your point, and they're stable, they've been seen, they have had vitals taken, okay, wait in the waiting room, there's no emergent medical condition now. You can say they've been screened.
I mean, things fall through the triage all the time.
It does. But again, MSC doesn't mean they have to have a diagnosis. They just have to be screened for an emergency medical condition.
So does active labor constitute unstable?
Active yeah.
labor from one hospital to the next?
As a transfer?
Yes.
Well, yeah, but they've been stabilized, meaning, yes, they're in active labor, but the contractions are 30 minutes apart and they're gravida 1. They've got hours before they're fine. They can get to the other hospital, that's okay. Versus water's broke, they're crowning, this baby's coming out.
Yeah, that's
Well, you can't go to the other hospital, okay, which they used to do sometimes,
I've done that last year.
which was terrible.
Mucus plug broke and
fraction 2 minutes apart, and they're like, "We're St. Mary's."
Yeah. Now, if it's a services that they don't have, and they think you've got 5 minutes to get over to St. Mary's, and they're not going to deliver, well, then that's okay too. They've been stabilized. Great questions. Yes, yes. Because, for example, SLU does not have high-risk OB. They go to St. Mary's. So there's a lot of transfers from SLU to St. Mary's because that's where the maternal fetal medicine specialists are. And so they stabilize them there, and then they send them over there. So great questions. Does that help?
Yes, thank you
Okay,
so much.
good. The last one is COBRA, the Consolidated Omnibus Budget Reconciliation Act. The short story is this. If you lose your health, if you lose your job, for example, you have the right to maintain some health benefits for up to 36 months under certain circumstances, so you're not just left out in the cold, okay? So when you're ready to retire from Abbott or from SCCAD or from MedStar, wherever, they should be offering you, hey, do you want COBRA? That just means you can pay into it for up to 36 months. You'll stay on our health plan, but the problem is those premiums are a lot higher typically. Okay? But at least you're not uncovered. Okay? That's what COBRA is. Okay? So EMTALA, HIPAA, COBRA, just have a working knowledge of that. We mentioned documentation. This is really important because your book does have an error in it. Your book has this slide which talks about documentation of competence, and this is incorrect. So it's in your notes. Take note. What should that slide say? Capacity. Documentation of capacity. The word competence is a legal term. Only a judge can declare someone competent or incompetent. We, as medical professionals, determine capacity, medical decision-making capacity. Okay? There is a difference. Capacity versus competence. So, can someone understand the risk and benefits of a bad medical decision and be deemed incompetent by a judge? Sure. Okay? In other words, how do you know that someone has been deemed incompetent in any way, shape, or form? If they have a what? Almost. It's the other one. A legal guardian. Yes, I know what you're trying to say. If they have a legal guardian. Okay? Now, you'll get some of these transfers where the patient is wide awake, they're fully alert, they know exactly what's going on, and they say, I don't want to be transferred to this other hospital. And then a family member stands up and says, I'm the power of attorney. They're going to get on your stretcher and go. Do you listen to them? No, because when does a power of attorney's power kick in? When they are no longer able to make decisions for themselves. That's a durable power of attorney for healthcare decisions or just a general POA. Okay? Now, it is possible to have a POA just for finances only, or a POA just for healthcare decisions, or a POA just for childcare decisions, right? Most people just have a general power of attorney. But if they have a POA for just this specific thing, that's different from a general power of attorney for healthcare. Okay? But yes, you can't just say, okay, well, your POA says you have to go. And that's not how it works. If the nursing staff walks in and says, the legal guardian says that they have to go and they have the legal guardian paperwork and they are wards of the state, assign the legal guardian, guess what? It doesn't matter how awake and alert they have to go, okay, because they don't have the right to refuse. Okay? Yes?
So back to POA. POA is only active when that patient cannot make their own decisions.
Right.
So I'm assuming that relates to capacity. Now, typically, most people use 804 for capacity because it's a lot more to it than just 804.
Right.
So could that be like, say the patient is under the influence of a suspected intoxicant,
Right.
like E2OH, could that power of attorney still be applicable for that, or is it, do you know what I'm trying to say?
Yeah, I know. So if they lack capacity, they lack capacity to make decisions.
Okay,
Yes, then I would say if you have a valid POA present who can help make those decisions, that's when it would kick in.
okay,
Because they no longer have the capacity to make the decision.
okay. So
Okay.
it's just capacity.
It's medical decision-making capacity that you're really, really focusing in on. And I'm glad you said that capacity is way more than ANL times 4, because it is, right? Capacity is more than just, do they know where they are? Do they know the time and date? We've all known people who have been intoxicated who can tell you the date and where they are and where their name is. But if they walked into a bank, the bank would never let them sign a promissory note in that intoxicated state, right? Or a tattoo shop, right? Hopefully the more ethical tattoo shops will say, we're not going to tattoo this until you're sober, right? I mean, so why would that be any different for your refusal form, right? Your refusal form is a legal document as well, just like a promissory note is. Okay? So, but if a judge says they are not competent and they have a legal guardian, then you kind of have to do what the legal guardian says. Okay? They have to give at least consent to refuse or transport. Make sense? Okay. So that's probably one of the biggest things that gets people in trouble is not understanding the difference between capacity and competence. Okay. Other related entities to know real quick, CAMES and ARMS. I don't know why they pronounce it CAMES, but because it's spelled CAMPS. But CAMES is the Commission on Accreditation of Medical Transport Systems. This is what most helicopter services are accredited by. It's an independent nonprofit that audits accredits fixed wing, rotary wing, even surface fleets to a worldwide set of industry established criteria. It consists of 22 other organizations. These are some of the organizations that belong to CAMES. Surprisingly, including the United States Transportation Command, which is the military branch that governs the movement of all assets around the world. You know where they're located? Right across the river in Scott Air Force Base, basically in our backyard. It's pretty cool. Our AMRS is the Air Medical Resource Management. They recommend any police, fire, EMS agency conducting air medical transport should incorporate AMRS into training. AMRS, the one that we use probably the most is Airline Resource Management System, or ARMS. It is a commercial product that makes compliance with AMRS very easy. And that's where most people get their AMRS through. Okay? Just be aware of it anyway. So that's chapter 2. Be sure to review the chapter more on EMTALA, HIPAA, and COBRA, and some documentation pearls, okay, which you should have already read before coming here today. Chapter 3, patient safety. You doing okay? Keep slogging? All right, patient safety. Patient safety is probably one of the most important things that we'll talk about in critical care, in that it is a combination of philosophy, discipline, it's an attribute, it's kind of a mix of all three. And man, there's a lot of opportunity for patient safety principles when you're a critical care paramedic. You've all heard this one before, right? Primum non nocere. What does that mean? First, do no harm. It is the first rule of medicine. And when we talk about safety, we can't help but talk about a culture of safety in medicine. It is locally fostered and managed. We acknowledge that error is inevitable. In other words, it's a fool's errand to try to stop mistakes. We know that mistakes will happen. We're human. The goal is to create systems that will trap that mistake from hitting a patient. Okay? Putting systems in place as much as we can so that when you do make a mistake, you are not going to harm the patient as a result. We also want to make error reporting easy and blame-free. The reason why people don't report mistakes and therefore we can't learn from them is because they're afraid of getting in trouble. And so When we talk about that, we talk about something called just culture. Have you heard of that before? Okay. SCCAD is very much a just culture organization. Now, the biggest myth to bust right now is what just culture is not. Just culture is not a way to never get in trouble. That's what it is not. Okay? Very recently, at another agency, not here, because I'm friends with that medical director, he told me about a case that he's working on right now. And at the end, the medic had to do some remedial work after following the just culture algorithm. Okay? And he said, wait a minute, I thought just culture meant I can't get in trouble. That's not what it means. Okay? It means that we're not going to cast blame. We are going to look for system problems that contributed to the error. Okay? There are 3 outcomes of a just culture process. So let's make this really mean something. You're a critical care paramedic in the back of a helicopter or the back of our ambulance with 9664. You are 9664. And somehow you push the wrong dose of a pressor. Okay? Regardless of whether the patient was harmed or not, a mistake happened, right? The patient got the wrong dose of a medicine. We will put that through the just culture algorithm, and one of 3 outcomes will come. We will either find that the mistake was a result of our current system design, our current behavioral causes and culture maybe. Maybe our training was actually really bad. The procedure was very unclear. Maybe the design of the ambulance, the environment, something that SCCAD could have affected to not allow that mistake happened. Guess what? Not only do you not get in trouble, you get consoled. Poor medic. Poor medic, I'm so sorry you made the mistake. That's my bad. Okay? You get consoled. Okay? But if we find that that dose error was because, well, you made a choice. You made a choice that was risky, that you thought was insignificant risk or a justified risk. You said, you know what, normally I would do a medication administration cross-check. But it just so happened that the patient was crashing and needed it immediately. The partner that normally would do the medication administration cross-check with me was busy putting out a fire in the back of the ambulance. We were on fire and a tornado was coming. Okay? Well then, we'll coach you. You know, we'll say, hey, well, okay, well, maybe we can put a fire extinguisher in the back of the ambulance, make that better, but maybe there's some other things that you could have done. Remove incentives for at-risk behaviors, create incentives for healthy behaviors, increase your situational awareness. Well, hey, you know, the tornado sirens went off 20 minutes before, maybe you could have gotten to shelter. Little things like, we coach you. You're still not in trouble though, notice. You're not being disciplined, but you're being coached. Hey, here's some things that you can do better for the next time. Okay? However, if it comes that it was reckless behavior, you made an unjustifiable, conscious disregard for existing policy and procedure, okay? Then that's where some punishment comes in, okay? But that's the last resort, okay? That's not the first thing we think of. I remember a time when if a paramedic made a mistake, the first thing we did was name, blame, and train. Name that medic, blame him, and train him, right? Regardless of the cause, okay? That's terrible, right? But console, coach, and punish, that's what just culture is all about. And that's what we're trying to do here as well. If you make a mistake, we want it to be risk-free, blame-free. We're going to look at the sum totality of the circumstances. What were the events and circumstances leading up to the mistake, and then go through that algorithm.
Can I add some
Yeah.
stuff to this? So, the 3 years that I was the executive, we used just culture a handful of times. And for all the SCCAD management here, especially the new ones, I'm telling you, the administration lives by that algorithm. They're not just gonna, for any mistake, whether you back up and hit something or make a med error or something, they're gonna live and die by that.
There's actually a worksheet.
There is.
There's a worksheet. We write what happened. We sit down with the medic that made the mistake, and together we go through the algorithm. By the time you get to the end, the medic and you are on the same page. Yep, it's coaching.
It's in our contract, so
Yeah.
it's very important that we have that in the contract, and the administration, like I said, lives and dies by it, so don't be afraid to make a mistake. I've been on the other end of it, where call review, we made a mistake, we didn't go through the entire just culture algorithm, but it ended into that human error console kind of stuff, so don't be
This one?
afraid
Yeah.
to make a mistake. Like, don't, if you're worried about doing a procedure that you think you're not good at, just know that training is coming your way if you need it. So just don't be afraid to speak up. You're not going to get in trouble. Obviously, if you do something where you purposely do something wrong, then yeah, you're going to get in trouble, but you're not going to be in trouble if you just make an honest, simple mistake.
And I swear I did not pay him to say that.
Every time this subject comes up, I tell everybody, because I feel like over the last 10 years that I've been here, there's been a lot of people that have just been nervous to do certain things, and hiding stuff is way worse than just coming out.
It sure is. That's worse.
Yeah.
And honestly, just culture makes it easier for me because it takes any subjectivity out of it. You know, you just follow the algorithm with the piece of paper in front of you and just go through it. And you come down to the end and it's either console, coach, or punish. It's actually very simple. Just so you know the context, Just Culture certification is a 3-day course. It's 24 hours. It's a 3-day course. It's longer than ACLS and PALS, okay, to be certified in Just Culture. So we're basically synthesizing it in 5 minutes here, okay? So, but there's a lot that goes into it, so trust it, okay? Medical errors in critical care paramedicine, you're gonna have a lot of look-alike, sound-alike medications, okay? Like dopamine, dobutamine, you're gonna have Demerol, Dilaudid, when we used to have Demerol, things like that, look-alike, sound-alike medicines. That's why there's a lot of tall man lettering. Have you noticed that? Like if you look at a hospital formulary, it says dopamine, it'll be small d and then B, capital O-P-A, and then to emphasize, hey, read this. This is dopamine, not dobutamine, okay? So tall man lettering is a way to get around that error. Near miss, you might see this on a test question. Near miss, the biggest misunderstanding is that a near miss is a mistake that almost happened. A near miss is a mistake that did happen, but it did not cause patient harm. Okay, you see the difference? You gave Lasix when you meant to give fentanyl. So the patient just peed a little more. No harm, right? But a mistake did happen, okay? Versus you gave etomidate, but you meant to give Lasix. Oops. You're gonna have to explain why your patient's unconscious all of a sudden, okay? So yes, a mistake happened. If you manage it well, there still may have not been any harm, okay? But still, you don't wanna do that, okay? A sentinel event, this is bad. A sentinel event is when a mistake does happen, either an act of omission or commission, like you didn't do something that you should have, or you did do something that you shouldn't have. Either way, the patient unexpectedly dies or has a very bad outcome. Okay, that's a sentinel event. For those of you that will become supervisors or are supervisors, a sentinel event, the reason why you have to know what that means is that means the medical director gets notified immediately, even if it's 2 o'clock in the morning. Okay, that's a phone call immediately. An unexpected death or bad outcome from an act of omission or commission that we did. Okay. A non-sentinel event means, yes, the patient had a medical error, the patient did suffer some adverse event, some harm, but it was not life-threatening, it was not limb-threatening, it was not major. Okay, that's a non-sentinel event, and the medical director has to be notified within 24 hours. Okay. So there's near misses, non-sentinel events, sentinel events. Okay. High reliability organizations are defined as organizations that routinely do very high risk operations with zero to very little error. Okay? Little to no errors when they do routine high risk operations. Nuclear power plants are high reliability organizations. Okay? Whew, that could be a bad day. One mistake can kill millions of people, right? SWAT teams are high reliability organizations. Air traffic controllers, high reliability. Bullet train operators, high reliability organizations. I believe that 9664 and critical care service line should be considered a high reliability organization. You are routinely doing high risk transfers with sharp instruments and dangerous drugs with very little to no major errors, okay? Errors at all, actually. Aircraft carrier pilots and operators, those are HROs, okay? There are many hallmarks of an HRO. One of them is that they are obsessed with failure. That sounds weird, right? But when you think about it, HROs are obsessed with failure, meaning they what if and look for fail spots constantly. And they create their training policy and procedures around preventing such failures, okay? Another hallmark is HROs don't care about outcomes. They sure don't. They don't care if that was the best call in the world. They don't care if that was the best aircraft carrier landing they've ever seen. They still grade the pilot. They meet afterwards. They talk about it. Well, you could have been even more perfect. What could you do better, okay? Every call out, our SWAT team gets together, whether it's sometimes it's 5 minutes, sometimes it's an hour, and say, what went well, what can we do better, all right? I hope that you as a critical care paramedic, after every call, will critique it with your team, what went well, what can we do better, regardless of how good the call went, because again, you're focused on process, not focused on the outcomes. That's a high reliability organization, okay? Crew resource management is huge. It is a huge part of critical care transport. We got crew resource management. We stole it from the commercial airline industry, okay? It is not an EMS thing. However, CRM has worked so well that we have adopted it in the EMS service, we have adopted it in the fire service, not just the air industry. Does anyone know what that picture is depicting? Tenerife. Very good. Tenerife, to this day, is the single largest tragedy in commercial aviation history. Okay? It was back in the 1970s, I think, right? 1974, something like that. Tenerife is a vacation spot. So lots of airlines from lots of different countries flying into Tenerife. Pilots don't always speak English, at least not very well. And back in the 1970s, air traffic control did not have a standardized vocabulary. The reason why the Pan Am jet was struck on the runway is because the pilot of this top airplane used the word takeoff, and the air traffic control heard takeoff. Air traffic control said takeoff. The pilot heard takeoff and mistook it for an order to take off. It was a very foggy day. The visibility was very limited. And what it did was it resulted in standardization of vocabulary among air traffic control. You will never, ever hear a pilot or an air traffic controller use the word takeoff until they are actually ordered to depart from the airport. Like they'll never, what happened is they said, we are ready to go for takeoff. And when they weren't actually cleared to take off. Okay? That was one thing. The other thing was the first officer of that top plane said, I don't think he said take off like to take off. I think he said get ready for takeoff. Probably, no, he meant takeoff. Crew resource management says no matter what your rank, no matter who you are, you have a duty to speak up and question actions if you think patient harm or something wrong is being done. That's crew resource management, okay? The airline industry has been using that for decades, and it has only in the last few years really infiltrated into fire and EMS, okay? But so much so that we now have Sully Sullenberger, the pilot from The Miracle on the Hudson, on the cover of EMS World because he really espouses this for EMS as well. The fire service actually made a book called CRM for the fire service. If you've ever done a ride-along with ARCH or Aerovac, the first thing they'll tell you in the safety briefing is, yeah, you're a student and you're doing a ride-along, but you're now part of the crew. And you can abort a mission if you feel like it's unsafe. Anyone who's on the flight can say, as you're walking out to the helicopter, man, those storm clouds look horrible and I don't feel good about this. I don't think we should fly. They will stop and turn around and go back, no questions asked. Now, you might not be invited back if there was really nothing to worry about, okay? But the purpose of CRM is so that unquestionably anybody can bring up a safety concern, okay? And if anyone's not comfortable, that flight is canceled, okay? It doesn't matter if you're the paramedic in charge or not, if you're on a critical care team and somebody says, I don't think that dose is right, double check it. CRM says you stop and you verify through an app, med control, something, but you never just disregard somebody, okay? That's part of CRM. That's why you need to know it. So, Chapter 3, overview, patient safety. Lots more on patient safety. Be sure to go over your chapter on creating a culture, common errors. Also, they talk about Reason's Swiss cheese model. We just don't have time to go over that, but read Reason's Swiss cheese model. That is an amazing discussion on errors in general and how they happen, okay? Okay, our last very quick overview chapter is chapter 20, but man, we've been here for 90 minutes. So can we take 5 minutes? Can you make it 5? Okay, make it 5 minutes, come back in 5 minutes, we'll do chapter 20. Man, they're asking great questions. I don't want to stop them.
No.
You know, I want to shut them down. Let them ask questions. So we're about 25 minutes behind, huh?
We're doing good on time.
You think so? Man, I should have been in chapter 5 by now.
I probably won't need a whole 4 hours to do mine. So, I mean,
Okay.
what time do you have to get out?
I have to be at the school by 1.
By 1, okay. Okay. Well, you're getting at least an hour in with your lab lecture.
Yeah, if you're flexible, if I could go to 12:30 instead of 12. and
You go to 12:30?
No, I said if you're flexible, instead of stopping at noon, can we stop at 12:30? And then they still get an hour for lunch, 1:30, or maybe make this a half-hour day, 12:30 to 1.
If we get back from lunch at 1:30, I should have plenty of time.
Should you?
Yeah,
Okay.
yeah, we'll have
All
lunch.
right.
Yeah.
We'll see how it goes. I'll still try to get done at noon, but I might go to 12:30.
Go to 12:30.
Okay, all right.
Absolutely.
So that means we've got 2 hours. Okay. Boy, I know I'm not going to get through lab, but I'll try to get through half of it. Week 3 is when I'm back, and I can probably do it
You
then.
can finish week 3, first part of week 3.
Sounds good. Okay.
Yeah.
So I am, the thing is that I really struggle with reading and paying attention because I realize how important it is to respond.
Is it an option?
It says that there is if you have a course key or a course code.
I would get that course code.
Thank you.
Yeah, for sure.
That would be great
Yeah.
because it really helped me.
If it belongs to the authors, I haven't broke up, and my book is old, so I don't remember if
Yeah.
did it offer it?
Mine's over there, but yeah, if you
Let me
look
see. Because we did that before.
on here,
Yeah, yeah.
under essentials, it says audiobook.
Okay. I will wrote that. I haven't contacted and the company, but I will get that.
Awesome.
Yeah,
Thank you so
no doubt.
much. My brain thanks you.
You're gonna need a lot of time to listen to this book on audio. There's a lot of words in there.
Yes, for sure.
Good sleeping material.
Truth is not water.
Jesus Christ. I keep forgetting it's on wheels. Doesn't it have brakes?
No. I think one person has bought the book here, so we'll go.
Oh, okay. Thanks, see. Hello? Oh my goodness. Did you try to call me? What?
You called me earlier, right?
No, I did not. I called, you called me and I didn't answer because I'm in the middle of a lecture.
Oh, no, I just got a call from you, so I called back. Okay, everything is okay.
Okay, good.
I'm going with Tori and the two girls, and I can go to, everything is okay. I
Oh.
told the packet message, don't even go.
Okay.
Okay,
Okay, thanks, bye.
love you, bye.
Love you too. Okay. Oh, I forgot to hit pause on the video.
That's okay, he said he'll edit it out.
Okay.
His software will knock out
Sweet.
dead space.
Dead space, okay.
Yes.
Your PACE class at SLO,
Yes.
I was planning on signing up and I didn't know if this class was involved in that.
It is not related, but a lot of people are taking it.
Yes, so I'll sign up. I just remembered, because it was like around this time.
Yes, at the end of the slides for today, there's a QR code that you can scan that you can register for it if you'd like. What she's talking about is the cadaver lab that I do every year.
I saw that online.
So, yeah, August 22 or 23, I think. You just pick one of the 2 days.
Okay.
Is that only?
Thursday?
Yes, one is a Thursday, one's a Friday. The reason why we always try to do it that way is because the out-of-town people choose the Friday one, they stay the weekend. We have a lot of people from out of state that come
Is that only once a year?
once a year. So if you missed this year, we'll do it again in 25.
All right.
Okay.
Other question, the
twice, I want to say twice a year, is that right?
I'd say one plus.
One's about to start, yeah.
Yeah.
One's about to
I think
start.
it's twice a year,
Okay.
I think, at least once a year, like this one.
It's generally once,
And
except for last year, or it's usually once a year.
Oh, is it once a year? Okay.
that's like the
2 weeks.
2 weeks, yeah.
Monday through.
Monday through Friday.
Okay.
Yeah, Monday through Friday.
Is the,
Does anybody not have their textbook yet? Everybody has their
this,
textbook, right? Does anybody need a textbook?
No, the
Because I thought we had one.
live tissue lab is.
because I think,
Yeah, one's more.
I think TKRS class,
So I just want to make sure.
Are we gonna, I know
Max is out.
I got mine.
Everybody has their textbook, okay?
Does it?
Make sure.
Okay.
Our tuition.
Tuition reimbursement, yeah.
Unless you get college credit for it.
So,
Yeah,
on the
We should.
baby learning code we use, it only has the audiobook and slides. I can't like, is there any way we access the book online, you know?
I don't, I'll call them, let me call them tomorrow, and I'll give them to you guys by this week for sure. There's other options there. The slides, I want to caution you to stay away from, they're just horrible.
Yeah, the slides are like useless.
They're completely despicable, they should be embarrassed, they're bad, so just stay away from the slides. But the audio, we can get. Yeah.
No, it's general.
all right. You ready? So chapter 20 is going to be our last really quick overview, and then we're going to get chapter 5 and 9, which we're going to spend a lot more time in, okay? So chapter 20 is on infectious and communicable diseases. And wait a minute, isn't infectious and communicable disease the same thing? But they're different, huh? How are they different? This is important. An infectious disease is simply something that is caused by a pathogenic organism, but it is not always communicable, right? So that if you have, for example, malaria, is that an infectious disease? Of course it is. Is it communicable? Could someone on an airplane get malaria from you? No. It's spread by mosquitoes, okay? So it's infectious, but it's not communicable. A communicable disease is capable of being spread from one person to another. That's contagious is another term for it, okay? So TB, very contagious, very communicable. And meningitis, especially in dormitories, right? Very contagious, very communicable. Things like HIV, it is communicable from one person to another, but it's not considered contagious, right? So in other words, if you're sitting next to someone who has hepatitis A, or sitting next to someone who has HIV on an airplane, you're not going to catch it from them, okay? It can be passed from one person to another, but you'd have to be a lot closer, okay? So communicable, contagious, infectious, all related terms, but not the same by any means, okay? What's the difference between disinfectant and antiseptic? Which one is a disinfectant? Is Bactine a disinfectant or an antiseptic? It's an antiseptic. You can put it on yourself, okay? The purple tops you see at the ER, those are disinfectants. You don't want to put that on yourself, okay? All right, so use a disinfectant for the countertop, use an antiseptic for your boo-boo on your skin. Types of immunity, this is also really important to understand. There's innate immunity and there's acquired immunity. Innate immunity is what you are given in the form of your organs, your tissues, your cells. So you have innate immunity simply from your skin barrier because that keeps most bacteria and viruses out of your body, just your skin. That's innate, you were born with it, right? Your immune system. The lymphoid tissues in your tonsils, for example, helps to fend off all the stuff you're breathing and eating and stuff like that. Then there's acquired immunity. Acquired immunity is the immunity you acquire over your lifetime. And there's active and passive. So each of those active and passive subdivisions are further subdivided into natural and artificial. There are lots of ways to classify immunity types, and this is where people get confused because, well, I thought natural was this subtype. And just remember innate and acquired as your main headings, And then acquired is subdivided into active and passive, and then each of those are natural or artificial. So let's look at active. Active immunity is something you acquire from an infection or a vaccination. If it's from an infection, that's natural, right? When I was a kid, if a neighborhood kid got chicken pox, everyone sent them over to their kid's house so that they could get chicken pox. That sounds really weird. Why would they do that? Because it's better to get chicken pox when you're a little kid. Because, yeah, you feel kind of bad, but then you get ice cream and you get over it and you're fine, and then you have lifetime immunity. Adults who get chicken pox get way more sick. So when I got chicken pox, the neighborhood kids come over to my house so they could catch it when they were young, and that was really weird to do, but that's what we did back then. So that's natural active immunity. Nowadays, you have chicken pox vaccinations. You don't have to send your kid over to the kid's house. You can get chicken. That's artificially active because it is attenuated organism, pathogens, right? So it's not the actual live infection. You get artificially active immunity through a vaccine. Passive immunity, it's after you receive antibodies from someone else or somewhere else. So the natural one is like breastfeeding, breast milk. Perfect example of a natural passive immunity. It's not an active infection. It's the mother passing along antibodies. Artificially is like gamma globulins. You get an IV infusion of antibodies. That's artificial passive acquired immunity. Is that easier now? So for me, it's much easier to look at it this way. Okay? So those are types of immunity. The cycle of infection is important for you to understand because you have to understand each step in order to know where to stop the spread of infection, because you may be able to stop a portal of exit, for example, although you may not be able to control the reservoir or vice versa. Okay? So susceptible host, you have to have a pathogen. You have to have some kind of reservoir where that pathogen lives. It has to exit that reservoir. It has to be transmitted once it exits. It has to enter a susceptible host, and so forth. Okay? At any one part of that chain that's broken, you kind of break the cycle of infection. Immunodeficiencies. This is especially relevant for critical care paramedics like you who will be retrieving patients from a hospital because they already have weakened immune systems. So reverse BSI is essential. I know we talk a lot about PPE to protect ourselves, but when you're a critical care paramedic walking into an ICU, they're already pretty vulnerable. They're already very weak. So reverse BSI means what? Protecting the patient from you, right? So making sure that you don't cough on them, you don't spread your scabbed wound onto them, etc. Reverse BSI. There are a lot of risk factors for your patients. The reason why they need protection from you is because they are malnourished. They are stressed. They've been in the ICU now for a couple days or whatever. They're on chemotherapy. They have end-stage HIV. They have all kinds of other, they're a transplant patient needing to go to big barns for some reason. They're at risk from getting something from you. So make sure that you take that into consideration. Now, going back to protecting yourself is things like workplace mitigation. So one of the things that I see all the time, maybe not so much now because people are more aware of it, but medics will put on some gloves, they'll work on the patient, and they'll get, vomit and stuff all over themselves, and then they'll reach over to the cabinet, open the cabinet with the vomity gloves and pick out stuff. Oh, not that one, not that one, not that, oh, this one. Now, all those packages have vomit on it, and then they'll open the side cabinet, they'll go out the side door, they'll then get on and drive the ambulance to the hospital with the same gloves on. Don't do that, right? You gotta change your gloves a lot. I had to actually say that to a food service worker once who was making the sandwich they put the gloves on, and then they're like picking up the broom and putting it over there and then opening the thing, and then they're going to go make my sandwich. I'm like, I want to say the gloves are not there to protect you. It's to protect me from you. So can you change your glove? So do the same with yourself. Change your gloves a lot when you're doing patient care, and don't wear the same gloves for the whole entire call. No proper disinfection techniques and dwell time. What's a dwell time for a disinfectant? Yeah. So if you read that purple top label, it'll say must remain on the surface wet for at least 3 minutes. So you can't just wipe it and then put your food on it because it's not disinfected yet. You got to wipe it, let it dwell for 2 or 3 minutes, and then it's considered disinfected. Okay. So lots more information in Chapter 20 about microorganisms, pathogenicity versus virulence, various types of infections, resistance. Be sure that you go over that information in your chapter as well. Okay? Any questions on it? But those were just the quick highlights of stuff you really need to know. Anything else? All right. Okay, we took a break already. Chapter 5. Now, our first delving into much more detail is Chapter 5, Patient Assessment. Patient assessment, why are we talking about that? Because you're already paramedics, so shouldn't you know how to do a patient assessment? Well, that's why we're not going to talk about patient assessment in general. We're talking about it from the standpoint of you as a critical care paramedic. It's going to be different because your acuity is going to start off much, much higher. If you're doing an interfacility ICU to ICU transport, you're going to be starting with an ICU level patient. So they're going to be dependent on technology that's not used in the field, which means what? You have to understand that technology that's not used in the field. Okay? You're going to get report based on information from technology you don't have in the ambulance. So this is why critical care paramedics have to understand things from the hospital standpoint, because you have to manage those things. Okay? So also, your patients will very often have already received a bunch of treatment by the time you get to them. You're going to get report. I know you're used to giving report, but you're going to get report from the sending hospital. So you have to understand their language. When they talk about things like ECMO and balloon pumps and this drip and that drip, you have to understand what they mean. So there's a lot of sophisticated diagnostic laboratory and imaging tests that they're going to hand to you that you have to understand what that MRI reading is. You have to understand what that CT scan reading is. So we're going to touch on that today. You have to be familiar with a much deeper depth of assessment as well as treating patients in the critical care setting. And a lot of the information that you gather will vary greatly. So whenever possible, en route to the call, if you know you're going to an ICU to pick up a patient who has got cardiogenic shock and is on a balloon pump, you should start thinking about, okay, what do I need as far as an updated patient report? You probably need to know whether it's 1-to-1, 1-to-2 augmentation, like what is the ratio of augmentation, what drips are they on? You should be able to develop a plan for an estimated time of arrival at your destination. Because if this is a very short Barnes South to Barnes North transfer, which Abbott does all the time, it takes about 3 minutes to get from Barnes South to Barnes North. The problem is the total transport time is about half an hour because 25 minutes is waiting for the elevator. All right, so you have to be able to plan for that and say, well, I might not need to use a whole propofol drip like I'm going to Chicago, but a little bit of Versed might be all I need to get this 30-minute transport, even though it's only across the street, okay? So know your ETA. There are really 4 variables influencing your transport planning. One is like, why are they going? The type of originating facility or location within a facility, like where are you going? How long is your transport? We kind of touched on that. Even though it's across the street, will it take you 45 minutes? Maybe. You got to take that into consideration. And where is my receiving facility? Where's my destination? So understanding these variables helps you make your time frame. So that is something that most of your 911 transports, it's not a part of your consideration at all. It doesn't really have to be. But in your new world as a critical care medic, it does. So think about those things. So the remainder of your textbook in chapter 5 talks about things that I don't think I wouldn't worry so much about because you already know it. It's like, it talks about calls for service, how to get an H&P, very general paramedic level knowledge. I think they wasted a lot of time in the book talking about that stuff. You're already a paramedic, okay? So therefore, we will now stop using the publisher slides and go into our own slides, which will emphasize our own priorities in critical care transport patient assessment. I want you to review the remainder on your own, just as a review, of course, but we're going to focus on critical care stuff. This is something that I think you all learn in paramedic school, but that it really becomes reality when you are more routinely trying to intubate or manage people on vents and put people on vents. That's the Mallampati score. You familiar with this from paramedic school? Yes, okay, so this will be also pretty quick. Suffice it to say, you know that class 1 is great. If you see a class 1 view, then your direct laryngoscopic view should be glorious, right? A percent of glottic opening or POGO score of 100%, okay? But if you get down to a class 4, all you see is a soft, that's it. Your POGO score is maybe 5%, if that. Actually, a Mallampati of 4 predicts that all you'll see is the top of the epiglottis, which means you're going to have to somehow get under the epiglottis or get a bougie under the epiglottis. It's going to be a difficult airway, meaning all things being equal, if you're bagging them okay with a Mallampati of 4 by some miracle, then you should probably just stick with that, unless you're going 3 hours away someplace, which we don't do a whole lot of, okay? But if you have to intubate someone with a Mallampati of 4, then you should probably have a few backups ready, right? You should not just leave your surgical airway kit somewhere, I know it's somewhere in the bag, no. You should go find it if you can, put it on the bench seat so you know exactly where it is if you need it. That's the kind of pre-planning that it helps you to do. What are the problems with the patients on the right-hand side there, the top and bottom? Let's start with the top picture. What is that condition called, that medical condition? First of all, what's the most prominent thing you notice about that patient? There's no chin, right? Their mandible is actually very underdeveloped. Okay, there's a medical term for that. What's that? Micronathia. Micro and then Gnathia, micronathia. It is an underdeveloped mandible. Basically, it makes it pretty impossible to really engage the tongue and the vallecula with a normal laryngoscope blade. You may have to use a much smaller one, like instead of a Mac 4, which is what I typically start with most adults, you might have to try a 2 or a 1, if that. Maybe even a straight blade, just a straight blade if you had to. In other words, you're going to have to figure out a much different way to visualize the glottic opening than you would a normally developed mandible. Okay. What's the problem with the bottom patient? Cleft lip and palate. So all your landmarks are way off. And look at the significance of his teeth, right? This is where a paraglossal approach with a straight blade might be the only way you'll get to see his glottic opening. So these are the kind of things that you're going to have to think about if for whatever reason you get a patient like that. How am I going to modify my approach to direct laryngoscopy, if I even have direct laryngoscopy? Yeah.
So for the cleft palate, I always thought that was more of like an upper lip deformity.
Mm-hmm.
So
That's the cleft lip.
left cleft lip.
Mm-hmm.
Okay.
What does cleft palate mean?
That's like.
That means that deformity extends all the way back to their pharynx.
Okay.
So there's a big hole, there's a big ridge all the way through.
Okay. Because I was trying to vision, like, if you are intubating a cleft palate,
Mhm.
I mean, really, you need
It's
to-
split.
on the palate.
On the in other words, the roof of the mouth doesn't exist like it normally does.
But would that still, like, could they still have a normal mountain cutting school? I guess I'm trying to, like, visualize inside.
So some can. So if it's only a cleft lip and maybe a partial cleft palate, remember this is a type of a neural tube, a developmental embryonal defect,
Yeah.
so that there's a spectrum.
Okay.
Some are just a cleft lip only, the palate's fine. All the way to this guy, which has double cleft deformities, extending all the way back into his neck, into the pharynx. So the answer to the question is, truly, it depends.
Okay.
I've seen just simple cleft lip with have everything else is normal. And those are usually fixed in childhood because it's easy. Okay? Cleft palate is a staged surgeries where it may be more than one. But they can get them to be fairly normal as well. So the Mallampati is not always affected by cleft palate.
Okay.
Okay. I think his bigger problem is not even the Mallampati score. His is the teeth and the maxillary deformity, hyperplasia that's sticking in front of you. You would not be able to go midline like you normally would with a MAC. It would be paraglossal. You know what I mean by paraglossal? Meaning instead of putting the blade in midline, you're putting the blade in down the corner of the mouth and going to the side. Okay. Which for straight blades, that's actually a known technique for Miller users. They don't always go down the middle. They can go down the side and kind of to the, under the epiglottis and take a look. Anesthesiologists use that way a lot. You can use a paraglossal look with a straight blade after you intubate somebody too. So if you intubate somebody and you just want to do a direct visualization, you don't put the MAC back in, you take a straight blade, go paraglossal and just look and make sure that the tube is still going through the cords. Waveform capnography is still the gold standard. No matter what you think or see, you think you see it going through the cords, you think you're seeing it in. If you have a 4-phase square wave capnogram, that's money. You can be confident that you're in the lungs, you're in the trachea. We use the term capnography a lot, but capnography is actually two different things, a capnometer and a capnogram. You can have capnometers, which just tells you a number. End tidal is 40, but there's no waveform. That's a capnometer. You can also have capnograms, where there's no number, you just see the line. Okay? But when you put them two together, that's a capnograph. Okay? So capnography is what we use. You have both a numeric value of 38 or 42 or whatever, plus the tracing. In intubated patients, you do want to auscultate as well, because you may still get a 4-phase square wave on a capnogram, on capnography, right? But it doesn't detect mainstem intubation, which is why you still have to listen for lung sounds. I had someone ask me that. Well, we got a perfect square wave. Why are we still listening? Because you can still have that. Okay. What are we looking at over here? We're looking at a right mainstem. If you look real carefully, you can see that line. See that line? It might be hard to see, but that line is that radio-opaque stripe that's built into every endotracheal tube. It is made to be picked up on X-ray. So you can see that it's pointing this way. It's going in the right mainstem. And what's happening with the left lung? Why is it whited out? There's no air in it. It's totally consolidated. Okay. Remember, air on an X-ray is black. It goes right through. Okay. So your lung should be black on an X-ray. Okay. Suction devices. Really, really important. There's Ducantos, Yankauers, inlines, and whistle tips. You should know what this vocabulary means. Okay, what's a Ducanto? A Ducanto is top right picture. a large borehole. Everyone thinks that the Yankauer suction is the standard suction device. That's great at a dentist office. It is not so great in ERs or in the back of an ambulance. Okay? So notice, in fact, the Yankauer on the outside looks like a bigger suction than the Ducanto. But if you look real closely at the Yankauer tip, the hole is tiny compared to the Ducanto, which is much bigger, the diameter, which is much bigger. Here, if you look at the speed at which milliliters per second that these various tips can suction out, the Ducanto wins every time. They took water, syrup, honey, and pudding. Okay? Yeah, pudding is going to be hard no matter what you do, but the Ducanto wins every time. It gets way more fluid out per 15-second interval than any of these other ones because the diameter is so much bigger, right? Then what's a whistle tip? Well, a whistle tip looks like a whistle from the side. You see that? There's an opening at the top, and there's an opening on the side. Whistle tips are rarely used for suctioning. What are whistle tips typically seen in? Foley catheters. Foleys often have whistle tips. Okay? There's a side port, there's a main port, but you just need to know what the difference is. Okay? Then there's inline suction, which is what this is. An inline is built in typically to an airway port, like you see that on a ventilators, so that when respiratory therapy has to kind of suction them out every few hours if they have a lot of secretions, this keeps it sterile. It's contained in the sterile field. They'll go down, suction them out, pull it back. It's in line because you don't have to you're not taking the endotracheal tube out. It's in through the tube. So it's inline suction, and you can suction a lot of the bronchial secretions out that way. Okay. The Thompson tube holder is very common. That's the securing device here. You want to reassess, reassess, reassess. Can't emphasize that enough. When you are picking up a patient, every time you move the patient, every time you transfer the patient from the stretcher to the bed or the stretcher to the CT scanner or CT scanner back to the stretcher, whatever, reassess your lines, reassess your airway. Make sure you still have a nice 4-phase square wave after you move the patient. I will also say this, make sure you document this and take a snapshot so you have evidence of it when you give report to the hospital and leave. Why is that? CYA. Cover your asteroids. Okay, because there was a case years ago where the hospital tried to say that, oh, your medics, the patient coded when they got back from CT scan. I think it's because your medics actually had an unrecognized esophageal innovation. Really? Well, we transferred them at this time to the CT scanner. Here's a snapshot of our monitor after transfer to the CT scanner with a 4-phase square wave. So it was when y'all moved them from the CT to your hospital bed after we left that something must have happened because we're good, right? So make it a habit. When you transfer your critical care patient from your stretcher to the new receiving ICU bed, hit that little snapshot button on your monitor, prove that everything was hunky-dory when you left. Another set of vitals, a nice 4-phase capnogram, and you're good, okay? But if the last set of vitals and the last picture you have of your capnogram is when you're in the ER bay as you arrived 30 minutes prior, that doesn't defend you at all. That's harder to defend you, okay? So take advantage of that documentation. Pediatric patients, there's a cheat sheet that's included in your notes. Talks about estimated weight for 1 to 6-year-olds and then 7 to 10-year-olds. There's this formula you can use for 1 to 6, 2 times twice the age in years plus 8. If they're 7 to 10 years old, you can use 3 times their age in years plus 2. I gotta tell you that the hand-Tevi method, which is made by a pediatric EMS physician is really handy. The formulas are just a little bit off, but they're very close. But to me, it's the ease of use. And I don't own any stock in hand Tevi or anything. I just like it. But have you ever heard of hand Tevi? Any of you ever train on it? You have? Okay. So a couple of you have. For those of you who have not trained on it, in a nutshell, it's hand Tevi comes from his name. It's a play on words. His name is Peter Antevi. I actually know him. He's a friend of mine. Peter, his last name is Antevi, and he uses his hand, so he just said hand Tevi as a kind of a play on word. So it's 1, 3, 5, 7, 9 years of age, using integers of 10, 15, 20, 25, 30 kilograms. So if it's an 8-year-old, they're between 25 and 30 kilograms. You can use 27 kilograms if you want to. Okay? If they're a bigger 8-year-old, just use 30. And using integers of 10 again, your 1 to 1,000 epi, your 1 to 10,000 epi, for example, 0.1 versus 1, 1.5. Notice how it matches their weight. 10, 15, 20, 25, 30, well, that's 1, 1.52, 2.53 mLs of 1 to 10,000 epi for your code epi. What I like about this is you don't have to wait to measure them with a Broslow tape. The funny thing is, Dr. Broslow actually says that, yeah, that's actually an advantage of age-based, is you don't have to wait till you get on scene. If you know that, hey, you're responding on a 3-year-old child who is unresponsive, you can say, okay, then they're probably 15 kilos. My first dose of epi is going to 1.5 mLs, and their saline bolus is going to be 300 mLs. You already know that before you get to the scene. So this is something you can consider. You can find that in your notes, but you can also find this card online. It just makes it a little bit easier to prepare for a pediatric emergency. Why is it that most paramedics are not the least bit nervous going to an adult cardiac arrest, but all kinds of panicky almost going to a peds arrest? Yeah, system 1 and 2 thinking, right? Does anyone know what Liz is talking about? System 1 thinking is just kind of automatic. You do it all the time. It's very easy. System 2 thinking takes a little bit more thinking, so it takes more energy. You're more distracted because you don't do it all the time. Okay, the purpose of things like Broslow tape and Antevi is to simply cognitively offload those tasks. You don't need a cheat sheet for adult cardiac arrest because you've memorized them. They're the same. You do it all the time. But for kids, it's all based on age, size. You don't do it all the time. It's nerve-wracking. Besides the fact that it's a kid, and so emotionally it's a lot harder, you now have this cognitive burden of calculating doses for stuff. Well, this tries to make it easier. Other things that you can use, like, for example, what ET tube size should I use? Well, age in years plus 16 divided by 4 is a quick formula. What size NG? Well, tube size times 2, tube size times 3, tube size times 4 for chest tube, for example. Once you calculate the tube size, you just multiply by 2, 3, or 4 to find NG tube, the depth of the tube, and what size chest tube do I use, for example. So using that, what if I said you have a 4-year-old patient who's critical? Well, you're going to intubate them with a 5.0 ET tube. How do you know? Because they're 4 years old. So 4 plus 16 is 20 divided by 4 is 5. You see that? Now that you have the tube size, which is 5, you can say, I'm going to use an NG tube of 10 French, because that's 5 times 2. I'm going to use a tube size inserted to a depth of 15 centimeters, because that's 3 times the ET tube size. And if I have to use a chest tube, it's going to be 4 times 5, the ET tube size, which is 20. 20 French chest tube. Question?
Do we no longer do the uncut size, like 3.5?
No, we actually, the new recommendation from PALS is using cuff tubes even. If all you had was an uncuff, that's probably fine, but They're actually pushing cuff tubes now. Now, because you're critical care paramedics and you should talk the talk and walk the walk, you should know what these numbers mean. Like, what does 5.0 mean? What does French mean? I need a 5.0 ET tube. What's 5.0 referred to besides the police? Exactly, the internal diameter of the tube in millimeters. Okay. Russ has been around a long time. I expected him to know that. Okay, so 5.0 is the internal diameter of the tube in millimeters. A 5.0 tube is 5 millimeters across internally. Okay. 6.0 is 6, and so on. Okay. What is the smallest ET tube size that can be bronched? In other words, you can do your friends in the ICU a solid by not putting a tube in smaller than this, because then they can't bronch through it. What is close? 7. A 7 ET tube. If it's smaller than a 7, it's, in other words, if it's a 6, it's too small to bronch through. They'd have to replace it. I like starting with 7.5s for male and female because it's kind of in the middle, and you can bronch through it. If it's a big dude and you think this is a mom potty of 1, this would be an easy tube, put an 8.5 in, you know, or an 8, nice and big. Okay, that's great. Versus little person, if all you can get through, if they're an anaphylaxis patient, you're thinking, man, I think I'm not going to be able to get more than a 7 in this thing, then you might have to start with a 6, 6.5. Okay, depending on your clinical circumstances, right? But the size of a tube is the internal diameter in millimeters. Question?
What do you mean by bronching tube?
Good question. What do I mean by a bronchoscopy? In other words, if they're in the ICU and they need to put a camera down in the lungs and look at the lungs from the camera won't fit through a 6. A 7 or bigger, the camera can fit. So if someone needs a bronch and they have a 6.5 in, they have to call anesthesia in and do a whole production to change out the tube. So bronchoscopy is a camera through the tube into the lungs. Yeah.
As a critical care paramedic, say like hypothetically, we're transporting an anaphylaxis patient with severe airway edema, but then like the hospital treated him and it got better,
Mm-hmm.
and so they have like a 6 tube in.
Yeah.
Could we change the tube to a bigger size?
I would be very hesitant to do that
Okay.
because we don't know the degree of how much they got better. Like maybe they got better, but only by a couple millimeters. And now you take that tube out, and now you can't get it back in, and you just killed them.
Okay.
So if they have a working tube and they're going transferred to another hospital, just keep it. I would not mess with it at all. Now, if they keep having peak airway pressure problems, and they keep plugging the tube, and you're like, I think we have a 2-hour trip someplace, and we need a bigger tube. We're not getting enough flow. Peak airway pressure alarm keeps going off. I'm worried about barotrauma, all this stuff. You can have a discussion with the hospital about changing it over a bougie, right? But I wouldn't just take it out by any means. If anything, it'd be over a bougie under controlled circumstances in the hospital before you leave, if it was done at all. Yeah, good question. Any others? All right. How about 20 French? What does 20 French mean besides 20 Frenchmen rolling around Paris? 20. Yeah, this is a little bit harder, okay? 20 French is the external of the tube where 1 French is 0.33 millimeters. Okay, so a 10 French tube is 3.33 millimeters external diameter. 24 French is 8 millimeters external diameter, etc. The bigger the French, the bigger the external diameter. So 34 French is way bigger than 24 French tube. Okay? So that's what French is. Now this is where the confusion comes in because French is directly proportional. The bigger the number in French, the bigger the tube, which is opposite of gauge. The bigger the gauge, the smaller the needle. A 20 gauge is much smaller than a 14 gauge, right? It's backwards. So people get this mixed up all the time, okay? So The other problem is I can't tell you that a gauge is this many millimeters. Gauge has many different measurements depending on what you're measuring. So needle gauge is different from wire gauge. It's different from pipe gauge. There's no standardization in the industry about what gauge means. So just know that gauge is inversely proportional when it comes to needles, and French is directly proportional, okay? You hear the doctor say, I want to suture that chest tube in with a zero silk on a straight stick. What did he just say? When you learn how to suture chest tubes in, which you will in either the live tissue lab or the cadaver lab or both, you're going to want zero silk on a straight stick. What does that mean? Silk on a straight needle, okay? So 0 is the size of the thread, which is big. Okay, zero is a big size. Silk is the type of material, and stick is straight. It's not a curve. It's uncurved, okay? So 0 silk on a straight needle is what you're going to use to sew your chest tubes in. Versus 8-0, for example, when you're using 8-0 suture, that is almost smaller than a human hair. Ophthalmologists use 8-0 in the cornea. Teeny tiny, you have to wear loops to see the 8-0 suture, okay? And they're sewing sutures under magnifying loops using instruments because you can't pick it up with your fingers. It's too small to pick up with fingers. So they have to use instruments to manipulate it, okay? That's 0 silk, okay? So it's basically like shoelaces, hair, okay? So that's the various sizes that you'll be using, okay? Respiratory assessment. Rate, effort, and patterns. Why are patterns so important? You're all paramedics, you know about rate and assessment, but patterns is what you should recognize as a critical care paramedic. Patterns like Kussmaul breathing, okay? If you see somebody Kussmauling, you might even get report from the hospital and say, okay, this is a blah, 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 they've been Kussmauling all day. You better not say, what is that? Because they're going to lose all confidence in you. Okay, what? You say, oh yeah, Kussmauling, I know what that is. It's these rapid, really deep breathing, right? What? Yeah, can you maybe smell for some ketones too, right? So Kussmaul breathing, whereas this is normal type respirations, this is Kussmauling. I'm getting lightheaded now. Okay, why are they Kussmauling? Trying to blow off acids, right? They're probably pretty acidotic, okay? So there is the Kussmaul mnemonic, which I wouldn't bother to learn because you just learn mud piles, which is the anion gap metabolic acidosis, pretty much the same thing. But like ketones from DKA, uremia, sepsis, salicylate poisoning, methanol poisoning, lactic acidosis, those are all types of acid disturbance, acid-base disturbances where they're acidotic, and the body is desperately trying to normalize that pH by blowing off as much acid as possible, okay? This is why that if you do not address the underlying condition, like DKA, for example, and you just intubate them, put them on a rate of 12, tidal volume of 400, hunky-dory, everything's great, right? What did you just do? You just killed them. Because now you've taken away the compensatory mechanism. Their acid is building up by the second. And now their pH goes from what they were compensating to be about 7.1, now 6.8, 6.7, 6.6, and they die. Okay? So when you take someone's airway because they look like that or they're unable to maintain, you better dang fast understand what's causing it and address that first. Or make sure you set your vent to 30 with a much higher tidal volume, okay? Watching for all the normal things of barotrauma, but you have to address the underlying problem. So understand things like Kussmauling, okay? Palpation of the chest wall, identifying rib fractures, flail chest, sub-Q emphysema, that makes a big difference when you have them on mechanical ventilation. If you have somebody on a vent, you have got to make sure that if they've got sub-Q emphysema, what are you worried about as the reason why maybe they have to be on the vent? A pneumo, right? You have to ask yourself, how did air get under their skin on the right side? And let's say that you're a critical care paramedic on a helicopter, and the descending hospital says, ship shape, nothing else to do here, airway secured, you're ready to fly. And it's like Rice Krispies, what's the problem?
Oh, you can stand.
You're going to get at altitude and you're going to have a major problem, okay? So to stabilize that patient for transport, what would you ask the hospital to do? Could we just do this one thing before we take off? What would you ask them? Could we, well, make sure, see how bad this is, right? But what could you do to mitigate? Put a tube in. Could we please put a tube in? Could we please, maybe? Yeah, double check. Exactly, because now you're going to take away the propensity for attention pneumo at altitude and your day going really badly. Okay, so do yourself a favor, do the receiving hospital, do the patient a favor more importantly, and put the tube in, deal with it, and then go. Okay, to me, that's a form of stabilization, but you have to recognize that. So practice good cyclic care by assessing and reassessing their level of consciousness, especially if they're on a non-invasive positive pressure ventilation. Maybe they're just on BiPAP. They're not even intubated. They're on BiPAP. They're doing okay. And are you doing better, ma'am? You're doing better, sir? And they're like, and they're breathing okay. You got to reassess them, because if they decompensate en route, they might have to switch over to invasive airway management, and you may have to be a little bit more aggressive at managing flailed chest, sub-Q air, whatever else. Okay. Tidal volumes. Your book talks about ideal tidal volumes of 6 to 8 cc's per kilogram of ideal body weight. I will add that something that the book doesn't emphasize well enough is that, which I want you to know, is that the 6 to 8 does not apply if the patient has ARDS. Okay. If they have adult respiratory distress syndrome, why shouldn't we be at 6 to 8? What are you worried about? Yeah, depending on what, it could be air trapping, it could be increased pulmonary pressures, but your barotrauma is your major thing. Okay, so if they have ARDS, what you're going to be using is more 4 to 6 cc's per kilo for tidal volume. Now, there is a formula in your book for calculating ideal body weight, but my goodness, it's way easier to copy this and put this in the back of your truck, because there's no calculations. Just how tall are they, and male and female, if you want to do low end of 4 cc's per kilo, and they're 5'6", guess what? It's 59.3 is going to be your value, right? So what is your ideal body weight? It's going to be using 59 kilos, not 80 kilos or 70 kilos. Make sense? So you can use the formula if you want to, but man, this table I put in your notes, it's a little smallish, but we can get you a bigger size, and you can you just use that instead, okay? P-plat. We talk about plateau pressures. In a normal pressure time curve, when you're looking at your ventilator settings, for example, and your graph, okay, your plateau pressures ideally being less than 30 centimeters of water. Why is that also important?
Over 40 is dangerous.
Barotrauma again. And you're going to hear this theme over and over as we talk about vent management and airway management, because if anybody has to be experts at vent management, it's going to be you. And one of the most common yet most preventable injuries is barotrauma. We routinely overventilate, we routinely hyperventilate. We don't pay attention to P-plats. We don't pay attention to peak area pressures well enough, I don't think. So make sure that when you're going through your cyclic reassessments of patients, that you're paying attention to these numbers. Don't assume their body weight, don't use their actual body weight, use ideal body weight, and pay attention to your time pressure curves. Our new Hamilton vents are, I don't know if you're getting more comfortable with those. They are amazing. The graphs on there, the things you can do with them are just amazing. So take advantage of all the data you can get from them. They really are cool, okay? So PIP, or peak inspiratory pressure, is another parameter to pay attention to. Remember, PIP is your highest inhalation pressure during PCV, or pressure-controlled ventilation. Normally, it's 22 to 26 centimeters of water, with your goal being keeping it less than 35. Your maximum is going to be, peak inspiratory pressure is going to be 40 centimeters of water. The exception to this also being ARDS. Sometimes you have to exceed that just a little bit, okay? You still have to be very, very cognizant of barotrauma, but sometimes you just need a little more peak airway, peak inspiratory pressures just to get oxygen to diffuse, okay? So pay attention to those too, okay? ARDS is our exception to that little rule. That's also a number that you can very readily see on your graph on the Hamilton. You can also show, it can also show up numerically, and that's something you got to pay attention to as well.
How do you tell the difference of it? Like, how do you know a patient is an RX patient or
Well, hopefully you'll be able to get that from your report, but also their total clinical picture. If it's somebody who's intubated just because they were in cardiogenic shock and their mental status was depressed, versus someone who has COVID and their lung is completely whited out, or pneumonia, or some other drowning victim. You know, we've had a lot of swift water rescues in the region recently with all the rains. You would probably clinically be able to say this patient likely has ARDS. Chest X-ray will also tell you. Hopefully you'll have a chest X-ray to look at. Very good question. Others?
Can you just real quick talk about plateau pressure, that P5? Where visualizing what we're looking at there, just, I mean, that peak inspiratory and then right before exhalation.
Yes, right before exhalation. So remember, this is on a graph. It looks like it's a week long. We're talking milliseconds, right? It's during your inspiration. So the P-plat or peak plateau, your plateau pressures in inspiration. When you take a breath, you don't automatically go. You don't go, right? There's a little bit of a pause. It's at that pause that. Right there, that millisecond, as you're exhaling, that millisecond before you exhale, that there is a plateau of pressure before you then release that exhalation. That is all it is. The plateau pressure is how high is that pressure maintained just milliseconds before I exhale. In other words, if you think about it, it's almost like PEEP, but on the inspiration. Chief, do you have a better way of it?
No, we'll cover in detail when we get to vent.
Vent, okay.
We will. We'll cover in detail.
For sure.
Yeah.
But we say PEEP is your peak and expiratory pressure. Like at the end when you do go, and just milliseconds before you inhale, what is the pressure in your alveoli remaining? That's PEEP, right? P-plat is the same, but at the end of inspiration. Does that kind of, so when you inhale, right there, that millisecond, just before you exhale, what's my pressure? And then, right there, just before I inhale, what's my pressure? So P-plat and PEEP are the mirror images of each other, one on inspiration, one expiration. Makes that, hopefully that's a little bit better. But yeah, Chief Stewart we'll go over that way more when we go in detail about vent management. Yeah.
On some like vent transfers, sometimes the RT has minute volume or just tidal volume higher than most medics do.
Mm-hmm.
Is there any is there any reason on their end that they're thinking or they're trying to treat the patient?
That's something that you can ask when you pick them up. Say, hey, it seems like by my calculations they're at about 10 cc's per kilo for tidal volume. Did we need that for something? How did we come to that? You know. And if they say, yeah, that's because they needed more tidal volume because of this or that pathophysiology, then that's okay. Most hospitals now are getting better about reducing acute lung injury, ventilator-associated lung injury or valley from barotrauma, but not all of them are. So if there really is no reason, that's what we 10 to 12, like we used to do all the time, then you can adjust that down when you get to the truck. For sure. Okay, moving to cardiovascular assessment. You're looking at your things like skin color, temp, condition, all those usual things, your vital signs. But here, because we are typically going from one facility to another, the other reason for vital signs is that you can trend them. So if you're looking at the nursing chart as you're flipping through on your way to your destination and you're like, wow, their pressures have always been in this range, but now as we're halfway down the road, it's really starting to trend downward. That can be an early indicator of volume loss. It can be an early indicator of decompensation, even though it's still normal. Like what if we said that their systolic pressure is 115 over 80, or their BP is 115 over 70. That's great. That's normal. Well, if it was always in the 130s, but now with you is down now in the 1-teens and it's trending downward, this may be an early indicator of something going wrong. So look at trending before and after. Vital signs can also be diagnostic. It can be a threshold for intervention. Maybe the sending hospital says, I'm going to send you with this cooler full of blood. And if their heart rate exceeds 90 at any time or their blood pressure gets below 120 at any time, start this unit of blood. That's your threshold for intervention. Make sense? And you'll actually get that. You'll get patients with a GI bleed that's going to Big Barnes for something or some other hospital for an intervention because they don't have interventional gastro. They'll say, here's a cooler of blood. Bring it with you to the hospital. It's typed and crossed just for them, so no sense in us keeping it. But if you reach these parameters, go ahead and give it. There's your standing order. Okay? It can indicate stability or the lack thereof, just knowing your vital signs. Now, mean arterial pressure or MAP, the reason why we tend to like it better in critical care than just mere systolic and diastolic is it is a more physiologic representation of blood flow, right? So there are a couple of formulas that you can use to calculate the mean arterial pressure. They're up on the board for you. What is actually the easiest way to tell someone's MAP? Yes, that's what this is, okay? This person's MAP is 207. Yeah, they're well perfused. Would you say that's a problem? Yes. So you can say that the easiest way to know someone's MAP is look at the parenthetical number there. That's their MAP. Okay. But if you just want to verify, or for some reason you don't have them hooked up yet, and you're doing a manual blood pressure, you can kind of calculate their MAP. To me, calculating thirds is not possible in my head. So I'll just double the diastolic, add the systolic, and divide it by a third about. And I'll get a ballpark figure what my MAP is. Okay. So that may in fact also be a threshold for intervention if the sending hospital says, yes, this patient is going to university hospital because they have a leaking AAA, And if their MAP ever gets above 100, give them start a nitro drip or what have you, nicardipine, whatever. That is significantly higher than that, so you would want to start your drip, okay? They may say your MAP goal is this, and you're going to have to titrate your pressors or your blood or whatever else to that MAP goal. So you probably have already gotten patients where that's what the hospital said your MAP goal is, right? So that's what they mean. Okay. So just kind of, I would know one of these two formulas just so that you can check the machine sometimes. Yes?
Can I answer that, Dr. Chan?
Yeah, please.
So listen, on your board exam, you will have a question that says calculate MAP. So you will have to know one of these two formulas by heart. Where MAP matters in critical care to me is how it's measured. So in an automatic cuff, when the cuff is inflating or deflating, it's not looking for a way we auscultate, that first bump we can hear. It's actually looking for the vibration in the artery. And as soon as it detects that vibration in the artery, it reads it as the MAP there. That's an accurate representation of the MAP. The systolic and diastolic numbers are actually calculated on an automatic cuff. Those numbers you see are calculated, they're not actual. So it's the MAP, is the reason why in critical care we use that more distinctly. Now in an arterial line, it's the opposite. An arterial line is measuring direct pressure changes in the line itself. So your systolic blood pressure and diastolic pressures are actual representations of the value of the numbers. So we'll talk about more about that in shock and hemodynamics, things like that.
Mm-hmm. That's why art lines are so much more accurate, because it's an actual representation directly. So, another thing that we are really beginning to pay attention to in critical care is the shock index. How many of you have heard of that? Heard a couple of three of you? Shock index. Over the last 10 years or so, there have been a lot more studies on the utility of shock index, how to use shock index, when not to use shock index, all these things. The shock index is this: heart rate divided by your systolic blood pressure. That's all it is. Less than 0.6 ratio, not so much of a problem, okay? Mild, what they call mild shock is if it's more than 0.6 but less than 1. Okay? If you're 1 to 1.4, that's a moderate shock. Anything more than 1.4 is pretty severe and can predict the need for ICU versus surgical intervention, okay? My personal cutoff is 0.9. When I calculate a shock index more than 0.9, I tend to pay more attention to that patient because now they're flirting with 1. I don't want them to get over 1. So I don't wait till they're hitting 1. I kind of say, well, 0.9 is my threshold, my personal threshold for intervention. And so I'm going to try to determine what is the etiology of this and address it right away. Okay. But 0.9 is kind of my magic number. So this is, again, something that's really easy to calculate, heart rate over systolic blood pressure, knowing that anything around 0.9, you should at least start paying attention. So in my trauma protocols, for example, one of the differentiating things I use to say, how does a paramedic make a decision to go to the closest hospital versus go just a little bit further away to a trauma center? Because if you use shock index, actually, you can have someone who's just maybe a tiny bit tacky, not too bad, like 102 or something like that, and their blood pressure is not so bad, like 100 or something like that. And that shock index is going to be 0.9. So by the numbers, they don't look so bad, and they're like, well, you know, I think they can go to the closest hospital. My threshold is if it's 0.9 anywhere near that, you should go the 10 extra minutes it takes to get to a trauma center. Unless they're actively crashing, you just need to stabilize them someplace. So that's one thing that you can use as well. Yeah.
Is there a calculation for that for pediatric patients?
Actually, I think there is, but I don't know what it is.
I always thought they were saying that maybe.
I think the index may be the same, but the threshold for what's moderate, mild, and severe is different. But I'll have to look that up. That's a good question. Dr. Finney would be mad at me that I didn't know that answer. Okay. GI pearls, inspect the abdomen, then auscultate, then palpate. Why in that order? Why can't you listen first, and then palpate? Why is it inspect, auscultate, palpate?
You don't want to, it's a aortic dissecting, you don't want to aggravate it.
That's one thing.
If you manipulate that and then listen, you're going to create those voices.
That's the other. So I don't know if you could hear us, but he said if you start mashing on someone's belly, then listen, the things you hear may be just because you've aggravated your mashing on them. So that's right. We inspect first, like what do you see? Any obvious abnormalities, distension, rigidity? Do you see ecchymosis? Do you see bruising, etc.? Then you auscultate. You don't have to mash it in, but just like put the bell on and check, you know. And then you palpate, okay? Now, one little trick I'll do is if I'm not so sure if the pain they're having is being hysterical or if they really are in pain, what I'll say is, I'm just listening right now. I'm not gonna press or anything, and I'll press a little bit harder than I normally. I'll listen, but then I'll press, and it's like one patient I remember, I was like pressing really hard. Nope, I don't hear anything. The minute I took my stethoscope off and touched him, right? So that helps. That kind of helps a little bit determine whether or not it's really the palpation or are they just really anxious, like, oh, you know, they're going to feel something bad and I'm really anxious about it. So that's one thing that you can do. But that's why we go in that order, okay? What is Kerr's sign? Kerr's sign is pain in the left shoulder from diaphragmatic irritation, classically from blood, okay? Blood is very irritating intra-abdominally. This is why you get peritonitis when you have free fluid in the abdomen. Blood is very irritating. And so Dr. Hans Kerr from the 1800s found that people who had like subcapsular splenic hematomas and splenic rupture, splenic trauma, bleeding, if he palpated their belly and the patient had pain up in the shoulder, they probably had a ruptured spleen. But you can also get Kerr's sign from anything else that irritates the diaphragm. So pus is also very irritating. So you can get Kerr's sign in pelvic inflammatory disease or PID. Sometimes you'll get Kerr's sign with that. Okay. Another sign is Gray-Turner sign and Cullen sign. Now, if you want to really look like you know what you're doing, don't ever hyphenate Gray-Turner. I've seen textbooks that hyphenate Gray-Turner. It's not a hyphenated name. Gray-Turner was the guy's name. His first name was Gray. Actually, I think his middle name was. Yeah, George Gray-Turner. So Dr. Turner found that flank ecchymosis was associated with intra-abdominal hemorrhage. So there are some examples. Notice how it can be really, really pronounced like this, or it can be a little bit subtle like that, or it can be splotchy like that. All three of them are considered Gray-Turner signs. Intra-abdominal hemorrhage, okay? Cullen sign was invented by or coined by an OBGYN doctor who noticed that ruptured ectopic pregnancy patients often had this periumbilical discoloration indicating intra-abdominal bleeding. So, but you can see Gray-Turner or Cullen sign with any intra-abdominal bleeding, right? So those are some examples as well. So when you're inspecting, if you're seeing a patient like this and they've got Gray-Turner or Cullen sign, you have to at least think about intra-abdominal hemorrhaging. The other thing to consider, though, is that the absence doesn't mean they don't have it. Just be sure to know that. So you can't say, oh, I don't see Gray-Turner or Cullen sign, therefore they're not bleeding. That's not true either. Okay. In fact, if you see it, they've probably been bleeding for a few hours. It's not something that happens acutely. It's something that happens after hours. Okay. So, neurologic pearls. AVPU, GCS, RAS, these are all types of neurologic scoring, which you should already be familiar with as a paramedic. These are things that you're going to use extensively as a critical care paramedic. So be sure you understand them. Look at pupillary assessment for size, symmetry, reactivity, distortion, okay? Like, what are we looking at in this picture? It's actually a traumatic injury, yeah. So the iris is partially coming out of that hole in the eye, so that's why it's teardrop shaped, okay? What is this condition called up here? Anisocoria, okay? If it's because of a blown pupil from a herniation of the brain, they're probably not going to have their eyes open by themselves. You're going to see fingers opening the eyes for them because they're unconscious, okay? This is probably something chemical called corn picker's eye. Corn picker's eye is farmers who touch like insecticide, and then they rub their eye, and that causes mydriasis. They're not herniating their brain, they just have a chemical dilation of their cornea, okay? How about that? What do you call that? What if I told you they were born with that? Strabismus. So a lazy eye. So, it often can be corrected surgically, but sometimes they're not. Okay. Secondary assessment. Reviewing head to toe, evaluating for change in condition, repeating vitals, map, and title, managing pain, 12-lead EKG. These are all things that you as a critical care paramedic will do on the regular, but especially repeating vital signs. In my protocols, you should understand that vital signs are vital, and so I like to see about every 15 minutes or so when you're with a patient. Most of our transports are less than 30 minutes, so most of my trip sheets I see are a couple vital signs. However, you should get vital signs every 5 minutes if what? If they're the least bit sick, right? If they're sick, you should be getting vitals about every 5. Okay, so vital signs are vital, and they're vital for trending as well. Remember, the eye only sees what the brain knows. So one of our goals in critical care transport class is to start filling your knowledge bank with things that you may not have known to look for before, so that your eye will see it from now on. And what is this? What is a fall of a systolic blood pressure more than 10 during the inspiratory phase? Pulsus, the two of you got it right. Pulsus paradoxicus, okay? So pulsus paradoxicus, notice it's not pulses, E with an E. It's pulsus with a U, okay? So pulsus paradoxicus. Clinically, the heartbeats detected on auscultation during inspiration cannot be palpated at the radial pulse. So you're feeling someone's radial pulse, and you're beat, beat, beat. They take a deep breath, and you don't feel them anymore, okay? Physiologically, how do you explain pulsus paradoxus? Any guesses?
Pressure, so you increase pressure in your thoracic pressure, so
Yeah, what happens when you take a deep breath?
Pressure on the heart.
You're increasing or decreasing? Right. You're increasing intrathoracic pressure overall. However, when you take a deep breath, the reason why you're taking a deep breath is because you're creating a vacuum, right? That's why air is coming into your mouth and nose. You're making a vacuum. So initially, and interestingly enough, there are a few proposed mechanisms for pulsus paradoxus. Not everyone agrees with it, but the leading theories are when you take a deep breath, you're creating a vacuum in your lungs, which causes air to come into your mouth and nose, because we are negative pressure breathers, right? We're not positive pressure breathers. That increased venous return dilates the right atrium, making the left atrium smaller, and also ultimately making the right ventricle expand, making the left ventricle smaller, which reduces preload, which reduces stroke volume, which reduces systolic blood pressure.
Could that also be seen in right side failure?
Yeah, for the same reason, right? So if the most common cause for left-sided failure is right-sided failure, and so now whether or not it's always with inspiratory pressure, that I'm not sure. But I know that at certain volume states, when you take a deep breath, you can get this pulsus paradoxus. But I'll tell you, when it is associated with a right ventricular infarction, which would be right-sided failure, you can see pulsus paradoxus. Classically, it's for something for tamponade. Like people say, well, if you suspect cardiac tamponade, can you feel their radial pulse when they take a deep breath? If not, that's pulsus paradoxus, and that helps you substantiate a diagnosis of pericardial tamponade, classically. Okay. The other constrictive entities or obstructive, if you're talking about obstructive shock, would be things like tension pneumo, PE, COPD. But tension pneumo, constrictive pericarditis, tamponade, these are all related conditions that can cause pulsus paradoxus. Again, little things that might help you as a critical care paramedic substantiate a diagnosis that you're concerned about. Okay. How about this? What is hypotension? You've got a narrow pulse pressure, muffled or distant heart tones, and JVD. Something around the heart.
Fluid, can be blood,
Brett, do you have a thought? Beck's triad. Both, I saw you mouth. Good, you both get credit for it. Beck's triad. What is Beck's triad? Well, Beck's triad was coined by American cardiac surgeon Claude Schaefer Beck, who said that, well, if you've got, what are we looking at here? Heart. So you were right, it was something around the heart. We're looking at, what is this big black stripe around the heart? Fluid. Should it be there? No. So you're looking at pericardial, a big pericardial effusion, and if Beck's triad is there, you're going to think about pericardial tamponade. So the heart is being squeezed like a walnut, right? It can't eject enough blood. Why is it that you get hypotension with a narrow pulse pressure? Because the heart can't eject any blood, so your pressure is going to plummet. Why do you have muffled heart tones? Yeah, so that was one theory, that the fluid around the heart was not allowing the sound.
It can't make those noises.
It can't make the, so what makes the noises? What makes the lub dub? The valves, right? Your heart doesn't make any noise when it beats, the valves do. The slamming shut and opening of the valves is the most, lub dub, lub dub, lub dub. The valves make the noise. So if your heart is like squeezed like a walnut and it can't squeeze very forcefully, the valves can't slam open and shut very loudly. And that's why you can barely hear the lub dub, because it's not making the sound, okay? And then finally, what's causing the JVD? It's all backed up. The blood has nowhere to go because it's stopping at the heart because the heart can't pump it forward. So there's a traffic jam behind it. So now your jugular veins start distending, okay? People also use Beck's triad to diagnose tension pneumothorax. Well then, how do you tell if you should dart the lung or do a pericardiocentesis? How do you know where to put the needle if they have JVD, hypotension, and muffled heart tones? Lung sounds, right? You got good bilateral lung sounds, put the needle in the pericardium and suck the fluid out. If you've got no lung sounds on this side, but good lung sounds on this side, ding, 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 put the needle there, okay? So how about this? What is hypertension, bradycardia, and irregular respirations? So, and just to be fair, some of you may have learned this as hypertension, bradycardia, and widened pulse pressure. You guys are scholars. So yes, Cushing's triad, the clinical manifestation of Cushing's reflex is Cushing's triad. So brain ischemia, which activates the sympathetic nervous system, which in an effort to do what? Increase cerebral perfusion. Remember, the body is going to do everything it can to keep your noodle perfused. So if it detects that your brain is not getting enough perfusion, it's going to activate the sympathetic nervous system. It's going to cause hypertension. It's going to do everything it can to keep your brain perfused. And Dr. Cushing noticed this and called it Cushing's triad. What if you see someone breathing like this? Remember, we talked about Kussmaul's, right? Where it's, how about this? Where it's a little bit, then it's really a lot, and then it kind of tapers off, and then they stop breathing. Well, what's the name of the breathing pattern? Good. So this is Cheyne-Stokes respiration, okay? They could be herniating. It's basically, it's hypoperfusion of the brain, the respiratory center. These are shallow, deep, shallow, and then apnea. That's the typical pattern. So you get gradual hyperpnea, then hypopnea, then apnea, sometimes periodic breathing. So this could be from hypoxemia, drugs, most commonly for some brain injury of some kind, hypoperfusion of the brain. Cheyne-Stokes respirations. Not to be confused with Biot's respiration. It's not Biot's, Biot's respirations, okay? Which is very irregular with cyclical pauses without the crescendo-decrescendo pattern of Kussmauling. So many texts incorrectly call it cluster breathing, and it's not, which is regular intervals of pauses between breaths. Biot's is very ataxic. In other words, there's no regularity to it. It's all over the place. Okay? Dr. Biot first noticed this in people with meningitis, and so the original name for this was rhythm meningitique, meaning meningitic rhythm. Okay, so it's got a very poor prognosis. Now, I'll tell you something. The reason why a lot of textbooks don't even teach Biot's respirations anymore and why we don't pay a whole lot of attention to it clinically, this is just good for a test question, right? But clinically, why we probably will see Kussmauling, we'll see Cheyne-Stoking, but we probably won't see Biot's a whole lot is because, not because it doesn't exist, but it's not really clinically useful because of this. Because if people get to that stage where they're kind of breathing ataxically, are we going to let them do that for more than 2 seconds? No. What are we going to do? We're going to intubate them. They're going to be on a vent. Okay, so it's probably going to be hidden by the modern airway management that we do anyway. Okay, so I don't expect you to ever see true Biot's respiration. You will see, and you probably have seen, Kussmaul's, right? So, which is still useful to recognize, and we talked about this already. Okay. How about this? What should you suspect with hypotension with more than 20 millimeters of mercury discrepancy in the upper extremity systolics? What would you be concerned about? AAA? I have a vote for a AAA. I have a vote for a dissection. AAA, dissection? Probably dissection, you're right. So in order for you to understand why we see this, you really have to understand the anatomy. Remember that when we measure people's blood pressures, we're usually measuring at the upper extremities on what artery? The one that runs right here, the brachial, right? The brachial artery is not its own artery per se, it's just the same artery just at a different place, right? It's kind of like in St. Louis, the same street has 3 different names. It drives me crazy. Skinker is McCausland, and north it's Kindland, and then it becomes what's north of Kindland? Where the clinic is. Anyway, it's the same street, right? So it's the same artery. So The brachial artery is the deep brachial artery, is the axillary artery, is the subclavian, right? So you have to understand then, how on earth does a dissection, a high dissection, cause unequal blood pressures? Well, if you look, where does the subclavian come off of? Right up there. It is coming right off of the brachiocephalic trunk, which is coming off the aorta itself. So if you've got an aortic dissection that extends up past that brachiocephalic trunk, guess what you're doing? You're reducing blood flow out the subclavian, which ultimately becomes your brachial, right? So now you get your blood pressure over here on the left, and it's normal, but there's at least a 20 millimeter mercury discrepancy, lower blood pressure on the right side, because that's where it goes. And vice versa. If it only extends past the left subclavian takeoff, and notice how the left comes directly off the aorta. There is no brachiocephalic trunk. It comes directly off of the aorta, and if that's where the dissection is, then the right side is going to have a relatively normal blood pressure, and the left is not going to have normal blood pressure. Make sense? So that's how you get discrepant blood pressures with a dissection. Okay. Now, people use the term dissection and aneurysm interchangeably. But just so that you know, as a critical care paramedic, they're very different. What's the difference between a AAA and a dissection? An aneurysm is a ballooning, right? It is typically all three layers of the vessel, the tunica intima, the tunica media, the tunica adventitia, all three are ballooning out together, okay? That's an aneurysm, okay? And if the aneurysm is way up here in the aorta, it's not a AAA. What is it? It's a TAA, because AAA is abdominal aortic aneurysm down here. This is thoracic aortic aneurysm. It's a TAA, okay? But nonetheless, it's a ballooning. A dissection means typically the tunica media or middle and adventitia or outer layer is intact, but between the intima, which is the intimal layer, the inside layer, and that middle layer, there's a defect, a hole of some kind, and that really high blood pressure, 200, 300 systolic, like you saw on that last slide, is dissecting and splitting that layer with every beat, okay? That's a dissection. Some people have really bad days and they have dissecting aneurysms. That's bad, okay? When you're a dissecting aneurysm, now it's dissecting and ballooning at the same time, okay? But they are actually two different things. I actually had to fix that in a textbook once where they were using the terms interchangeably. I said, this is not the same thing. I said, you keep using that word. I don't think it means what you think it means. Aneurysm is ballooning. Dissection is dissecting through the layers, okay? So, all right, so this, what I like about this little graph is that it very much simplifies what this is trying to say, and again, helps you explain why one arm would have a different blood pressure than the other based on where the dissection is. So really, when I have this patient, whether it's type 1 or type 3B or infrarenal, that's what IAAD is, infrarenal aortic dissection below the level of the kidneys, then there's nothing that I can do in the ER except control their blood pressure head, right? I'm going to give them a lot of esmolol, reduce that force and that change in force, that delta V, so to speak, and get them to a surgeon as fast as I can. That's really all I can do. That's all you can do. What the most important thing for you to do is control their MAP to goals and titrate that esmolol drip appropriately, because that's probably what you're going to get from the sending hospital is titrate the esmolol to this MAP goal. That's going to be your most important job. Manage their airway as needed, of course, and make sure that they get there safely. reassess, reassess, reassess. Something else we're going to talk about is tubes. You're going to have all kinds of tubes that you're going to manage. Gastrointestinal tubes include NGs, Dobhoffs, GJ tubes. Which picture up there is showing a Dobhoff tube? The far left, the middle one, or the far right? It is the far right, okay? So you might get a report saying your patient is this old, this many years old, blah, blah, blah. They have a Dobhoff that's running. You should know what that is, okay? Dobhoff is this feeding tube. It's typically, it's a weighted tube that is fed through the nose that goes into the first part of the small intestine, and that's where they get tube feedings from, okay? What's a GJ tube, and now how is that different from a G tube? A GJ tube is actually going into the jejunum, right? A G tube is just the stomach, say. So you should know what that is. What is a bolt? Which one is a bolt? You got two left, far left or middle? Far left. A bolt is going to be intracranial pressure ICP monitor. Okay? So these are patients that you're probably going to be transferring to the university hospital or transferring for a bolt at the university hospital because of a head injury of some kind. And then what are we looking at there in the middle? It is a form of a central line, but to me that looks like it's a Swan-Ganz catheter. Yeah, oh, sorry. Yeah, so there's this little pressure catheter through a central line as an introducer, so yeah. So then you're also getting Foley's, suprapubic catheters, nephrostomy tubes. I'm sure you've seen those already too. So you're going to monitor lots of those tubes as well. So patient assessment. It really is the bedrock of clinical practice. You're used to doing clinical assessments as a paramedic, but we've highlighted the nuances that will separate you from the regular road medics. You're going to be a critical care medic, you're going to be looking for these other things. So critical thinking, expanding your differentials, reassessment, these are fundamental tenets of critical care transport. And even the things we talked about today we'll hit in more detail once we get to those specific chapters later on this semester. All right, questions? My goodness, it's 12:15. We haven't even gotten to chapter 9 yet. Now, to be clear, I love the questions. Man, it's a lot easier for me to talk to a class that's asking questions than a class that's just staring at me. That's terrible. So you guys are great. I love the questions. I'm not going to get to chapter 9, but I will. Chief Stewart has some time built in week 3, I think. So how about I tackle chapter 9 then, and then he'll have all afternoon to get to chapter 8. Okay. You have chapter 9, so if you want to read ahead, that'd be great. That'll be part of, you got to read it anyway. This is part of your homework, so go ahead and go through it. You'll see in the notes what I've kind of highlighted, and then we'll do that on week 3. All right. So do you want to send them for lunch now?
Yeah,
Okay.
that's,
12:15 now.
yeah, 12, or 1:15.
1:15.
Or 1. Well, we cut it a little closer today, guys.
Yeah. Can you be back in 45 minutes? 1 o'clock? All right. Thanks. I really love the discussion. You guys are scholars. This is going to be fun. Man, awesome.
I feel like this is a question, these tabs here, is this to help us organize the notes that you give us? Okay.
You'll fill it in as the course goes, yeah.
Okay. That's actually very nice.
Yeah,
Are the numbers to the, like, each class, like one?
I don't believe they're associated, I mean, they're in order of when we're going to present it to you, so maybe, yeah.
Okay.
Yeah. Yeah, I think they're just the tabs they chose.
You go to the beginning, or whatever, the beginning.
Yeah, there's an index. That's helpful too. Yep, okay. So some housekeeping things. One, going back to your syllabus, we have built-in study hall days that are in your syllabus that you may not know those dates yet. Prior to every exam, there are going to be 2 study hall days that you guys can come to. It's optional. But either Nate and myself or both Nate and I will be there to answer any questions prior to a test. So you have 2 opportunities because of shifts. We have to have it for twice. Come twice. I've had people who came both times every time. And you know what? They passed the tests. So come do what you need to do. But I want to remind you that those are in there. So look over that syllabus very carefully tonight and make sure that you're aware of that. Also, team names. So this is a team, that's a team, and that's a team. You're separate teams. We're going to pit you against each other throughout the course. So I want team names by next week. If you don't come up with a team name, I will come up with one for you, and you don't want my team name. Last year, this was Team Clueless. This was Team Trauma Wheelchairs. And this was Team Bars because they used the first name out of everybody on their team. Gay. So whatever. It was a team name. It was gay. But this was Team Clueless and the name held. The name was accurate. I mean, really, let's be honest. So. Okay, well, maybe I should. Okay, sorry. For those that offended, I do apologize. And I'm recording too. This is on record. So now I'll probably be.
I'm sorry,
Okay, so today, this afternoon, the rest of the time, let's try to get through pharmacology. This isn't all the pharmacology you're going to get for the course by far. But I want to introduce these vasoactive drugs, and there's 13 of them we need to go over today because we're going to be using them all throughout the course. During our shock lectures, especially during hemodynamics, we're going to talk about them, we're going to use them. And I want you guys to start studying them now because there's 13 of them. So let's introduce them now in the first week.
Question, has nothing to do with pharmacology. Since we didn't get chapter 8, with Dr. Tan, will it be on the quiz?
No, it will not be in the quiz. Good questions. I had to rewrite the darn quiz because he went behind. He gets one freebie, and that's it. So, all right. Just saying. All right, vasoactive medications. So there's a pharmacokinetics, pharmacodynamics. We're going to touch on this lecture briefly. This is a bit of a dry lecture when it comes to this kind of stuff, unless we have pharmacy students in here. I don't think we do.
I was just curious, where are we at in,
Oh, go to the slide until you see that slide there.
Slide 240.
60, slide 240. Appreciate that, thank you. And we're here.
So last year during this lecture, someone put a fork in their eye. I don't suggest you do that. It's that dry. So don't do that. I'll just kind of rush through it, and everybody keep their eyeballs intact, right? It's kind of a dry material, but here we go. So I start with pharmacokinetics. Pharmacokinetics is a study of the action of medications within the body. These drugs that we're giving, for them to be effective, we need to know why we're giving them, and we need to know how they work, right? And so this is what this field studies. It's how the body responds to the drugs that we ingest, inject, or otherwise place into our bodies. And the 4 principles of pharmacokinetics are absorption, distribution, metabolism, and excretion. We're going to break each 4 of these down, but it's an acronym called ADME. So make sure you know that acronym and what that stands for. So absorption is the movement of drug molecules from the site of entry into the systemic circulation, right? So basically, it's the route. So what are some routes that we use or are available for drug administration? Just name a couple of them out. IV, IM, IO, sub-Q, oral, good. Inhalation, beautiful. Inhalation, ET tube. Transdermal. See, did we catch them all? Ooh, rectal, right? Nebulized, sublingual. So these are all different routes that we can use that your body's going to absorb, right? The medication that's being given. The term bioavailability is actually looking at the percentage of the drug that reaches the systemic circulation. Did you know that oral meds only get to the target receptors 60 to 80% efficacy or strength? Wow. Right? Now an IV med will get to where it needs to go. But the reason why oral meds decrease is because it goes through the liver. And we're going to talk about that here in a second. So the oral meds, when you take them, have actually more drug in there to compensate for that. But again, you're only going to get 3/4 of the med to where it needs to go. So knowing that, What factors might affect a drug's bioavailability? Think about the different routes we give it. What are factors?
Medical history,
If it's oral,
If
what
it's-
else is in their stomach?
If it's oral, what else is in their tummy? Okay.
Size of the patient.
Age, size. What if we're giving it what if we're giving it for anaphylaxis, we're giving it sub-Q?
Subcutaneous tissue, I mean, the density of, like, how big they are.
Well, what if they're in anaphylaxis? Are we perfusing those tissues well?
Right, no, it's just.
No. So that's going to affect things, right? So perfusion of the skin temperature, your pH level. What I need you to know in critical care is that pH levels matter when it comes to drugs. And you're going to see a big change when it comes to vasopressors and a patient is acidotic versus a patient is not acidotic. Right? We're going to need to give an acidotic patient a lot more vasopressors to treat hypotension when they're in acidotic states. They just burn through it. So the medication you give is not being absorbed all over the body. It's really going to where it needs to go. But prior to getting where it needs to go, it's going to go through some changes. It's going to be affected by different things. So distribution is the study of moving that medication about, right, from where it's being introduced into where it needs to go, right? This is highly variable. Blood is the highway that transports these drugs to tissues, but things can depend upon it. The molecule size of the drug, the ionization, the receptor availability, and their acidotic status. So one thing I need you to know is the first pass effect. This is for oral drugs. So over here on the right, it kind of breaks down what happens when you take an oral drug. 1, the drug is taken orally. 2, it enters your stomach and GI tract. Some of it is actually absorbed through your GI tract. That's normal. It's going to happen, but not all of it. Then the liver veins pull it. It actually pulls it, sucks it out of your intestine. You haven't used it all. And then from there, it goes to the liver. Why? Liver is a filter. And so the body sees something in there, and it's like, I need to filter that. Not realizing that it's your antibiotic for your tooth infection, and you need all that. But it's going to take it through, and it's going to filter it. And so that's what first pass effect is, the process by which a dose of an oral medication is reduced as it passes through the intestines and the liver. And then from the liver, it goes into the central circulation, and then it targets where it needs to go.
So like a medication that's a oral delayed release, is it
Ah.
delayed release because it goes to the liver?
I don't know. That's a good question, Dr. Tan. I would think that's the case.
Because I would think that like,
Yes.
that's how my brain works, like it goes to the liver and the liver is obviously gonna filter it.
Yes.
But
But I think delayed release more, it depends on the dose that it is and how much the patient is getting. More. Also, this is played into fact, but I think it's more of we want the dose to last longer and be released slower.
Yeah.
But it certainly is affected by this. How it's affected, we'll ask Dr. Tan when he's back on week 3, how that affects the first pass effect. So we answered the question already, why is the liver involved in the process at all? Because it has to metabolize them for the body to excrete them. Okay? So the liver's got to break them down so they can be excreted from the body. Because we're going to learn that when you inject morphine into your body, that's not the chemical substance that's treating your pain. The morphine is going to metabolize into metabolites. And it's going to break it down into different components. That molecule is going to break down different components, and that's what's going to target the receptor and give us our desired effect. And so those metabolites need to be excreted, and so that process starts in the liver. So metabolism, the process by which the body alters the medications. The liver is the primary site for metabolism of oral medications. That's why Tylenol overdoses, liver problems, right? We kill our liver. Alcoholic cirrhosis, it's liver. We kill our liver. Because the liver is trying desperately to get rid of all that crap, but you're giving it at such high dose, it causes problems. But metabolism also occurs in the intestines, the lungs, the kidneys, and also in the blood. In your book, it talked about the cytochrome enzyme. I'm sure you read that. And I want you to make sure you know for sure what a metabolite is. A metabolite is what happens when a drug is transformed. It's broken down, processed, and converted into active components, and those active components are what targets your cells or your receptors to give the required physiological response. Everything you take in is going to be broken down into metabolites and then eliminated from your body. I'm going to pass over this slide. You can read it if you want to. I'm not going to test you on this. It's just the journey from a medication to metabolite. It's very thrilling, obviously. Excretion, how we got to get rid of these drug metabolites. They're primarily excreted by the kidneys via the urine. So we can also get rid of them through our stool, our sweat. We can breathe them out, and also through our bile. An example of a bile excretion, if that sounds weird to you, VEC. Vecuronium is actually excreted through the bile. So kind of interesting. That's why vecuronium has a longer duration of action than rocuronium does, because it takes longer to excrete it, because it's going through the bile instead of through the kidneys. So you can see how all these factors play a part in how long our half-life is, how the efficacy of the drug is, and more importantly, dosages, right? How they determine what a dosage is, right? They determine that because they've studied that drug that's been broken down into the human body, and they've studied how long it took it to get through the liver, how long it take to get excreted, right? So they took all those factors into consideration when they set a drug dose. And so there's a lot back into that. And we just give it as 2 milligrams of morphine like no big deal, but it's actually been very well studied. One thing I want you to remember, and you may see this on a test or a quiz, the liver participates in the metabolism, and then the kidneys participate in the excretion of the metabolites. Generally speaking, mostly speaking. Of course, there are exceptions. Okay, when it comes to excretion, there's something called first-order elimination, and that's just the relationship between the drug's concentration and the metabolism rate. A zero-order elimination is a fixed amount of metabolite is eliminated over a time period, regardless of the amount of metabolite in the plasma. Really not really concerned about those two definitions, but half-life I definitely want you to get. Half-life is the time it takes the body to eliminate half of the amount of the metabolite present. Okay? So if I go drinking with my buddies, in other words, how long does it take for half of that alcohol I ingested to excrete from my body? That's a drug's half-life. And we're going to talk more about examples when we go through these drugs. A medication can have several half-lives. Take, for example, aspirin. Aspirin has a half-life of 15 minutes, but the antiplatelet effect of it lasts longer than 15 minutes. It lasts for 7 days. So a drug can have several types of half-lives. Okay? Aspirin is broken down into different metabolites, and the metabolite that handles the antiplatelet side of things lasts for 7 days, versus another aspect of aspirin lasts for 15 minutes. So these metabolites are broken down and targeted very specifically on mechanisms of actions and duration of half-lives. And it will make more understanding to you when we start talking about the drugs individually. But why does this matter to us in critical care? Why does knowing the half-life of a medication matter?
Throwing blood thinners, you know if blood thinners still active.
Okay, I like that.
Or like if you're giving Zofran, like knowing when that medication is going to wear off so you can get more.
Beautiful. Yep, that's exactly right. So setting limits for dosing of medications to reduce overdosing the drug. If I didn't know I couldn't give Zofran every 4 hours, and I just give it every hour thinking more is better, am I harming the patient? Yep. And so that's why they have time limits. That's why it's important for us to realize medications have half-lives, and that's why we dose these drugs as often as we do or we don't. But like I said, we'll talk more about this when we get into the drugs. And that's pharmacokinetics. So pharmacodynamics is a little bit different. That's the branch of pharmacology that deals with the drug's mechanisms and its actions. So basically what the drug is doing to your body. There's 4 ways a medication can work. Just be familiar with this slide. I'm not going to really test you on it. A medication may bind with the site on a cell to promote or inhibit an activity on that cell. That makes sense. Medication may affect the physical property of a cell, which in turn alter the function of that cell. A medication may alter a metabolic pathway to achieve the desired result. Really, number 1 is the only one I'm really concerned about, and we're going to talk about that here in a minute. So when we look at the onset of action, that's the time needed for the concentration of a medication at the target tissue to reach its max effective level. Therapeutic index, the ratio of a drug's lethal dose for 50% of the population to its effective dose for half the population. So this is the patient's or the medication's margin of safety. So make sure you know that term there. And again, we'll talk more about that as well. All right, that's it. God, we got through that. Okay, if you have more questions on pharmacokinetics, pharmacodynamics, read it in your book. Quite honestly, you're not going to be tested much on that. Okay, let's get to the good stuff. Let's talk about the sympathetic nervous system. The sympathetic nervous system is our fight or flight response, right? That's our sympathetic. Versus, what's the opposite of that? Parasympathetic. So the sympathetic nervous system have receptors, and they're called adrenergic receptors, right? Very important. An adrenergic receptor applies to medications such as epinephrine, norepinephrine, and dopamine. These are drugs that stimulate those receptors. We know they're found in the heart and blood vessels. Anybody know what a catecholamine is? Other than reading it from the board? Well, they're hormones. They're hormones that our body uses to facilitate a response in the sympathetic nervous system. Guess what? Epinephrine, norepinephrine, and dopamine are catecholamines. They are endogenous. What does endogenous mean? It means coming from within the body or produced by the body. We produce epinephrine. We produce norepinephrine. So should we ever be afraid to give that to our patient? No. It's going to take a lot for you to overdose someone on epinephrine and norepinephrine. So don't be afraid to give it. It's produced by the patient's sympathetic nervous system and used, which is why we give it. Because catecholamines are, very important if you know, put a star next to this. 3 things. They have a rapid onset of action, which makes them beautiful when we need them. They work when we need them to. They have a high potency and efficacy. So in other words, they're very effective. And they have short half-lives. Why? Because they're endogenous catecholamines, right? The body can continue to make them. It's not like the body's going to say, hey, I already made this much epinephrine, I can't make any more for another 10 days, right? The body's going to continue to produce that hormone as often as we need it, right? Now, there's something called adrenal fatigue, which we'll talk about later on in the course, but we're not concerned with that today. So catecholamines are awesome for those 3 reasons. Catecholamines are epinephrine, norepinephrine, dopamine. Kind of looks like a test question. I don't know, just me. What do you think? I think so. All right. Catecholamines are affected by a patient's acid-base balance. When I say acid-base balance, what do I mean by that? What their pH is, right? Right? So what's a normal pH for a body? Somebody knows, yeah. So does that mean they're more acidotic or more alkalotic?
7.2.
Yeah, because where's the baseline? Where's the pH scale go from 0 to what?
0 to
14. Right in the middle is 7. So if we live at 7.35, 7.45, then we're slightly what? Slightly alkalotic. Why is that? Why aren't we slightly acidotic? Oh gosh, you're way ahead. All right, calm it down, sister. Bring it back a little bit.
I was like, hold on.
Okay, well, we'll learn that. But today's reason is because acidosis is bad. That's simple. That's simple. Let's leave it at that for today. Acidosis is bad, all right? And so, these advanced people who are really smart know better, but yeah, acidosis is bad. And it's going to affect your catecholamines, believe it or not. It's going to reduce the effectiveness of this epinephrine you're given, of this norepinephrine we're given. Does it mean we don't give it in acidosis? Yeah, we do. But guess what? You may be dosing it more frequently than you normally would. Or you may have to increase your dose. Ever been to an ICU transfer patient and they were on 4 or 5 different pressors? Why? Because they're acidotic. One good reason, right? Yeah. And so we have to increase the dose. We have to add additional vasoactive medications to compensate for that acidosis. So something to be aware of that, yeah. Now, what about sodium bicarb? Doesn't sodium bicarb fix acidosis? Why on earth don't we just don't give them sodium bicarb? Could we? Could we just say, you're acidotic? Please, I got something for that. Sodium bicarb.
That's what's causing the acidosis.
Okay. So is it a good idea to just give every acidotic patient sodium bicarb? No, it's not.
That causes other problems.
It causes other problems. And you're going to learn that next week on ABGs when you cover them. But you're right. No, that's a decision that you guys should not make in critical care paramedicine. Okay. If you think your patient needs help with the acidosis and sodium bicarb is indicated, and sometimes it is and sometimes it's not, guess what phone call you're making? You're talking to a guy who's got, or a girl who's got MD after their name, because it will. It can cause some serious complications, and we're going to cover that next week. So, but if you do give sodium bicarb, remember, don't mix it with anything. If you mix it with the catecholamine, it's going to degrade the catecholamine even further. Something to keep in mind. All right, let's talk about receptor sites. Receptor sites are just proteins that live on a cell wall. They act as a gatekeeper to that cell's mechanism of action that we want them to do. If it's a blood vessel and it's an alpha receptor, blood vessels have smooth muscles, do they not? Are smooth muscles able to constrict and contract, dilate and constrict? Well, how do they do that? By receptors. So if you were born with no receptors, well, you're in a lot of trouble, right? Because we need the blood vessels to dilate and constrict. And so that's all receptor sites do, is they act as a gateway. So, but they can do two things, receptors. They can act as an agonist, which means they stimulate, or they can act as an antagonist, and they block. Okay, so those are the two big ones. An example of an agonist would be what? What's a drug that agonizes, or it becomes an agonist when it hits the receptor?
Epi.
Yeah, epi, there you go. What's a drug that acts as an antagonist? Narcan, right? So there you go. So, okay, let me answer this question first. A beta agonist such as epi, right, increases patient heart rate. Do we agree with that? So if we give a beta blocker and it hits the same receptor, a beta receptor, will it cause the patient's heart rate to decrease? If epinephrine activates on the receptor, causes heart rate to go up, will a beta blocker activate the receptor and cause heart rate to go down?
No. Prevent it from being high.
It prevents it from accelerating.
It prevents it from being stimulated. Does that sound right? What do you guys think?
Yes, because, well, okay, so a beta agonist, so it's working with, it's pro-receptor,
Yep.
like go receptor,
Yep.
and then if you beta block that, then
But does it act on the receptor to cause the heart rate to go down? Russ says no.
It's not an agonist or an antagonist.
So that's right. So it blocks it. So remember, antagonism isn't the opposite effect in action. It's simply blocking it completely from occurring. Okay? And you're going to read about that when it comes to rocuronium and what's the other one? Succinylcholine. The mechanism, how they work, depends on the receptor, right? So because it blocks acetylcholine, right, which is going to stimulate muscle contraction. We'll get to that later. But just so you know that an antagonist blocks. It occupies it. Why? Because it looks like it should be there. It looks like a stimulant. It looks like an agonist chemically. So the receptor says, yeah, come on in, park here. Well, then the naloxone gets the final laugh because it's not a stimulant, right? It's not designed to be there and work and make the patient high if it's pretending to be fentanyl. It's going to go in there and block it, and then the fentanyl gets bumped off. So that's how our overdose patients wake up, right? Because Narcan comes in, occupies the site, and kicks that opiate off physically, gives it the boot, and it can't go back because the antagonist is stronger and it's going to hold on stronger. Okay, so important that you know that because, again, when we get to paralytics, this matters a lot and how paralytics work. Okay, any questions on that? Pretty easy stuff. So sympathetic nervous system receptors are called adrenal receptors. We have quite a few of them, but we're going to concentrate today on alpha 1, beta 1, and beta 2. And so is this news to anybody? Alpha 1 causes vasoconstriction. Beta 1 causes increased inotropy to the heart, which is contractility, right? And then beta 2 are vasodilation and bronchodilation. Did anybody not know that beta 2s cause a vasodilation? It's important. If you don't already know that, make sure you put a star next to that. Because guess what? Some of our vasoactive drugs act on beta receptors, but what are they going to do? They're going to cause vasodilation, which is going to do what to your blood pressure? Uh-oh, spaghetti-o, right? So some of our vasoactive drugs that are beta agonists are going to raise the blood pressure, and others that are beta agonists are going to drop the blood pressure. It's important to know we know which ones those are and then when to give them. So the location, the receptor site dictates its response, as we said. And there are specific receptors in there, like dopaminic receptors and vasopressin receptors, we're going to talk about later, that can only take in dopamine or vasopressin, right? So there's a lot of specific receptors in our body as well that are just not alpha 1, beta 2. But please know these three, because I'm sure you may see those again. All right, the alpha 1. Endogenous catecholamines like norepinephrine, epinephrine, and dopamine hit on the alpha 1 receptor. Guess what drug has a high affinity for the alpha-1 receptor. It's phenylephrine. Well, it's on the board there, though. If you give your patient norepinephrine and phenylephrine at the same time, and the alpha receptors see both floating by, they're going to grab that phenylephrine every single time. That's what that means. They much prefer phenylephrine living on that receptor than norepinephrine. Why? I don't know why. Talk to the person who made your receptors. But we've discovered that. And so, which do you think is a more potent alpha constrictor? Norepinephrine or phenylephrine? Well, I just told you that the affinity of the receptor is to grab that phenylephrine instead of the norepinephrine if given a choice. So if I gave both of them at the same time, which one is going to work better? Every time. That's why if you ever see phenylephrine given, it's an awesomely potent alpha constrictor. Why? Because the receptor loves it so much. So not only is it because it's going to grab it more often, but when it's in the receptor, it's going to work that much more better. So it's going to severely vasoconstrict your patient's body. And it's going to rapidly jump your blood pressure, which is why in the ICU they carry these phenylephrine sticks. Have you ever seen them? 100 micrograms, 200 micrograms, preloaded sticks that they pull out of Pyxis and give, like boom, to rescue the blood pressure when it needs to be rescued that quickly. Phenylephrine is an awesome drug for that. Well, how does the alpha-1 receptors work? Well, it's those smooth muscles in the veins and the arteries and the capillaries. They all have them, right? And they all can dilate and constrict, and phenylephrine works on those. So how does it work? Well, it increases blood pressure by increasing systemic vascular resistance. Now, it's a hemodynamic term we'll get to in hemodynamics, but I just want to introduce these terms to you now. Basically, squeezing the blood vessels. So for extra credit, if my patient's blood vessels are squeezed, is that a high SVR or low SVR? What do you think? High. Yep, exactly right. That's a high SVR. Okay, good. Interesting note. Did you know that alpha-1 receptors are also found in the bladder and the prostate gland? Patients who have BPH and they're shocky will have reduced urinary output for that. You guys have been taught, right, to look at the urine output to see whether the kidneys are working or not. That's accurate to a point, but if they've got BPH, they're already going to be vasoconstricted. So keep that in mind. When you're assessing urine output status as far as kidney function and shock. These patients are going to have just reduced urinary output because alpha receptors live in those areas that are enlarged. Prostate's enlarged. Okay, beta-1 receptor. Again, endogenous catecholamines such as epinephrine, norepinephrine, dopamine. Guess what this receptor has a high affinity for? Isoprel. Remember learning about isoproterenol and isoprel in medical school? Oh, you didn't learn in medical school? Get your money back, gee whiz. Okay, so what's so great about isoprel? It's a potent beta agonist, isn't it? You give isoprel to somebody, you know what their blood pressure is going to do? It's going to go through the roof and keep going. You have to get an airplane to get it back down because it's so high. Okay, why? Why does it work so well? Because the beta receptors love isoprel the most. They just do. And so isoprel is given only in emergent situations where we got to get that blood pressure up because it works so doggone good. And of course the contractility of the medication as well. So it's located in the heart arterioles and heart arteries. Beta receptors do a lot of good to the heart, right? Beta-1, heart, increases chronotropy, which is the rate. If you don't know that, write that down, increases the rate. Inotropy talks about contractility, right? Increases the contractility of the heart. Dromotropy, what's that referring to? Okay, but what's it actually physically doing though? But what's it physically actually doing? No, because nope, that's chronotropy. It's speeding up the heart rate is chronotropy.
No, it's dromotropy.
I know, what's dromotropy?
It's speeding the electrical current from point A to point B.
But what's it going to? But there's a physical response that you know what it's going to do. It's going to provide extra beats.
Yeah.
So chronotropy increases the heart rate that's intrinsic to the heart. Dromotropy is going to increase the heart rate because it's adding in extra beats because things are going through so fast. So there's two mechanisms there. You understand? I want you to know the difference between those two. So there's two ways that increases heart rate, through chronotropy and through dromotropy. And inotropy, we know what that is. That's contractility.
Aren't those typically those extra beats that throw us in atrial beats?
Atrial beats, yeah, it still goes through the same mechanism the heart rate is intrinsically going through, which is the SA node ideally. But yeah. Okay, so it increases heart rate, increases blood pressure, which this increases cardiac output, which is the name of the game. We got to get a good cardiac output for a patient. No beta-1 receptors are also found in the kidneys, and they assist in releasing renin. We're going to talk about kidneys and renin here in a little bit. Okay, beta-2. Beta-2 is endogenous, it's the same catecholamines, very high sensitivity to what? Albuterol. Isn't beta-2 targeting the lungs? Why does albuterol do such a doggone good job? Because beta-2 receptors love albuterol the most. And so that's why it's our preferred medication when we give for lung problems. So albuterol. Where is beta-2 located? In the coronary arteries, skeletal muscle tissue, and lungs. We get bronchodilation. We also get some vasodilation. We'll talk about that more in a little bit. So be careful giving it because it may lower your blood pressure. Dopamine, we're going to just rush right through this. There are specific dopamine receptors. Do we give dopamine anymore? Very rarely. It's fallen out of favor. Matter of fact, we booted it off our trucks not long ago, right? A couple years ago.
We transport it maybe, but that's about it.
Yeah, and we'll talk about what it has very narrow use, and we'll talk about how in a little bit. Vasopressin, though, I think is a miracle drug. I love vasopressin. Who's ever given vasopressin or transported a patient on vasopressin? Dude, freaking awesome, man. Vasopressin rocks. And so what it is basically ADH, right? So what's ADH? So what's the purpose of antidiuretic hormone? What's it do in our body?
Retain salt.
Stop answering all the questions. He's a nurse, right? You've been through RN school?
Kind of.
Okay, so he knows a lot of this stuff. So he's going to be quiet for a little bit, let other people answer some questions. Brett, what were you going to say?
I was just going to say the body's going to start with withholding fluid.
Why do we want our body to withhold fluid? Go ahead, Russ, go ahead.
To increase increase that what we have inside, so we take the pressure, maintain homeostasis.
There you go. So are we better wet or dry?
Wet.
We're better wet, right? And so we need something to keep the water in. Otherwise, we're going to pee everything out all the time. We're going to sweat everything out all the time. So there's a hormone called ADH that our kidneys produce that regulates water balance in our body. That's going to be very important for critical care. And we're going to talk a lot about ADH in the future. But what happens here is, say here we don't have ADH in our body. What's the body doing? It's just peeing nonstop. It's peeing out all the fluid we take. If I drink a cup of water, I'm going to pee out a cup of water like right away. But what happens instead is our kidneys will reabsorb the water. So the kidneys know how much water I need to be okay. And if I drink a gallon of water right now, I'll pee out 3/4 of that water because the kidney says I can. The kidneys say I can. Because the kidneys know exactly where my water balance is at all times. And that's what's happening in this picture. Here, there's no control at all. All the water's being peed out. Here, there's control. The body's reabsorbing water and then peeing out a small amount. That's concentrated urine. And that's what we want to happen. So the beauty of this is, how does that affect blood pressure? If our kidneys are telling our body to retain water, how's that affecting blood pressure? Yeah, it's keeping the plasma full of water, which is going to increase volume, which is going to increase blood pressure. And so that's why vasopressin is phenomenal, because it does just that. It helps the body retain water and keep the blood pressure up. It also acts as a vasoconstrictor as well.
So could vasopressin be like contraindicated in patients with like bad CHF?
Well, no, I wouldn't go that far, but there's other endocrine conditions we're going to learn about later throughout the course where that would be true. There's other endocrine conditions we're going to talk about. But for now, as far as it being a vasoactive medication, it's a beautiful thing. We love vasopressin today because it does so many things.
How fast do you see the effects of it?
Good, man, awesome. It's a quick acting drug because it's endogenous. We make ADH, again, just like epi and norepinephrine. We make vasopressin in our bodies. So when you give it, it works really fast and really well.
How fast do you see the effects of them? Because the body has to retain that fluid to build your pressure.
Well, the effects depend on what? Depends on the patient's condition, underlying physiology, and whether or not they're acidotic. The good news about this, which I don't think I talked about in this slide, but later on, it's not affected by acidosis. Not affected. So that makes it a perfect second and third line vasoactive medication to put on, which is why you see patients on norepinephrine, then they next reach for what? Vasopressin. Because they know they're acidotic. They've increased doses of norepinephrine or epinephrine to a point, they're like, we're getting nowhere here. We need another receptor. The V receptors is where you want to be.
So,
Go ahead.
I was just gonna say, it affects more fluid, not necessarily like the vasculature.
It does both. But you're right, it does more so affect the fluid volume and fluid distribution in the body, but also vasoconstricts.
Okay.
So it's like a double whammy.
And then obviously, like, the function of somebody's kidneys have a huge
Yes,
effect
yes,
on
absolutely right. Yep. So if they already are in the ICU for a Tylenol overdose or something, or not Tylenol, if they got kidney dysfunction for renal problems for whatever happened, absolutely.
So would that be a patient that doesn't get vasopressin for that reason?
Or what kind of overdose?
Ibuprofen.
Oh, ibuprofen overdose. No, I don't think that's the case.
Okay.
But, because I've seen them do it in that case, but they had to increase the dose. And we'll talk about the dosing of it here in a minute. Okay, then there's a last receptor I want us to know about, and that's the angiotensin II receptor. That may be new for you. It's part of the RAS pathway. Do you remember hearing about the renin, angiotensin, aldosterone system pathway? Yes. Okay, we're going to learn about that today. It does something very similar to what vasopressin does. It works on the blood vessels, regulates blood BP by moving fluid around, but by a different mechanism. We'll talk about that. These receptors are found in the smooth muscles of all these different organs and blood vessels. They help in releasing ADH, which is a good thing. That's where the renin comes from. The aldosterone helps in sodium retention. If Dr. Tan had gotten to his lab lecture today, he would have went really deep into sodium levels. Water follows sodium, right? Sodium pushes water around. And we're going to learn that when you go to sodium, to labs. So sodium retention, aldosterone plays a big role in how much water we have in our body. And then also they do vasoconstriction, obviously, because we're supporting blood pressure. All right, so when you talk about vasoactive medications, there are terms that we're already familiar with, right? Such as mean arterial pressure. Hey, guys. Shock index, right? We learned about that today, right? So where should our shock index be?
0.9.
Less than 0.9. 0.6, 0.7. Once we get to 0.9, we're concerned, right? Where's the critical level at? 1.4. Very good. 1.4. If we have a shock index 1.4, we're critically in trouble. We have huge problems. But 0.09, we're very concerned and we need to act. And then, of course, skin, right? Why is noting skin in shock states so important?
Because it's the largest organ in the body.
What's that?
It's the largest organ in the body.
Yep.
That tells us a lot about your overall.
Yes.
One of the first things it's going to shunt blood away from.
Yes, but guess what? The capillaries is where the magic happens. That's where tissue perfusion takes place. The capillaries, not the veins or the arteries, right? So if I have evidence of capillary dysfunction, i.e. pale, cool, wet skin, then what do you think my tissue perfusion is at the cellular level? It's in the toilet. And as paramedics, we know that. We understand that. We assess our patients for that. But in critical care, I want you to take all those and now start thinking about cardiac output. How cardiac output affects shock states and how we can go about fixing that with these vasoactive medications. What about systemic vascular resistance? How well our arteries and our smooth muscles and our blood vessels are clamping down or not, right? What shock state allows our blood vessels to openly dilate and causes hypotension? It's distributive, right? So septic, neurogenic shocks, right? So we really need some alpha stimulation there, don't we? Right? What about central venous pressure? We may not know about that. We'll learn about that in hemodynamics, but that's how much pressure is present right outside our right atrium, right? And if that pressure is down, they may signify hypovolemic states, right? So we can measure that pressure, and we'll learn how to do that later. But in critical care, these are the terms we talk about in addition to the paramedic terms you see above. Okay, so we're going to, of the 13 meds we're going to talk about today, they can be broken down into 4 categories. Inopressors, vasopressors, dilators, and vasodilators. Okay, so let's start with inopressors. To understand how they work, I need to understand what inopressor is. Ino means inotropy, right? We talked about that already. That's contractility. So an inopressor drug assists in contractility of the heart. It's going to give, it's a positive inotrope that's going to provide contractility of the heart, which means a more forceful contraction, which means an increase in stroke volume, the amount of blood that's being pumped out, which means an increase of what? Cardiac output. which means what? Increased blood pressure, right? So this is what that's going to do. And then it's also a pressor, inopressor. Pressor meaning constriction, vasoconstriction. So inopressors increase blood pressure by 2 mechanisms. They increase inotropy, the ino, and they increase vasoconstriction, the pressor. These drugs are your epi, your norepi, your dopamine, and your isopaterenol. All right, let's break down epinephrine. So here, for your studying pleasure, because I'm so nice, I created workbooks for you guys to help study these medications. I'm kind of an awesome kind of guy. You'll find that out as the weeks go. So if you want to fill these out today, you can, or fill them out later, but use this as a study guide for these 13 medications. And if you haven't figured out by now, we're going to kill like 12 trillion trees throughout this course. Okay, so trees are not safe anymore because we're going to have a lot of paper. So we're going to talk about all these different things for each of our medications. So we got a long way to go, friends. All right, what are the indications for epinephrine? That's obvious, right? It's anaphylaxis. What's the number 1 drug we use for anaphylaxis? Epinephrine. It's the number 1. Cardiac arrest, hypotension with bradycardia. Contraindications? Tachycardic hypotension. Why would tachycardic hypotension be a contraindication for epinephrine? It's not an absolute contraindication, which means I definitely wouldn't do it. It's more of a relative contraindication, but why?
Increase in the heart rate's not working.
Yeah, because our heart rate's already high, right? And if our heart rate's already high, then what's that doing to myocardial oxygen demand? It's already suffering. So do I want to give it a drug, even though it's going to raise the blood pressure, it's going to raise the heart rate and cause more oxygenation issues to the heart? Is that a good thing? It may be in some cases, but not necessarily. So I'm speaking in generality. It's probably not a good idea to give a tachycardic hypotension patient epinephrine on the surface. Unless they're anaphylaxis, then your first choice is epinephrine regardless of the heart rate, right? It just is. So there are exceptions to this rule, but just generally speaking. Why is the onset of action less than a minute? Because it's endogenous. Know that term. It's an endogenous catecholamine. You already have it in your body. So the receptors note it. They've seen it before 1 trillion times, and they know what to do with it when they see it again. So when you put it in the body goes like, yeah, I know what that is. Cool. This is what it's going to do. So the onset of action is immediate. And we know the receptors are all those. Now, be aware that epinephrine is a 50-50. It's a 50% alpha and 50% beta. That makes it a balanced vasoactive drug, doesn't it? But it doesn't necessarily mean there's one above the other. So that's something to think about. If I need just alpha constriction, say I've got a patient in septic shock, would epinephrine be the best pressor to use?
No.
Why?
It's gonna have base.
Well, it's providing alpha agonism, isn't it?
There's also affecting beta 2, which is the vasodilator.
It's also affecting beta 2, and it's not giving enough. There's a better drug. Norepinephrine does 90% alpha. So probably why that's the better choice in sepsis, right? Because of the mechanism of action in the receptors. What are the effects of epinephrine? We know. It gives us vasoconstriction when it stimulates alpha 1. When it stimulates beta 1 and beta 2, it gives us these things as well. And one thing really to note is that high doses of epinephrine can cause mesenteric ischemia, which is what? Shut down the blood vessels of your colon, right? And so that's going to be a problem. That's a huge problem. So we don't want that to happen. But that's not going to happen on our watch or in our time that we have the patient. Unless you're picking up a patient on high doses of epinephrine, it's really not a concern. We can't measure for it anyway. But just something to be mindful. Push dose. Now, for this class, I'm using SCCAD dosing things because most of us work at SCCAD, so let's keep it constant. So as you go through these slides, they may differ from the book. The slides are precedent, okay, for tests. The slides are precedent. So to ignore what the book says for dosing, just go with the slides say. So 5 to 20 mics, have you push your push dose. Epinephrine can be given either mics per kilogram per minute or micrograms per minute. So it can be weight-based or not. Usually you're going to see a weight-based in the hospitals. And here at SCCAD, we use the weight-based dose. But you can use it without weight-based, and I'll show you how in a minute here as soon as we get to it. There are times, actually, where you will see epinephrine as the primary drug. That's contraindicated and contradictory to what I just told you. Even in sepsis, can you tell me why that would occur? Why would you see epinephrine hung as you walk into your sepsis patient for a transfer instead of norepinephrine? It happens. One, physician choice. They may think that for this instance, I'm going to give epinephrine first. Gosh, there could be a dozen reasons why, but sometimes you will see epinephrine given as a first-line drug even when you suspect that it shouldn't be. I've seen it dozens of times. So just be aware of that. Epinephrine will also cause an increase in lactate levels. Have you ever heard that before? Do you know how that happens? When we get to shock, we're going to go through the Krebs cycle. Remember the Krebs cycle from high school? Remember glycolysis? Oh, yeah. Oh, yeah. We're going to go there, friends. We're going to go there, and you're going to have to memorize a lot of that crap. So just to give you a heads up, though, what epinephrine does is it speeds everything up, right? It speeds up heart rates, raises blood pressure. It also speeds up glycolysis. And the body doesn't like that. The body likes that circle to move at a certain speed. But epinephrine can't help it. It just speeds up the glycolysis. So what it does, it creates more energy through the ineffective route. And if you create energy through the ineffective route, you get lactic acid production, right? Anaerobic metabolism is cellular metabolism without oxygen, right? That's what's happening. Your body's not providing enough oxygen to the cycle. You're speeding things up with epinephrine, so it goes down the less efficient path, which produces lactic acid, which then breaks down into what? Lactate. That's why lactate levels will be elevated in your patients receiving epinephrine.
Is that why hyperglycemia is another side effect because of the lactic acid?
There you go. There you go. Same mechanism. Epinephrine is also very dose dependent. And what do I mean by that? Okay. So there are 3 dosing for epinephrine. We have a low dose, a middle dose, and a high dose. A low dose is your pushes for hypotension, right? 5 to 20 mics, right? You know how to mix that. We give that push, and that raises the heart rate and the blood pressure, right? That's a very low dose, 5 to 20 mics. And 1 vial of epinephrine for a code, that's how many mics? 1,000. So 5 to 20 certainly is a low dose, but it does a very good job of raising the heart rate and the blood pressure, doesn't it? Why? Because there's what they call right? Low dose. So even though it's an infusion, you can still have low dose epinephrine through that infusion. That's the dose range we start at here at SCCAD. Medium dose is you're looking for anaphylaxis. When we give 0.3 to 0.5 sub-Q or IM, that's actually 300 to 500 micrograms, right? We don't think about it that way, but I want you to start thinking about your drugs in that manner. That's a medium dose. That's far more than we're giving for beta-1 activity, right? That's a heck of a lot more. But guess what? Does it do frac? It doesn't. You know why? Because at that dose, the body recognizes and it hits the beta-1 and the beta-2 receptors. So now the beta-2 receptors can see it and they can act on it. And so what do we get? At that dose, we get bronchodilation, and we also, for bronchospasms, and we also get vasoconstriction at that dose. Okay? So what's that do? That increases inotropy and decreases afterload, which actually improves airway responses and the vasodilatory effects of the whatever shock they're in. Finally, we get to the high dose. This is what we're most familiar with as far as epi goes. In cardiac arrest, we give 1 milligram, right? Which is 1,000 micrograms. 1,000 micrograms in our abject. Or when we do a high dose epinephrine infusion, 0.1 mics or greater, which is, if you look at the decimal points, a heck of a big time, a lot different. From 0.01 to 0.1 is a big increase. So that's considered high-dose epinephrine. Surprisingly, the beta receptors don't see it. The beta receptors, the alpha-1 receptors see it. So that brings us to a question then, doesn't it? Why do we give epinephrine in cardiac arrest then? If the beta receptors, the heart receptors, don't see that dose in cardiac arrest, then why are we giving epinephrine at this dosage to people in cardiac arrest? It's not starting the heart because the heart receptors aren't seeing it.
Pressure, it increases the pressure in the body.
Okay, by how?
Vasopressure.
Yep. What's the two things that's going to restart a heart in cardiac arrest? There's only two. And epinephrine isn't one of them, guys. What is it? Huh? Well, no, good CPR and defibrillation. In order to facilitate that heart getting oxygenated enough to respond to defibrillation or to respond to good CPR, we need to get what to the heart? As much oxygenated blood as we possibly can. What epinephrine does at that dose is it vasoconstricts, is all it does. Shunting blood to the central, to the heart, giving it a chance to be oxygenated and to restart again. So how many times you've been on a code and you're like, well, that's the epi talking. Maybe, maybe not. Maybe, maybe not. Question for you. If we gave 5 epis throughout cardiac arrest and we got ROSC back at the 40-minute mark, that means we gave them 5,000 micrograms of epi, would you agree? Then why is their blood pressure 70/40? Why isn't every time we get ROSC back, their blood pressure is 2,000/1,000? Because yes. Their half-life of epinephrine and what else? The fact that it's hitting on which receptor? Alpha-1. Is it hitting on the beta receptor? Well, I'm not saying that it's not. It is, but not enough to be therapeutic. Okay? So now what do? We give them 10 mics of epinephrine, and now all of a sudden their heart rate is high? The only reason that can happen is because the right receptors now see the dose and respond appropriately to it. And the half-life, which is why we dose epinephrine every 3 to 5 minutes. Why? Because the half-life of epinephrine is what? 3 to 5 minutes. Right? So, okay, do you guys understand how epinephrine is dose-dependent and what's actually happening when you give epinephrine?
So if you had like a status asthmaticus who arrested and you got him back, like you started mag drip, but could you give a medium?
Heck to the yes. Heck to the yes. You absolutely can. It's not in our protocol to do so, but it's not wrong. But max sulfate's obviously going to hit better on where we need to go in that case. Yeah. Okay, how do we mix it? We can do the syringe method. I'm not going to read this. You guys can read it. We know how to mix epi. I just wanted to put it in here in case you don't. But does anybody not know that we can put 1 milligram of epi in a 100 cc bag? Are you guys familiar with that way of mixing?
I've heard of it, yeah.
Jacob?
It's like a dirty
Yeah, so what we do here at SCCAD, we don't really do the syringe method, except I will do it if I'm going to RSI somebody, and I keep it on hand if I need to give it after RSI and they go hypotensive, or if I need to treat just an isolated hypotension incident where I'm not going to hang an infusion. But generally what we want you guys to do is to put 1 milligram in a 100 cc bag. All right, and then what that's going to do, that's going to give you concentration of 10 mics per cc, which is what you were doing up here anyway. And then you pull 1 cc out of the 100 cc. We're going to talk more in detail about this. You pull 1 cc out of that bag, 100 cc bag, and give it at a time, that's 10 mics. Again, it's a low dose, so it hits on the beta 1 receptor, and it's going to raise the blood pressure or the heart rate, whichever you need.
So it's 1 to 1,000 though, it's not 1 to 10,000.
Well, it could be 1 to 10,000, it could be either one.
Okay.
And that's why it's called a dirty epi drip. A dirty epi drip isn't referred to the fact that it's clean or dirty. It just means that it's not entirely accurate. So giving a 10 cc bolus of the 1 to 10,000 code epis is actually adding 1 milligram to 110 cc's. So now the concentration is slightly off, isn't it? But do we care? No, of course not. We don't care. So they call it a dirty epi drip for that reason. Pharmacy cares and the ER cares, but because they would never do that. But we're sloppy paramedics, we can do that. But does it do the right thing? Yes, so we're okay with it. We can also put 1 milligram in a 1 liter bag. Not really done a whole lot, and that gives us a concentration of 1 mic per cc. So in order to pull out 10 mics, you pull out 10 cc's and give it, it's no big deal. Not really done as much, but you could do it that way if you want. Who's heard of the Hebby clock method? Hebby clock method? The difference there, if you want to do the Epi clock method, is you're providing an infusion without the weight. This is in mics a minute now. And you have to put 1 milligram in a 250 cc bag. Once you do that, you get the right concentration where now you can use the clock method. So 1 milligram a minute is 15 drops a minute. 2 milligrams a minute is 30 drops a minute, and so on. You can only get that right concentration, though, if you put 1 milligram in a 250. So at 2 in the morning, if you don't have a Sapphire pump and you just don't want to think about it, do that. Put 1 milligram in a 250 bag and run it at 1 drop every 2 seconds. That's 2 mics a minute, correct?
That's what I'm familiar with.
Yeah, and they're done. You've accomplished what you need to accomplish. So I want to put that in there. So if you guys don't know about the Epi clock, that's how you mix it and do it. But we have pumps here. Every transfer you run on will be on a pump, so that's not an issue for us generally. Know it, love it, sleep with it, live it. Because I guarantee you, this is going to be on your test. You will have to calculate an infusion using this formula because pumps break down. Pumps break down and we don't always have them available to us. So this will work on just about any infusion you need to do here in the class. It's the desired dose times the patient's weight in kilograms times the drip step you're using divided by the concentration times the time. The answer is always in drops per minute. This gives you the drops per minute. So let's practice. All right, we have a patient that needs an epi infusion, and by the way, write this into your slides. The answers will appear, but they're missing in your slides because I want you to write the answers down in your slides. So we need to administer an epi infusion at 0.05 mics per kilogram per minute. The patient weighs 157 pounds. What's my desired dose? 0.05. You got it. So that goes in the desired dose part. I'll wait till everybody gets there. Jacob, are you trying to get there? Yeah. Okay. I'll wait till everybody gets there. I'm sorry, I should have warned you. Some of these slides you're going to have to fill in. You don't want me to do all the work, do you? I mean, come on, seriously. To help them out, what page are you looking for, guys? I got it. Oh, you got it, okay. Okay, what's the kilograms?
71.
Good job. 71. Take the patient's weight divided by 2.2. You guys know that. What's our drip set?
60.
Always 60. Always the 60 drop. Well, not always, but you should use the 60 drop for infusions. Concentration. When we talk about the concentration, what are we talking about? The formula for concentration, if you don't know it already, is what? Milligrams divided by volume, cc's. So the total amount of the drug divided by the volume, so milligrams divided by milliliters, always. Okay? So if we're putting 1 milligram, which is 1,000 micrograms, in 100 cc's, always change it to micrograms. Why do we need to change it to micrograms? Because we're giving it in micrograms. So we have to convert it to mics. So 1 milligram is equal to 1,000 mics. I'm putting that in 100 cc's. I divide 100 into 1,000, and that gives me a concentration of 10 mics per milliliter. Does everybody see that? It's important you see that so we can move on. We can't move on until everybody sees that.
Okay, Brian.
Yep.
Sorry,
No.
I was writing, just
Yep.
say that last sentence one more time.
So we are putting 1 milligram of epinephrine in a 100 cc bag. We have to convert the 1 milligram into mics, so that's 1,000 mics.
Okay.
Now in a 100 cc bag.
Yes.
The concentration formula is drug divided by volume. Drug divided by volume. 100 going to 1,000 10 times, your concentration is 10 mics per milliliter. So that goes there on the concentration.
You could essentially put 1,000 over 100.
Yes.
And just multiply through to get the same answer.
Yes. Yeah, it could have. Now the time. The time is blank because the problem doesn't give you a time of infusion. It doesn't say give it over 20 minutes. So that's really times 1 minute. I left that blank. You can leave it blank. It's really times 1, which is now, it doesn't matter in the equation. So that's why time is kind of forgotten about. When you do that math, you get what? 21 drops a minute. Go ahead and do the math. Get your calculators out and just go through the process of doing the math so we make sure everybody can punch in numbers right. You can. You can. If you don't get that answer, let me know. Okay, now, how do we give 21 drops a minute? That's 1 drop every 3 seconds. There you go. I would round it to 20 and give 1 drop every 3 seconds. Done. Now I'm administering an epinephrine infusion at 0.05 mics per kilogram per minute without a pump, obviously. Everybody good with that one? We got another practice.
What's the unit of the 60 again? It'd be drops per
Drops per minute.
minute, right?
Yeah. Okay. Let's go. Let's talk. Is everybody done with that one?
Also, it's drops.
Only question I have, so on the top, I'm good there, with concentration, good there, what's the bottom time?
Times time.
Times time.
Yeah. If some problems will say, hey, give that infusion over 30 minutes,
Oh, okay,
then you put the time in. But since no time is given, it's left blank.
okay,
So it's there because it belongs in the equation, but there's no time in this problem, so disregard it.
okay.
It's really times time 1 minute, but 1 is,
So if
sorry,
Time's always in minutes.
time is always in minutes. Time is always in minutes.
you multiply,
But I'm not going to give you problems like that because that's a nursing thing and we don't care about that. And we have pumps. Thank you. So it's not going to be an issue, so don't worry about it. Don't stress out about the time part. All right, let's move on. So let's talk more about concentration. Question for you. If you've got a bag of D10, how do you figure out the concentration of that? They don't give you any mics or milligrams.
25 grams per liter.
Close. Do you know what the 10% means? The 10% means that there's 10 grams of dextrose in that solution. So now that you know that, now you can get a concentration. Because 10 grams is 10,000 milligrams, correct? I'm sorry, yeah, milligrams in 250 milliliters. Divide it, and now your concentration for that bag is 40 milligrams per milliliter. So let's do a D50. You have an amp of D50. Well, how much D50 is in that fluid?
50 grams.
50 grams, which is equal to how many milligrams? Which is equal to how many micrograms?
500,000.
There you go. That's it. That's all it's telling you. So I say that because on pediatrics, we don't carry D25, right? We carry D10. But in a pediatric patient, if I need to give D10 to a pediatric patient, the dose is 5 milligrams per kilogram, right? Well, how many cc's am I given? I don't know. If I don't know the concentration, do I? So that's why it's important to know the concentration of these kinds of drugs so you know about how much you're giving. It's 40 milligrams per cc. I figure out the dose, and I know how many cc's to give, right? Another way of looking at it, say what?
A pre-mixed bag of D10 is 25 grams, it's 21 grams per mil, right?
No, no. That's what, it blows your mind. That's what the 10% is referring to.
10% means number of grams in 100 cc.
Yes, yes.
Right, which is
So in a
25 per
250
bag.
bag, there's 25 grams.
Per 250, it's 25 grams.
Oh, wait a minute.
It's 10 grams per 100 mils. There's 25 grams.
Oh, shoot, I messed that up, didn't I?
I thought I was freaking crazy, dude. I was like, I've been giving.
Are you sure? Are you sure?
I'm 100% sure.
Are you positive? Okay, I'm wrong. All right.
I was like, I'm giving people 700 grams.
All right, fine, whatever, okay? I'm allowed to be wrong once a day.
I just thought I was crazy.
Okay, so fix your slide, okay, because I screwed that up. All right, fine.
He was just testing us.
I was testing you. Fix your slide, I apologize.
10 grams per 100 mils, there's 25 grams total.
All right, I got it, thank you, I got it.
Whenever you
Fix your slide.
I thought I was crazy, so I Googled it because I was like, wait a minute, I feel like I'm going crazy here.
All right, so tell us how we should fix the slide. So it should read 10,000 micrograms, it should read 25,000 micrograms. Should it? Is that what you're saying?
Correct.
Okay, so fix your slide, please. It should say 25,000 micrograms and 250 cc's.
So that's still is 40.
Yes. No, it doesn't. It equals 10, or 25, I mean, yeah.
Which is 10 per 100 mils.
No. Now change that 10,000 to 25,000 divided by 250.
Okay, because there's 25 grams of dextrose.
Yes, yes, yes.
There's 25 grams in
One,
Oh, but also,
So every 100 ml, it's 10%.
isn't there also 25 grams of dextrose in D50?
But it's
no,
not
I
in
thought the whole bag
250
was
mils.
10 grams.
So we did one more.
No, I was wrong. The whole bag is 25 grams.
Or
25 grams.
Same amount of
Wait, the whole bag,
Mhm.
It's 25 grams.
It's 25 grams.
25 grams.
Yeah.
For D10?
Yeah,
Okay.
because it's per 100 cc's. I messed up there.
It's just in more volume,
Mhm.
right?
Mhm.
Same amount of drug. and
Yes,
more-
same amount of drug, just in different volume. Sorry to confuse you guys. It happens every now and then. Okay, anyway, let's move on. So adenosine. So adenosine concentration is easier to figure out, right? 3 cc's per milliliter because it's 6 and 2. Would you agree? Is everybody caught up? Is everybody caught up? Okay. So the concentration is 3 milligrams per milliliter. I know I got that right. Okay. Now, the question is, how do we use that information to figure out a pediatric dose, right? And so what I do is, I'm sure you do as well, is we cross multiply, and then that gives you the amount of cc's. If you don't know that method, know that method, because we'll be testing on it as well. But you guys should know how to do that already. Does everybody not know how to do that? To cross multiply to get your cc's? So what I do is I take the drug over the volume, milligrams over cc's, the calculated drug versus the unknown volume. So 2 times 2.2 is 4.4, divided by that 6, divided by 6, and that gives you 0.7 milliliters. So if you don't know that, that's the way you should do it as well. And disregard the top part of that slide. I'll fix it for next class. I don't know what I was thinking. All right, so that really covers epinephrine, and that was a lot. So any questions on epinephrine?
You know what's interesting, Brian, is when you started to read that slide, you read it, and you got to the 10, and you sort of hiccuped, and you're like, no.
I knew in the back of my mind it didn't sound right. Yeah, I don't know. Okay, let's move on to norepinephrine, because that's only 1 down. We got more to go. Norepinephrine, all right. So, indications. It is a first-line pressor for distributive shocks. Obviously, right, because it hits on 90% of the alpha receptor. So, yeah. But it's also used these days as a first-line pressor for most everything else. Unless you need inotropy, like for CHF or heart failure, norepinephrine is going to be your first choice in most cases. Didn't always used to be that way. If you have a shock of unknown etiology, you just don't know what's going on, then norepinephrine is a good choice to use. Nothing wrong with that. Are there any contraindications? This really isn't a contraindication. It's just to be aware that we can wear out a receptor. Did you guys know that? You can wear out your alpha receptors and your beta receptors by hitting them with so much drug. It may be endogenous, and the receptors may know what to do with it, but you can actually wear your receptors out. And that's when they go to vasopressin a lot to hit on different receptors. So the only contraindication is if you see that there's desensitization or the pressor isn't working as well, and they're not acidotic, it's probably because you're wearing out the receptor. And that's called, whatever that's pronounced, tachyphylaxis, I think? Tachyphylaxis, maybe? No, it does. It does. Generally, it does. Just leave it at that until we get to shock. Okay, and again, the onset is quick. Again, like I told you, it's 90 to 10%. Peripheral vasoconstriction, that increases blood pressure. We all know that. You're going to hear terms like vascular tone. And when I say tone, I mean what? When it refers to a muscle, because remember, these are smooth muscles that it's working on. The tone is how floppy or springy that muscle is, right? So we have a condition called vasoplasia. Ever heard of that term before? Vasoplasia? Where there's no tone at all left in the blood vessel. And that's what septic shock leads to, where they dilate, the blood vessels dilate and basically die wide open. And so I don't care how much epinephrine or norepinephrine you give them, they're not going to respond all that well. And so we have to go to the bigger stuff. And so we can wear out receptors, and so that's something to be aware of. Hypotension, tachycardia, breathlessness are side effects. The dose, as we know, is 4 to 16 mics. It's given both the same way as epinephrine in mics per kilogram or in mics per minute. When you see it in mics per minute, it's normally commonly 8 to 12. So be aware of that. They don't start at 1. They go straight to 8. Typically, you see it around 10 mics a minute on average. But the infusion dose for epinephrine varies greatly, or norepinephrine as well, I should say. Norepinephrine can go pretty high. I wouldn't be surprised if you see norepinephrine sometimes really, really high, like up to 1 mic per kilogram a minute or even 50 mics a minute. However, studies have shown that when they do that to patients, it actually will decrease mortality in them. And they only go that high when there's no other choice. They've maxed out on everything. They can't max out vasopressin anymore. They can't max out epinephrine anymore. So norepi is the drug they kind of try to max out the most. But like I said, studies have shown that it's not always great, and it will increase mortality in some people. It has a short half-life, just like epinephrine does, about 2 to 4 minutes. So if you're giving it in ROSC, right, this is why we tell you in ROSC to start an infusion, right? Aren't we telling you guys that? We just don't want you to push doses in ROSC, because you know now that epinephrine or norepinephrine only lasts for less than 5 minutes. If you do an infusion, how long does that medication last? For as long as the infusion's going, right? So push a dose initially, get the infusion going, and supplement with push doses along the way, but get that infusion going. Get that infusion going. You need it. Okay, how do we mix it? We put 4 milligrams in a 250 bag. That gives a concentration of 16 mics per cc, and there's your dose range. There is also, believe it or not, a norepinephrine infusion clock as well. There's a clock for norepinephrine as well. It's already in a 250 bag, so this applies to the 250 bag. And there's your clock method. A little different than norepinephrine, but it's still the clock method. All right, let's practice this. We want to administer a norepi infusion of 0.1. Patient weighs 182 pounds. What's my desired dose? 0.1. I'm sorry, 0.1. What's my kilograms? 82, good. What's my drip set? Okay, and what's my concentration? Well, it's the same thing. It's the drug over the volume. We're putting 4,000 mics in a 250 cc. That gives a concentration of 16 mics per milliliter, right? So the concentration is 16. Times nothing. There's no time given. Someone tell me what the answer is for drops per minute. 30. There it is, 31. Close enough. So basically, one drop every 2 seconds. One drop every 2 seconds. Is everybody getting it? Because you better believe this will be on your test. You'll have to do this exact calculation for me. It's pretty easy once you get a few down. But you know what? Let's do something. Let us practice. So I'm going to put up a problem. You guys take the left one. You guys take the middle one. You guys take the last one. And we're going to do a race. And whoever comes up with the answer of your table first, raise your hand. And the first table raise their hand to get the answer right gets 1 point extra credit on their next exam. 1 percentage point credit. All right, so this is for real. All right? So there's your problems. I'm going to go back. You guys ready to go? Make sure everybody tells me they're ready.
I'm nervous.
So you guys do the last one. You guys do the middle one. You guys do the one on the left. You guys do the middle. You guys do the one on the right. You got it? Teams, you ready? By the way, does anybody have a team name yet? No. Okay, fine. All right, here we go. Go. Got to raise your hand. Okay, what's your answer? 4.5. Okay, that's fine. If they're right, they win. But you guys are still racing. So between you two. So are you rounding to 5, Tyler? Are you rounding to 5?
Well, if I round 4.
Round up, round up.
Then 5.
So your answer is 5, okay. So you guys are you done? What's your answer? Okay. See if they get an answer for theirs. 32. Okay. So they think their answer is 5. And yours was this one.
Ours was the middle.
No. Oh, yeah, yours is in the middle. You're right. I'm sorry. I was going to say you guys are way off. Okay. And then you guys said your answer was 13. And you guys said your answer was?
Not right.
You didn't say 51.
Yeah, that's it.
All right, do your problem again, all of you guys. See if you get 51. Or did I do it wrong? Because that could happen. Everybody check the last one. Make sure my math is good on the last one.
The concentration is where I get screwed up.
That's okay. That's what practice is for.
So we're taking the total amount of drugs, like,
Yep.
that we're.
That you would put in the bag.
Okay.
Yep. All right, someone checking my math on the last one? Okay, okay. I only make one mistake a day, trust me, just one. Well, no, I take that back, you have to calculate a map, 100% sure of that. So there are, and you have to calculate a Parkland for burn. That's 100% will be on your test. So we'll let you know what calculations are on the test. So this is not one of them for the FPC, CCPC, just for this class. And again, it's really moot point because we have pumps.
We get
But,
stagnant because we have pumps.
yeah, but I have to teach this so you guys know it.
So if we're, I got a question. If we're,
Oh, we already have a break.
we're just looking at this slide here, where, like, we just have this information, where do we get our concentration? Are we
Well,
always-
you know that always 4 milligrams goes into 250, 10 milligrams always goes at
That's what
100.
we always use. Gotcha.
Yeah.
Yeah, I thought we were doing leave up.
No, it's okay.
I got you, yeah. I tricked you, my work is done. God, we're actually behind too. I can't. We're only on dopamine.
I'm shocked at firefighters, we don't do shit.
I don't know if you, because this is technically overtime for me,
Yeah.
this is required.
Yeah.
I don't know if you have to sign off or if I just submit it to.
No, I'll get an overtime sheet so you can fill it in. Yeah, I forgot about that, but I will have one for you. Or what you could do today is just go to Becky's office and write it in. Don't want you to do that every day. It's just you in here. So whenever you do it, just put Becky's. Yep. Yep. And I'll make sure Becky's aware that's what's going on. So she's like, what is this? She'll know.
So you put 1 milligram into.
Epinephrine, 1 milligram into
100.
100 milliliter bag.
We're just going to use that as a standard for the class.
Gotcha.
Per 100 mil, yeah. We just skip dopamine then, if we're not gonna ever use it?
No, dopamine's next. Oh, can we skip it? Yes. No one uses it. No, it won't be on the test.
Cool. Woo! Will it be on the board?
Not likely. Not likely.
How many times you can?
Everybody hates it now, so.
There's just so many better things than, yeah.
Well, we'll learn it. It has problems. It has problems.
We used to always say, give this dose for kidney function, this dose
Yeah.
for
Yeah.
that.
All been
I thought
debunked.
that was all bullshit.
Debunked, yeah. Mostly debunked. It's true, because it has receptor agonism like epi does. It actually does. It is dose dependent. But most of that's been debunked as far as the effects of the positive stuff it was supposed to do. But it does operate on different receptors.
So if we were to do an epi dose, epi drip for an arrest,
Yeah.
right, like they're still dead.
For
we do
ROSC.
Epi dose, you would.
No, I'm not saying do it in cardiac
No,
arrest.
but people have been talking about doing an epi drip for arrest recently, been going around.
Yeah.
And I was thinking about, you have to do a really high dose of epi drip to do that, right?
We were talking
No.
about doing a lower dose because we already
Yeah.
give
You would want
the
to
code.
you would want a lower dose because what you're counting on is that your rhythm you see is not PEA. It's actually a perfusing rhythm that you can't palpate a pulse on. That's
Well, I thought
why.
when they're in a systole, you just give them like.
There's no benefit. There's no benefit. No, you wouldn't do it. There's no benefit to it.
Someone doing continuous epi infusion on the entire code.
There's no benefit to it. They studied it.
Isn't there studies going on that prove that epi could just go away?
Yes. That's why AHA calls epi like 2C or something. Like maybe beneficial, probably not.
Did we ever trial different pressors? Like,
Yeah. Well, do you remember in 2015 when we had vasopressin and it was given for the second dose instead of the second epi? Were you guys in EMS back then?
I thought it was the first line.
No, it was the second. You gave epi, then you gave vasopressin. And I thought that worked good, honestly. But then they took it away because another study came out and says, there's no benefit. Well, yeah, there is. Because we're the only thing that's doing in cardiac arrest is vasoconstriction. And that's what epi is doing in cardiac arrest. So maybe there wasn't a great benefit to it. But once you get ROSC back, I think there's a great benefit to giving vasopressin.
We also did the ET2 tower thing.
Oh, yeah, the impedance device, which is now starting to come back around. Have you noticed that? It is. Are we back?
Oh, we
Right.
had this like stack of crap on the ET2.
Yeah, we had an impedance device, a filter, and
And a filter.
Who
and
knows what
something
else.
And then mine, like,
it stood like this tall.
you had to hold ET till there was a
Yeah, yeah. It would flip around like this when you did CPR. It was funny.
give the patient a head injury.
All right, dopamine.
A lot of silly things.
Okay, indications. Really, the only thing dopamine is left for is bradycardic shock. That's all it's given for. And it's only given in the CCU. You're not going to see an ER hardly ever give it or an ICU patient on it. You're just not. And when they get to CCU, they may be put on dopamine. I'm not saying you won't ever see it, but it's pretty rare. It causes tachycardia. Not just that, but it causes tachyarrhythmias, they're finding. And so that's like no bueno on a patient who's in the CCU for them to have some tachyarrhythmias. Caution when given for patients with left ventricular outflow obstructions. We'll talk about those later, like HOCM. When we get to cardiology, we'll talk about that kind of stuff. Again, it's an endogenous catecholamine, so the onset is quick. And it hits different receptors at different dosages like epinephrine does. All this is in your slides. There is no push dose. The infusion dose is always 2 to 20. We learned that in medical school, 2 to 20 mics per kilogram per minute. A lot of pearls here, but we don't really care. Like I said, it's got different dose ranges and it does different things. But it's shown to have bad outcomes in septic shock, so it's never given for septic shock. Unless maybe it's a severely bradycardic septic shock, which is not likely. The SOAP-2 trial in 2010 studied patients on norepinephrine versus dopamine in the ICU and found that patients on dopamine had worse outcomes and higher incidence of arrhythmias. So that's the actual trial that says dopamine is no longer good. From after that trial, dopamine started having a quick decline to where now it's crash and burned. So simply put, dopamine was harder on patients than norepinephrine, so it's gone, it's out. Okay, isoprel. We got to kind of speed up because I'm behind. Isoprel is, what I say about isoprel when it involves the beta receptor. Loves it. Very high affinity for it, right? What do I mean by affinity, right? What about carbon monoxide? Why do people die from carbon monoxide poisoning? Because hemoglobin loves carbon monoxide 100 times more than oxygen, believe it or not. So that's why you die from carbon monoxide, because the carbon monoxide fills up the hemoglobin and oxygen can't occupy it. That's affinity. That's what I mean by affinity. So the beta blockers love isoprel like that, except the good news is isoprel doesn't kill you. So isoprel is given with symptomatic bradycardia, but especially in beta blocker overdoses, because it reverses that beta blockade like a big dog. So it's really only given for those instances. It is also given in heart transplant patients as well, because they lose their vagus nerve. Did you guys know that? In a heart transplant patient, the vagus nerve is deinnervated, whatever that word is, basically no longer functional. So they don't have that side of the sympathetic nervous system to work for them. And so they'll give them that if they need to for those kind of patients. But you will get tachyarrhythmias because of the beta agonism is so high. Sometimes it'll cause tachyarrhythmias, so be careful. Onset is quick, beta 1, beta 2 stimulation. There is no push dose, and that's your infusion dose. Very, very potent. I've never seen a patient on isoprel. Has anybody here actually had a patient on isoprel? Pretty rare. But when they're on it, now you know why, right? It's a very potent beta agonist, and they obviously need that help. All right, so let's go on to the second class, which are vasopressors, and they're pretty easy. Vaso is blood vessels, and pressors means constriction. So the only thing they do is what? Clamp down blood. So is there any heart agonism at all? So is there any beta activity at all? No, none. This drug only goes to the alpha receptors. So that's what makes them highly skilled in raising the blood pressure by clamping blood vessels alone, which increases SVR, which increases blood pressure, right? So these are the drugs like phenylephrine, vasopressin, angiotensin II, and methylene blue. So those are your next four. It never ends, I know. Let's talk about phenylephrine. Okay, phenylephrine is given for severe hypotension. It's not a first-line drug. It's not a first-line drug. It's used as a rescue vasopressor to stabilize the crashing BP. I've seen ICU given it tons of times. I've given it dozens of times in critical care transports. When I've had pressure that's bottomed out for whatever reason, probably because I gave fentanyl and Versed and I shouldn't have, and bottomed the pressure out. Yeah, it happens. I'll reach my phenylephrine and again rescue the blood pressure almost immediately. It's an awesome drug. It's an awesome drug. But dose it appropriately, right? So more is not better here because it's such a potent alpha constrictor. Remember, the alpha receptor loves phenylephrine so much that the agonism is such a high degree that you want to give it at the right dose because you are clamping everything in the body down. Everywhere there's an alpha receptor lives is going to clamp down. So that's a contraindication. As a result of it, you can get a reflex bradycardia. It's very important you know that. Phenylephrine will cause a reflex bradycardia in certain instances. So you got to be careful of that and recognize that. So we obviously are not going to use it on patients who are already bradycardic.
So, I have seen nephrin given in, like, for SVT.
Oh, we're going to touch on that.
Okay.
Yep, we're going to touch on that. Okay, the onset of action is very quick, and its half-life is very long. So that's another good benefit of it. The half-life is 10 to 20 minutes. But it's very quick acting, and let me tell you, it really is quick acting. Next time you take a blood pressure again, you're going to see result. It's a pure alpha-1 agonist. It's extreme vasoconstricting, so it's going to reduce blood flow to organs. So you can also get that mesenteric ischemia. It's pretty common with this. It may also worsen myocardial ischemia. So if I got a patient with a STEMI, right, who's hypotensive and cardiogenic shock, is this the best drug? Absolutely not. Absolutely not. So it's not used for every single patient in severe shock, for sure. But those patients that will benefit from alpha constriction, for sure. The dose is 50 to 200 mics a minute. IV push. And there is an infusion dose. It's 10 to 200 mics a minute. Very rarely will you see neosynephrine and phenylephrine as an infusion, but it can happen. If you do see it, it'll be about 50 mics a minute. So what Russ was saying is in the pearls here. So it's primarily used as an adjunctive agent. So if it's used as an infusion, it's only as a very last resort due to the systemic vasoconstriction. However, there's evidence that phenylephrine can be indicated with patients with HOCM, right? And so that goes along with what you were saying, is for some kind of obstructive physiology in the heart. Because does everybody know what afterload is and preload? We're going to talk about that in great detail in hemodynamics, but what afterload simply is the amount of pressure the left ventricle has got to pump blood against, right? Which is your systolic BP, right? That's afterload. Well, if I clamp down all my blood vessels in my body, my arteries, what did I do to my afterload? Does it increase or decrease afterload? It increases. So because when you clamp down the blood pressures, that raises the pressure in those vessels. So now the heart has got to pump against greater pressure. So it increases afterload, causing the heart problems. But you would think that would be a bad thing, and generally it is. But patients with HOCM have a decreased surface area inside their left ventricle, right? So this is beneficial to them because what that extra pressure does is it translates back into the heart and widens those chambers now, that extra pressure. And so actually, in a weird way, phenylephrine for patients with HOCM, which is hypertrophic obstructive cardiomyopathy, so they've got enlarged heart, but a reduced lumen of a left ventricle chamber, will benefit because it increases the diameter of that chamber because of the increased pressure. Kind of weird. But that may be because something going along with the SVT question. Other than that, I don't know much more about giving phenylephrine SVT, Russ. But you've seen it given?
Yeah.
Maybe they had HOCM. I don't know. Maybe they had HOCM or some kind of aortic stenosis is another reason why you would give it as well. But again, the increased afterload expands the area around the heart and increases blood flow and actually increases cardiac output. So that's kind of neat. This is your pearl. How do we mix it? It comes in 10 milligrams in 1 cc vial. And so we'll take that 10 milligrams and put it in a 100 cc bag. So that gives us what? That gives us 10,000 micrograms, right? In 100 cc's, would you agree? If it's 10 milligrams, it's 10,000 micrograms, right? Put that in a 100 cc bag, that gives us a concentration of what? 100 mics per cc. So now we can pull out of that bag, pull out 1 cc and give that, because remember the dose is 50 to 200 cc's each push. Pull out 1 cc, give it as a 100 mic push.
You said it usually comes in like a 100 or 300?
It doesn't come pre-mixed, it comes in a vial of 10 milligrams and 1 cc. And you have to.
They run around with this in a vial and you
Oh, no, they carry sticks.
Oh.
They carry phenylephrine sticks, which is 10 cc's and 100 mics. 100 mics and 10 cc's. Or 200 mics and 10 cc's. But we don't carry those in EMS. Only the hospitals have those. So we would have to mix it. And in the critical care, in our critical care green bags, we carry phenylephrine. And it's a 10 milligrams of 1 cc vial. And I will mix it up and give it whenever I need. I've done, like I said, dozens of times for different patients, and it works really well. Again, you can pull the push doses out of the medication bag. I've never hung an infusion, never had to. The push doses do awesome. Okay, let's practice this. So what is the desired dose? 40. Now, do we need to worry about the kilograms? No? Why not? Because the dose is in mics per minute. So we don't have to worry about the kilograms, the NA. We don't care about how much the patient weighs. It's not weight dependent, right? Everybody see that? Okay. So then it's just 40 times 60. What's the concentration? We already told you it's 100 mics per cc, so that's 100 there. There's no time. So what's the answer? 24. So make sure you guys can do that on the calculator. And that's it. So that's basically one drop every 3 seconds. Rounded to 25, or I'm sorry, rounded to 20. Yeah, 20. It's one drop every 3 seconds. Okay? Cancel out the zeros for that one. That's an easy one. All right, vasopressin. Vasopressin is given as a second line for sepsis. Why? Why?
We want to keep the water in the body and support the blood pressure.
Okay, because it acts on a different receptor, right? We don't want to do receptor fatigue. If we did epinephrine second, we could. But we're really going to hit on the alpha receptors and the beta receptors pretty hard by giving escalating doses of those drugs, right? So what they'll do is they'll use vasopressin as a second or the third line therapy to reduce the exposure on the receptors to utilize, to maximize that receptor efficiency. Okay, because I'm telling you, receptors will burn out. So that's something you got to consider when you're hanging these. Well, we don't hang them. The doctors hang the medications. We transport them. But something to be aware of, if your patient, you arrive on the scene of a transfer and they've got 3 pressors going and the pressure is still 80/40, you got to ask yourself, Doc, do we have receptor fatigue here? And what can we do? Can we hang some vasopressin if you don't already have it going? Get another receptor active to help that patient. And I can't tell you how many times. You guys have probably seen them. Most patients I go on the ER, they're hypotensive. I don't know how it happens. They either have no pressors on or they have a pressor on at the inappropriate dose. It happens all the time. So you guys need to be aware of this kind of stuff and know what these drugs do and when. Contraindications is severe hypertension, right? Obviously, we wouldn't do it for severe hypertension. Onset of action is a little bit slower. Why? Because it's a hormone. Vasopressin, ADH, is a hormone. It's not a catecholamine. So the hormone's going to take a little bit longer to get going, but once it does get going, it's going to get going pretty good. So that's why the onset is 5 minutes instead of a minute. It's a pure V1 agonist, has no beta effects at all. It helps the body to retain water, as we know, and vasoconstriction, thus increasing blood pressure. There is no push dose for vasopressin that I'm aware of. And vasopressin is given in units. Now, why is it given in units and not micrograms or milligrams? Because it's a hormone. Very good. So insulin is given in units. What else is given in units? Heparin. What else? Right? So all those different things that are not catecholamines, but they're hormones that we provide our patients are given in units. Vasopressin is one of them. So, but this has a very narrow range. 0.01 to 0.04, you would think that's very narrow range. Let me tell you. Are you guys familiar with the Richter scale as far as earthquakes? A scale 5 is like 10,000 times worse than a scale 6. You guys are aware of that? So it's the same thing with vasopressin. A 0.1 to a 0.2 is like a massive leap. So they won't ever go above a 0.04. They will sometimes, though. They'll go to maybe a 0.06. I've seen as high as 0.08, but this lady was on death's door. Had 4 different vasoactive medications, and they were desperately trying to save her. And she ended up passing right when I got to Barnes South with her. Just couldn't rescue her blood pressure. Maxed out on everything. So she was on a 0.08. Very rarely we see that. Their max really is supposed to be 0.04. But in a desperation, Hail Mary, they'll bump it up to 0.06, 0.08 as well. It's not titratable. So whenever you pick it up, this is not a medication that you are going to titrate en route. Everybody say that back. You're not going to titrate en route. You're going to keep it where it is. The epi drip or the norepinephrine drip that's also hanging with it, because remember, this isn't a first-line drug. It's a second or third-line drug. So you've got epi and norepinephrine hanging first. That's what you're going to titrate. This you're going to keep as is. It has a very long half-life, again, because it's so doggone potent. It's not a catecholamine. It's a hormone, like we said. It's not sensitive to acidosis, which is a good thing. Oh, it also assists the coagulation cascade by releasing factor VIII. We're going to talk about the coagulation cascade in detail in trauma, but just so you know. Oh, and then, and like I said, in 2015, we had vasopressin and cardiac arrest, but then they took it out. The AHA took it out in 2015. All right, angiotensin 2. So this is the RAS system, the renin, angiotensin, aldosterone system. Okay, it's a big word. Basically, it's a system that utilizes the patient's kidneys and different organs to regulate sodium levels, which is also going to regulate what? Thank you, water levels. To keep water on board more instead of peeing it out, because wetter is better. Okay? It involves 3 hormones: renin, which is produced by your kidneys, angiotensin 1 and 2, we're going to talk about where this is produced, and aldosterone. RAS is automatically activated in your body every day when you go through a shock state as it responds to hypotension. If you become hypotensive for whatever reason, anaphylaxis, sepsis, your body, that's your body's mechanism, one of the body's mechanism to rescue your blood pressure on its own. And it's a normally occurring thing that happens. What happens is, and I'm not going to test you on this process, so don't memorize it. Just for familiarity, step 1, the kidneys release renin. So we'll start here. You got low blood pressure, go to the top. Your kidneys release renin, which is a hormone. When renin is released, it interacts with angiotensin, which is in your blood. That converts all that to angiotensin 1, which isn't doing anything yet. We're waiting for angiotensin 2. Angiotensin makes the way to the lungs, and then it releases ACE. What does ACE stand for?
Angiotensin converting enzyme.
Yep. So it's an enzyme that's kept in your lungs. I don't think it's produced in your lungs, at least it's stored in your lungs. It's released and mixed as the blood passes through your lung capillaries, and ACE is released as well. It's mixing with angiotensin 1, and that's what creates angiotensin 2. When we get to hypertension, we'll talk about ACE inhibitors, right? But we'll talk about that when we get there. Angiotensin 2 now will go and stimulate your adrenal gland to release aldosterone, which is going to help keep the body retain sodium. If my body is more salty, what does that mean about water? I have more water. Okay? So it's going to make my body more saltier. It's going to help me hold on to water. Because remember, water follows sodium. So if sodium goes up, water retention goes up, right? And then also, it's going to have vasoconstriction properties, and eventually it's going to increase BP. Don't have to memorize that, just so you're aware. That's how it works. Kind of interesting, really interesting way your body protects itself. Hypotension is refractory to other vasopressors. It's not given. I've never seen it given. I've never transported it, but it is out there. It's pretty rare to give because it's very expensive. It uses very different totally mechanisms, the AT mechanisms, or receptors, I should say. Contraindication are blood clots, and I can't remember why. Maybe I talked about it in the pearls. Let's see. Onset of action is pretty quick for this one. We know it works on the pathway. It increases BP by vasoconstriction, water retention. Oh, that's why. Because the side effect, it'll cause increased platelet aggregation and increase the likelihood of thrombotic events, right? So if they already have a history of PE or DVT, we don't want to worsen that. So they're going to stay away from angiotensin 2. It's given as an infusion. Now this drug is so potent that look at what it's using. Nanograms. Nanograms. Just so you know, 1 nanogram is equal to that many micrograms. Super small dose. So potent. And it's very pricey. It's $1,500 each dose. So, I mean, that's expensive when it comes to vasopressors.
You said you've never seen it used?
I've never seen it used. Yeah, not yet anyway. Maybe one day will come where I'll see it used. I've never seen it used yet, but it's very pricey, and it's a little bit goes a long way, obviously. But it's given, when I told you about the receptors are exhausted, they'll reach for this. When you finally get to the point where nothing's working because the receptors are just hit and bombarded all day long with this infusions they're giving, they'll turn to this, which is probably why I've never seen it, because I haven't had that kind of patient yet, I don't think. Okay, so moving on to methylene blue. Who's seen methylene blue given? I've seen it given once. On a 911 call, I had a patient who took sodium nitrate as a suicide attempt. And let me tell you, freaking scary. Freaking scary to see. Severe hypoxia, low SpO2s, gray in color. He got it on the internet because it's used in food, meat preservation. And he got onto some website and got it and took like spoonfuls of it. And then decided to call 911. Severe, I've never seen anybody so severely short of breath. And it was a scary thing. And when I recognized it and called ahead to the health center, because it was in St. Charles, I said, get the methylene blue out now. And as sure as crap, when I got there, it was out and ready to be given. That was impressive. And he got it and survived. Yep, so that was like amazing. But I knew about it. I knew the guy was in methylglobinemia. And so what happens is this sodium nitrate will affect hemoglobin. And it'll damage them so where they can't hold O2. And so you've got red blood cells carrying hemoglobin, but no connection with O2. And so you're severely systemically hypoxic. Nothing you can do until you reverse that condition. You can throw all the oxygen in the world, doesn't matter. And that can get oxygenated. So do you need this kind of drug? And he was able to get it. Also, metformin poisoning. They'll need this drug as well. No contraindications I know of. It works really fast. What it does, it works with nitric oxide. And nitric oxide works well with your smooth muscles in your body. And that's why, doesn't Viagra and Cialis utilize nitric oxide? Is why, I think that's how it works. It uses your nitric oxide stores to vasoconstrict blood vessels so that those drugs will work in that manner. But anyway, it works with nitric oxide in your body. So we'll reverse vasoplasia. Remember I told you that vasoplasia is like the loss of control of the smooth muscle. It's like permanently dilated. There's nothing we can do. Methylene blue will fix that condition. And also will fix the hemoglobin that are affected by the sodium nitrate. It will give you blue-green urine. And it's really it's funny because it comes out and it's blue-green. The medication is actually blue-green, like the ocean. It's a really pretty color. And it infuses in like that. It's like watching one of those Marvel movies where they, which one am I, you know what I'm talking about. I can't remember which one.
It's the boys.
The guy that wears the red suit. What's the Marvel movie I'm thinking of? No. The superhero guy.
Superbad, or not Superbad.
No.
Iron Man?
No. What's the other one?
Deadpool.
Deadpool. Thank you. Deadpool. Remember how he goes in that room, they give him all that stuff? Yeah, it was methylene blue is what it was. Anyway, okay. So there's your infusion dose. 1 milligram per kilogram over 20 to 60 minutes. You can't repeat it. And it treats methylglobinemia, which is a dysfunction of the hemoglobin that affects the iron, to be exact. And you need the iron on the hemoglobin to work to attach the oxygen molecules, right?
Don't they give that in cyanide overdose or cyanide poisoning?
Yes. No, you think of hydrochloroboxamilabin, that thing. That's what you're thinking of for cyanide.
Well, you used to have these, back with the Tylenol, they had these cyanide kits, and they had...
Yeah, it's
They had
hydrochloroboxamilabin.
amyl nitrate and methylene blue.
Oh, I didn't know that.
Well, they're supposed to have amyl nitrate, those were all gone. But
Yeah, I didn't know they had methylene blue too.
I think, maybe it's because of the amyl nitrate.
Well, that's what they turned into. I'm kidding. That's blue, man.
Which is really cool.
But if they overdose on this amyl nitrate, which is what my guy did, but also nitroprusside, which we'll talk about a little bit later, and nitroglycerin overdoses, because what? Nitro, the nitric oxide, right? So that mechanisms will cause a cyanosis and a refractory hypoxemia. And I'm going to tell you guys, we had him on a non-rebreather and a nasal cannula, and I couldn't get his stats above 70s. I mean, refractory hypoxemia. It was scary. I thought the guy was going to die on this, but he didn't. They're supposed to get brown chocolate blood. That used to be a board question, so keep that in mind. It used to be on the boards, but I don't think it is anymore. But super high levels of this drug will cause you to turn blue. It's not permanent, thankfully. So, all right, do we need a break, or can we push through a little more? What time is it? Okay, we're on the track to get out here a little bit early if I can keep going. Are we good? Because I'm over halfway through. Inodilators. So what does ino mean? Well, ino is inotropy, and dilators mean the blood vessels, instead of constricting, dilate. So these types of drugs work well for sick hearts because it increases contractility, but they will also dilate blood vessels. The reversal from the inoconstrictors, inodilators. So primarily they're giving for what? Heart failure. Now, the side effect is they're going to dilate blood vessels, so we need to be careful about that, right? So how do we respond to that if that happens? If we give dobutamine for the heart failure patient, increases contractility, but now we lower their blood pressure, how do we respond to that? No? We put on norepinephrine. So you're going to see dobutamine paired with norepinephrine and epinephrine commonly to either combat the hypotension or to make sure the hypotension doesn't occur. So they'll be partnered together. But the two drugs that are antidilators are dobutamine and milrinone. Okay? Dobutamine is given for cardiogenic shock or low ejection fraction. That's another hemodynamic term we'll talk about in a few weeks. Heart failure. Obviously, hypotension is a contraindication. It works quick. It works on beta 1 and obviously beta 2 because it lowers the blood pressure. Vasodilation. Effects of, it lowers the blood pressure. It's a great inotrope, which means it has great contractility properties. It's beautiful to get that heart going again. There will be some vasodilation. It's not every single time. You may be lucky and not get vasodilation or hypotension, but it could happen, so be aware of it. We carry dobutamine in critical care here at SCCAD. So we have it on the trucks. Very rarely do we give it to a patient because if we arrive on the scene of a patient that needs dobutamine, they've got it. Or they're on an epi-drip. Either way, I know something, right? So they're getting the INO properties they need. But we do carry it here at SCCAD just in case we need to put it on. Again, no push dose and the same as you learn in medical school.
So why does it lower the blood pressure?
Because of the beta 2 agonism, which causes vasodilation. So it hits on beta 2. We don't want it to, but just the chemical makeup of the drug, it's going to hit on beta 2 receptors with the beta 1. It's going to hit on both betas. It is what it is. So it will drop afterload, which is good because if I've got a sick heart, isn't it a good idea to lower the pressure that sick heart's got to beat against? Yeah, that's what afterload is. So that's why it vasodilates, right? Isn't a vasodilating property going to lower afterload? Yes or no? Yeah. So in the end, it's a good thing. But it's not a good thing if it lowers the blood pressure as a result of it, vasodilation, right? So something to keep an eye on. But it's a good thing that it's doing that. It's not like it's a bad thing. That's going to increase cardiac output because it's going to provide the heart to beat as good as it can against reduced pressures. That's okay. We like that. So it's good for bradycardic, hypotensive, cardiogenic shock, and heart failure. So they're not afraid to give this if the patient is hypotensive. If it happens, what do? They put on norepinephrine. Right? Or they just put norepinephrine on at the beginning. It is dose dependent. I won't test you on these dose dependent things. But just be aware of it is dose dependent and it's going to hit on different receptors at different times. Actually, for dobutamine, it's not the fact that it hits on receptors, it's that how it affects the heart rate. So on a low dose, it's going to have very slight effect on the heart rate. At a moderate dose, you're going to see a noted increase. At a higher dose, you're going to have a risk of tachycardia because it's going to really increase the heart rate. So the dobutamine works a little different than the other drugs that are dose dependent, but it is dose dependent.
If you're going to start this in the field, you need 2 pump sets.
Yeah, because I'm worried that I'm going to drop the pressure. But you really don't need 2 pumps. I would just rescue it with phenylephrine, or if that's going to be too much for him, norepinephrine with pushes. Okay, milrinone is a little bit more potent of a beta 2 agonist. It's really given for left diastolic heart failure. I've never transported with milrinone. You see it in the CCUs, the thoracic ICUs, for patients who are really in there because their heart is like dead, waiting for a balloon pump or an Impella or something, But it's given for that. 5-minute onset. Okay, we can go through all that. Nope. Oh, there is a push dose for that, and it does have a weird kind of infusion rate dose. I won't test you on that. Milrinone beats dobutamine in patients with early stages of cardiogenic shock because it's a really good inotropic agent. And it has reduced vasodilation when compared to dobutamine. So maybe we should carry milrinone instead of dobutamine. Okay, finally, the last one is vasodilators. And I'm sure you can figure out that vasodilators work on blood vessels, right? And they're going to do nothing but dilate the blood vessels. Okay, so there's no inotropic support, right? It's just vasodilators. Now, keep in mind that vasodilators work on all types of blood vessels, capillaries, veins, and arteries. We like to think that vasoactive drugs only work on arteries. It's not the case, especially on these types of drugs. So there's a lot of venous effects and arterial effects we'll talk about. But there's no beta activity at all. It's all alpha stimulation. So your nitros, your sodium nitroprussides, and your nicardipines. So nitroglycerin, we're very familiar with nitroglycerin and why we give it. Now, it has two mechanisms. It does hit on the veins, so it decreases preload, and it also hits on the arteries, and it decreases afterload. Okay? Remember, it's a vasodilator, so it's going to dilate the veins, which is going to provide less preload to the heart. Sometimes we want that. Or it's going to dilate the arteries, right? And that's going to provide less afterload the heart has to pump against, right? Which is another mechanism we would like nitroglycerin to do. We'll talk about when we would do what here in a minute. So it's a potent venodilator and a potent vasodilator of the vascular smooth muscles in veins and arteries. Okay, the push dose is really like the spray or tab we give, the 0.4 milligrams, right? That's kind of like the push dose. That's basically 400 mics. Now, the dose of a nitroglycerin is very dose dependent. A lot of medications, these medications are, aren't they? So at a low dose, 5 to 400, and remember, 400 mics is what we give in the spray or the tab, right? So that's a 5 to 100, I should say, is the venodilation effects, right? So when we give that tab of nitro in the ambulance, we're targeting the veins, right? We're targeting the veins. We're targeting the preload effect of it, right? And so and when we give it above 100, though, then we have arterial effect, right? And so that's going to work more in the arteries. Nitroglycerin is a nitrodilator, so it, again, affects the nitric oxide. Another pearl is, why is nitro always in glass bottles? Because it'll leach the plastic. So of all the medications, nitroglycerin is always found in nitro because the nitro will be absorbed by the plastics, and it decreases the efficacy of the drug. Okay?
So what would you start a dose at?
Well, that's a good question. If I had a nitro infusion, I would want to know why they're on it. So are they on it because they're having an MI? Well, that's going to be a lower dose. But if they're on it because they've got, I don't know, what was some of the other indications that we talked about? CHF, pulmonary edema, angina, those are going to be much higher doses of nitroglycerin. Oh, you have a question? So it matters. But I really wouldn't want to see a nitro drip less than 100, honestly, if coming from the ER. They generally need to be about 100 or higher. You're generally going to see them 100 or higher. If they're under 100, I'm kind of asking why. Why is the patient getting less than 100 mics a minute? So just so you know, as a standardized dose, an infusion, 100 mics a minute or higher is what you're looking for and what you're traditionally going to see. Because we don't put people on nitro drips that are having heart attacks, do we? Right? So there's no point in doing a less than 100 dose, right? For that reason. We just give them tabs, 3 tabs, right? And then we're done, right? But if I need to put them on a nitro infusion, there's a specific reason for it, and I need to be at a higher dose for it to be effective, right? So we're talking the 100 to 400 dose. We need to be that high. But I can't remember last time I transported someone with a nitro drip. It does happen, but it's pretty rare anyway. But just so you know, the dose effects and the dose ranges. I feel like, well, we'll talk more about nitro when we get to cardiology. Sodium nitroprusside is another drug that I have never seen, pretty rare. This is given for profound hypertension with signs of end-organ dysfunction, so like end of life, almost dead kind of thing, which is probably why I've never seen it. I'm sure in the ICU it's given quite often, but as far as transport environment, we don't see it. But the problem with sodium nitroprusside is you must have a central line, and you must have an arterial line as well to monitor blood pressures through this, because it is a very potent medication, and you can overshoot, and you do not want to overshoot this drug. It is very potent. It's a very fast onset as well, which makes it a little bit scary to give. But what it does, it goes, when it hits your body, it just like releases nitric oxide like you wouldn't believe. It just massively, like a bubble effect. So it just bubbles nitric oxide everywhere, which is a very potent arterial venous vasodilator. So it dilates arteries more than veins, which makes it even more dangerous, right? And then a side effect could be profound hypotension. And this is like refractory hypotension. If you drop someone that low sodium nitroprusside, good luck getting them back, because how are you going to fix that nitric oxide problem, right? So that's the issue. So it's a very scary drug to give. You don't see it given much often. I've never seen it. I've never transported with it. You can try phenylephrine, but you're not fixing the problem with the nitric oxide. So it can be a problem. Low dose range, obviously. So as I said, it's a very strong smooth muscle relaxer or vasodilator. Last one. What time is it? Ooh, we're doing pretty good. I'm not going to get you out of here this early, but we got stuff we can do. But okay, nicardipine. All right, let's talk about nicardipine. So nicardipine is given for aortic aneurysms, like Dr. Tan talked about earlier, and CVA. You're going to see it a lot, especially with aortic aneurysms. When you get to vascular later on in the course, when you talk about our aneurysms, our dissecting and our aneurysms, the ERs out here transport on esmolol, but they also transport on nicardipine. Why? Does anybody know why we have both? Dr. Tan mentioned esmolol, and he's right. We definitely need esmolol. Let me ask you this. Let me put it this way. If a patient has an aneurysm or is dissecting, doesn't matter, which is worse on that aorta? The sheer force of the pulse, heart rate, or the high blood pressure that's occurring? Which is worse on the artery? The force. The force of contraction is worse than the high blood pressure. So that's why Dr. Tan mentioned earlier esmolol for sure. But they're also going to be in a nicardipine to help the blood pressure. Now you say, isn't esmolol a beta blocker and it handles both heart rate and blood pressure? It does. But you're not going to titrate the esmolol in response to high blood pressure. You're going to titrate the esmolol in response to what? Heart rate. So if my patient's heart rate is 100, I need to titrate my esmolol down to a heart rate of what? 60. I don't care about the blood pressure. If my patient is also hypertensive, how do I deal with the blood pressure? Nicardipine. And so I titrate the nicardipine. If my heart rate is 60, but my blood pressure is 180 over 110, I'm not titrating esmolol because I don't want the heart rate to do what? Drop. Hello? Right? So I need to have both agents because they both do different things. So if I titrate the esmolol, heart rate's going to go down, so I need to put a nicardipine on and titrate that to get the blood pressure down, the esmolol to control the heart rate. Okay? So that's very important. So nicardipine is a very common drug out here in St. Charles County. A lot of our transfers, as you see, if noticed, I'm sure, nicardipine trips. It's very common. It does really good. Contraindications, aortic stenosis. Onset, it works pretty fast, 5 minutes. And it's a calcium channel blocker, right? Nicardipine, remember? So what's it do? It affects calcium channels. It doesn't have a receptor that it goes to. It works with the calcium channels that are present on the heart, right? Or on the blood vessels, And so it affects the smooth muscles by causing smooth muscle relaxation, which means the SVR goes up or down? Down. So it reduces SVR, decreasing blood pressure, right? By smooth muscle relaxation. Obviously, it affects the arteries more than veins, but it affects both. Oh, that's pretty obvious. Now, wait a minute, we're still in the side of, okay, that should say nicardipine, my bad. Okay, so, hey, out here it's given two different ways. Depends on the hospital system you're in. The SSM hospitals, West and Health Center, do the mics per kilogram per minute. The Barnes St. Peter's and the Progress West do the milligrams a minute. So you need to be very familiar with both those ranges because you will be titrating nicardipine on a critical care transfer. It is the #1 most titratable medication in critical care, nicardipine. So if they're on the mics milligrams per hour, it's 5 to 15 milligrams per hour. If you're on the mics per kilogram per minute, it's 0.45 to 4. And if I'm on the top one, I'm going to go up by 2.5 milligrams each time. If I'm on the bottom one, I'm going to go up by 0.5 micrograms each time on the pump. Okay? And you know you can just put the dose in the pump, and it'll figure out your drip rate for you. Right? So we're just titrating up by 2.5 or 0.5 until we get a blood pressure less than what? Does anybody know?
160?
Even less than that. It's like 140, 120 sometimes. Even sometimes they want it under 100 or right around 100 systolic. So it depends on if they're dissecting versus aneurysm. It depends on what's going on. Sometimes you get that blood pressure as low as you can go. Maintaining a good map, of course, but as low as you can go. So it is a calcium channel blocker, like I said. Can't think of anything else I need to talk about nicardipine. Okay, how do we mix it? So nicardipine does not come pre-mixed in critical care. In the critical care out here, we carry the vials. So we'd have to mix it ourselves if we don't get it from the ER. It comes in at 25 milligrams. I'm sorry, it comes in a, nicardipine comes in at 25 milligrams and 10 cc's, I want to say. So you put 25 milligrams in a 250, comes 25 milligrams and 10 cc's, put a 25 milligram in 250. That gives you concentration 10 mics per cc. Sometimes you'll see it mix a little higher. 50 milligrams in a 250 gives you a higher concentration, and then, of course, you're running out those doses. Oh, that reminds me. Going back to norepinephrine, there's a dosing of norepinephrine that I can't remember the name of, where they put 16 mics in a 250. That's how many times more than it should be? 4. That does what to the concentration?
16 milligrams?
16 milligrams instead of 4. Quadruple is the concentration of it, yep. Norepinephrine. I forgot to mention that norep because it wasn't on my notes, but I just remembered it. I can't remember what it's called. With Dr. Chan is here, we could ask him. I can't remember what they call it, but they actually quadruple the dose of the concentration. Now, they run it at a slower rate, but they do that if they really need to get the alpha support. I've transported a patient one time on that. So be careful. So when you get on scene of a transfer, you've got a norepinephrine drip, make sure the concentration you're aware of. Is it the 4 milligrams or the 16 milligram dose that they're using? And the drip rate will be different for the 16. I can't remember what it runs. I'll have to look that up for you guys. But I want to mention that because I forgot to mention that before. All right. So let's summarize. We're done. So when we get to shock, we're going to talk about this in more detail. But what? Hey, your first line is always what? Norepi. You're okay. After that, we're going to put an epi infusion on. Once we get to that point where we got both agonists going on the alpha and the beta, and we're not getting anywhere, we need to think about receptor fatigue, right? So let's go to vasopressin next. That's your third line, or your second line, but definitely by your third. Consider angiotensin 2 for severe refractory shock because it works on those AT receptors, and they're going to plummet. They're going to get that blood pressure going up real high. Add phenylephrine at any time as an immediate rescue drug. You can give that any time. As an infusion, it's hung at the very end, but you can give those push doses anytime to rescue your blood pressure, especially for tachycardic shock because it has no beta activity, right? Phenylephrine? Well, we have them on critical care. It'd be nice if we got them on front line.
Yeah, you're right, intubating somebody and giving them Versed.
Bottoms in. Yeah. Dude, I got to tell you guys, giving Versed IV, Versed is a very potent drug when given IV. If you haven't discovered that yet, you will. Be careful. Be careful, especially when you got an intubated patient. The last thing you want is to drop their blood pressure. So I used to give all my transfers intubated 2.5 of Versed and 50 of fentanyl if they were just on propofol, which 99% of them are, right? And we'll talk about propofol later in the course. And it would drop their freaking blood pressure. I'm like, damn it. And so I have to transfer. I'm rescuing the blood pressure that I dropped. So I learned the hard way to not do that anymore. So take my advice. Just be careful. Add to butamine if you need inotropic support, if you have a patient low EF for cardiogenic shocks. And only consider dopamine or isoprol for bradycardic shocks only. And that's the summary of the day. Any questions? There's a lot there. A lot there. Now,
That's it, huh?
no, that's nowhere near it. Now we're going to, as the course goes along, we're going to teach you guys how to use them in what shock states as we talk about shock. And when we get to hemodynamics, we're going to talk a little bit more about the mechanisms as well. But that was just a brief overview on those 13 drugs. So now that you've got this overview, I want you to start studying them. Next week when you come in, you're going to have a quiz as soon as you walk through that door. And a lot of that quiz is going to be on my lecture and some of Dr. Tan's lecture this morning. So know that formula. Know as much as those drugs as you can. And you do great on the quiz.
Not that we shouldn't study some drugs, but are there certain ones that we should study more, like that are?
I would study the first 4 drugs for sure. And that just makes sense. Get those epis down, the norepinephrine's down, the dopamines, and the, what was the other one? Isopropyl. So no epi, no norepi, no phenylephrine. Let's just go there, for sure. Know those 3. Because those are the most common vasoactive drugs used in critical care, transport, and phenylephrine. Nicardipine, we'll talk more about nicardipine when it comes to head injuries and head things. We'll delve deep into that then. But still study all the drugs. That's why we did this in week 1 to give you 22 weeks to get these drugs mastered, okay? So I will test you throughout the course on the drugs. I'm letting you know. But for the next week's quiz, please know those. You guys won the competition, so you guys get 1 extra percentage point on your next exam. Congratulations. Also, well, Dr. Tan didn't cover labs. He won't do it till week 3, so I'll hold off. This is more extra credit. It's a lab worksheet, but he didn't cover labs, so I won't hand that out today. That'll be another point for your test. So as we go through the course, I'll give you opportunities to make more extra credit. This is how. I usually hand out candy too, but I didn't have any candy today to hand out. I hand out a lot of candy throughout the course. If you ask anybody who's attended before, I hand out a lot of M&Ms.
Brandon's
So.
office, you guys, just steal like candy from Brandon's office.
Is there candy in Brandon's office? Never seen it.
That is desk, the back wall, I think it's the top drawer.
Okay. All right.
Every time I was in there, he just pulled candy out of his desk.
All right, here's your homework. So review chapters 1, 2, 3, 9, and 20. Make sure you read chapters 5 and 8. If you read a dose different than what I told you, then go with what I told you. And then also, more importantly, this is how to prepare for next week. Read chapters 4 and those specific pages, 6, 9, and 17. Because next week we're going to get into, I don't know, what are we getting into? Is it respiratory? It's respiratory, it's respiratory, VQ shunting, oxygen dissociation curve, fun stuff. It's going to be good. And then ABGs too.
Can I go back to the last one?
Oh, it's on the slides. It's on your paper. It's on your paper. Yeah. And then here's our contact information if you don't already have it. Don't leave yet. Don't pack up. We're not going anywhere yet. I'm just finishing out the slides. So on your slides have our contact information, okay? And then here's what Dr. Tan told you about earlier, if you want to go to the lab. Now, we're having our own. Oh, no, that's cadaver. The one we're doing for class is a pig lab. So this is separate from the pig lab. So if you want to go. Let me get my laptop. We're going to play a game, and then we'll go.